and extending up to your cyst. These are the normal variants where you can see in a anterior horn of lateral meniscus, you can see a linear density which is almost transverse. As we go on from the midline up to your laterally, you will see a two distinct structures. That is your transverse intermeniscal ligament, which is attaching up to your anterior horn. The second variant would be your posterior horn of lateral meniscus, which mimics the vertical longitudinal tear, where a linear high intensity signal can be seen extending from your superior to your inferior edge. That is your ligament of Humphrey. Coming to the classification of tear, where horizontal, vertical, discord, which will all be discussed, where vertical is again further divided into longitudinal, radial, oblique. Longitudinal is further divided into your ramp, bucket handle, and radial is divided root, and oblique is peak, and all combination of this is your complex tears. Coming to the horizontal tear, where the tear is perpendicular. If you see, the tear is parallel to your tibial plateau, and it is mostly seen in as age prevalence increases, and it divides. You can see this here. The high intensity signal extends from your periphery up to the free edge or into your articular surface, where it divides your meniscus into your superior leaflet and your inferior leaflet. So sometimes the inferior leaflet might go into the gutter, which gives you which patient complains of the pain clicking sensation when it's from flexion to extension. That is when you have your inferior leaflet extending into your gutter, and if you're not suspecting this, you might miss during the arthroscope. And this tears are most commonly will have your cyst, parameniscal cyst, which is globular or lobulated in shape. Here in this, you can appreciate some cartilage. There are grade 2 cartilage changes, degenerative changes, and this is a superior leaflet and this is your inferior leaflet. Once you do the pie crusting, you can see it clearly, and at last you can see some amount of fluid which is gushing out. So this is another case where similar, we can see here near the posterior horn extending up to the root, where you see your superior leaflet and your inferior leaflet. Vertical longitudinal tear here, the tear is perpendicular to your tibial plateau and parallel to the long axis of your meniscus. Yeah, here posterior most commonly seen in the posterior horn of medial meniscus, where you can see high signal intensity at the periphery, and most commonly it is your full thickness tear of your meniscus. And sagittal, you can see the high intensity signal at the periphery, where extending from the superior to your inferior meniscal surface. An arthroscopic view, here the medial meniscus, once you do the pie crusting, you can see clearly where you have full thickness tear of your portion of medial meniscus extending almost from superior to the inferior. And probing is very important. If you don't do if you're suspecting a meniscus tear on the medial side and you're not doing pie crusting, you won't see the full extent of the meniscal tears. Coming to the radial tear, where the tear is perpendicular to your tibial plateau and the long axis of the meniscus, and it extends either from the capsule meniscus up to the free edge, or from the free edge to the capsule meniscus. As you take the slice from the normal edge up to the tear, you can see from the wedge it leads on to the truncation of the meniscus. Here in the coronal, you can see a cleft seen in posterior horn, and in a sag you can see your truncations. This radial tears can be missed if your slices are not thin enough. I'll take another 2 minutes. Here you can, in axial, you can see your clear cleft and extending full thickness. This is your lateral meniscus, where extending from your it's almost at the junction of the body and the posterior horn, where extending up to your capsular meniscus. Come to the parrot beak, which is oblique tear. When you start your slices from the free edge of the tear, as we go, you can see the truncation. But as we go on towards the tear, you can see your marching cleft sign. You can see Matic left side here, where you can see both the ends of the in posterior horn, you can see both the ends of the meniscus, but you have a linear high intense signal crossing vertically. And axial, you can see a oblique tear. Before we do the pie crushing, we can see that we can see only your radial tear. But as we do the pie crushing slowly, you can see the tear extending obliquely. The root tear. Root tear is a type of radial tear which is within 1 centimeter of a root attachment. Always, it is most commonly seen in lateral root with respect to your associated ACL, but degenerative is usually seen in your medial meniscus. But this is a case of traumatic, where you can see where you can see in a coronal, you can see the extrusion of medial meniscus more than 7 mm. And in coronal, you can see a radial vertical high intensity signal with a truncation sign. And in a SAG, you can see your ghost sign. This is a case of medial meniscus root tear along with your MCL tear. This is a lateral meniscus root. It's a other case. A displaced bucket handle tear. It's a type when a vertical longitudinal tear extends from your anterior to your posterior horn. This displaces this is a truncation sign. This displaces your meniscus into your intercondylar notch, and here you can see your double PCL sign. Sometimes you can see a small disproportionate posterior horn of meniscus. You can see the meniscus in the intercondylar notch. Coming to the ramp, which can be easily missed as the sensitivity is very less because the MRIs are taken only the supine. So most of the time the ramp sits back. So here high suspicion has to be seen where if a patient has a pivots or a bone bruise, you can't see in this. But if you have a bone bruise pivots, posterior meniscal, posterior tibial bone bruise is seen, and if you have a linear fluid or a high density signal seen from superior to your inferior, and a fluid is seen. Here you can see fluid. So always you need to go and see for the ramp, ACL patients. Discoid meniscus. This is a variant where you can't rely on the you can't rely on the meniscal signals, but you need to rely on your morphology. Where because of the high vascularity, you can't see your intermeniscal signal. The sensitivity is very less. So in this case, you need to compare the meniscus with the other meniscus, most commonly seen in the lateral meniscus, where thickness of the meniscus is more than the other side of the meniscus, and the meniscus is extending up to your intercondylar notch, where the transverse diameter is more than 13 mm. This is almost a complete meniscus or a discoid meniscus. Thank you.
Thank you, Sumant. Now, I request Dr. PC Jagdish to deliver his talk. Request all the speakers to kindly stick on to the time, the tight agenda.
Good morning, everybody. So congratulations, Dr. Sharad, for organizing a very nice UCME. The first one. So yep. Yeah, so the repair of the medial meniscus tear is the one for the bucket handle tear. So we know that, how it's important is to restore the medial meniscus in avoiding the contact stress and low transmissions. And it just has stabilizes to keep it the knee instability. So in 1982, in the early stages itself only, they have notice that, how if you just do the meniscectomy, there is chances of getting laxity of the knee, though you do a ACL reconstruction. Then why we do the meniscus the excisions? It has been reported in the US. You say that 9:1. They used to do the meniscectomy versus the repair. And earlier they were thinking that the repairs were not so easy, and getting it, it's not easy to the healing also will be difficult. In early days, in 2001, the Moon cohort study, they showed that the 31% of medial repairs the heal, that is repaired, and versus 53% was resected. Still, repairs are less compared to the meniscectomy. So as we go right now in the state now in the 2000, see the journals 2023 and 21 and all, there are a lot of reports are saying that the repairs are very much healing potential than this meniscectomy. And there were a lot of skeptical about whether what sort of equipment we should use. It was the costliest and sufficient skills do we need it to get into it, and competitive. And that is how it extends in the beginning. If you do not get into this, the meniscus, so completely it goes into coming to the notch. And that is how we see in an MRI, that's double PCL sign and shows that bacterial tail is there. And you see that the world gives a little tips of how the repair has to be there. Carefully, just to have the portals is very important, especially when you are doing it in the first time. And then if you need it, you can use an accessory portals. The lateral allotted portals cannulas you can use to reduce that cartilage damage, which is important because sometimes when there is a knee is very tight, you might not be able to reach to the posterior part of a medial meniscus. So might need a little bit of medial pie crusting. So once if you have to stabilize the medial meniscus, the fragment to the capsule, and you can put a stable one stitch to the attachment to the capsule. It can be the inside out repair type of technique. And then you can stick on to the whether it is all inside technique or to the inside out technique, and it's your easiest one. So one of the technique which I'm showing over here is how the flip meniscus is there here, and you have to reduce it first one. And when you reduce it, you can see that how it goes inside. And when you're reducing it, you can feel the meniscus structure. It is sometimes, if it is very hard, it might be a chronic one. If it is very slips, goes inside, it's an acute one. So you have got an ease of repairing it with an inside out technique. Here, I am just showing it how the inside out technique only we are doing it. To reach the inside, that is the every specific the zones you have got a cannulas where you can reduce the cost. Sometimes you might be feeling that the repairing might really be very costly here. So always there is a cannulas available here. You can reach out even the posterior. Only the direction has to be changed away from the midline. So when you get into it, you can repair see very perfectly the meniscus. Another one which I'm showing you is the outside in technique here. Yeah, you can see this is a very simple novel technique where you don't need any extra needles also. You can just use the simple spinal needle attached with that from the outside in. But only thing is you need to identify where you are getting into it. So before getting it, because too much of puncturing can also damage the medial collateral ligament. So be precise in where you're putting into it, gentle, and get into the part where you're repairing it about it. So once if you're done with the inside part, the outside towards the periphery, you can come down using the Prolene, and then tunneling with the suture which you are going to do. So on that is how stabilized. So they have success of this medial, that is neglected medial bacterial tears is 70 to 80%. So it means that we have still enough time to repair any of the medial meniscus rather than excising it out. And what is the failure rate? You can see that failure rate is 29.3%. That is still, if you compare to the success rate and the healing and the failure rate, we have enough chances of time to take the time to repair the medial meniscus. And there are a lot of things that are, as I said, all inside, you can do it, compare if you have got enough, the time cost. And inside out technique is still a golden standard compared to the all other techniques. And when you have got a constraint with this, you can combine with the hybrid technique as well as with the other techniques, all inside technique. So how many the sutures we may have to use it. This says that at least a 2 to 5 millimeter of an interval should be used when you're repairing from the medial meniscus from the posterior horn to the anterior horn. And there is Sentinka et al. It was in 2021. We have showed that out of 26 patients, after 6 months follow-up, the clinical healing rate. That is, what is clinical healing rate? Just many people will be difficult about it. When you do the squatting, the patient does not have any pain. That means that the healing is very much potentially nice. So that healing rate is 77%. And radiologically, it's seen that 80% of the meniscus has been healed. That is, you will not show the meniscus, that is MRI immediately at 6 months. You should do the meniscus MRI, the new MRI post at least 1 to 1.5 years post surgery. That shows that, the 80% of the meniscus has been getting. So what are the factors which we have to use it? Because when you're doing it alone, the medial meniscus alone, you need to add some factors to hasten the healing about. So you can use a trephine, you can do an hyaluron injections about it, you can do the bone marrow aspirates, you can do marrow stimulation, that is especially in the intercondylar area, and sometimes we can give the fibrin clot also and platelet-rich plasma. So all these factors definitely hastens your medial meniscus repair. So what is take-home message which I'm going to give it? It is restore the biomechanics rather than exercising it about it. And you got it all inside or inside out technique which you can use it. But when you're constrained, you can seek whichever technique which you're going to use inside out technique. And healing factors has a very good role when you're repairing the biomedical medial meniscus tear, and success rate is at 70 to 80%. At the outset, I would like to invite you all for the ISCON 2024, which is happening first time in Bangalore. That is in 12th to 14th September. Many international faculties have agreed already. That is to be on the give a feast for you. So here is one of the Professor Ranbir Singh from Thailand, from New Zealand, Daniel Moya. He has got so much of this knowledge about it we can share within our faculties, and Nick Van Dong for the ankle. So we have got for the hip, wrist, everything we are including it. I'm not going to do through detail about it. And one more, we have got is Sang Din Jin. So he is a very good health as well as the shoulder and the knee surgeon. So I would like to invite you everybody to register very early so that you can save much money from your side. Thank you very much.
Thank you, Dr. Jagdish. Do you have any questions for him? All right. So we move on to the next one. We have Dr. Mohan Kumar speaking on horizontal tear repair techniques.
Good morning, all. At the outset, I'd like to thank and congratulate Dr. Sharath for this wonderful academic event. All the best, and hope it continues every year. So good morning, all again. My talk is on horizontal tears of the meniscus. So as by definition, it's a tear extending from the apex of the meniscus going on to the periphery, parallel to the tibial surface. But it does not always follow this definition. There may be some oblique tears also. So these constitute about 32% of all meniscal tears. Initially, it was thought that because the circumferential fibers are intact in a horizontal tear, a leaflet resection, either the superior or inferior, was the treatment of choice, and it was done routinely. But there have been a lot of biomechanical studies which has shown that even a single leaflet resection leads to increase in contact pressure and peak pressure over the cartilage surfaces. This study concluded that a single leaflet resection is as good as the double leaflet resection itself. MRI, of course, is a classical where you can see the horizontal tear. The important thing here is to identify extension onto the articular surface. Many a times, the presenting symptoms with which patients come with for a horizontal tear is a cyst, a parameniscal cyst, which is either on the medial or lateral side. That will be the presenting complaints for a horizontal tear. And many studies have shown that 96% of parameniscal cyst in a medial meniscus is always associated with a tear, and about 98% in case of a lateral meniscus. Now, once the failed conservative method surgery is decided and indicated, obviously you'll have to look into the other aspects like the instability, the alignment. Those issues has to be kept in mind. And once it has decided about the surgery for the horizontal tear, the principles have to be adhered. The principle is same as for any other meniscal repair. A proper anatomic reduction. Biologic stimulation is very important in a meniscus repair, because as we know that the inner aspects are all mostly avascular. So to stimulate the healing or increase the healing rate, some kind of a biologic stimulation. And in the horizontal tear, the more important thing is a circumferential compression stitch to get that compression between the two leaflets, superior and inferior leaflets. Now, techniques, all the techniques can be utilized all inside out, and outside in, depending upon which part of the meniscus you are repairing. So the posterior horn and up to the body, all inside or inside out can be done. Whereas if the horizontal tear is extending more into the anterior half, then an outside in technique can be very useful. Now, the first step in repair of a horizontal tear is identifying the pattern. Most of the time, you'll see that the horizontal tear is not a classical horizontal tear. You always have some component of a flap tear or a complex kind of a scenario. So once we identify the tear, it's important to clear off these friable tissues and make a stable part of the meniscus for further repair. Now, if it is difficult to access this area, sometimes you may have to do a pie crusting to have enough space so that you don't damage the cartilage. You can use a shaver and meniscal punch to debride these tissues. And once you're done with that, so you'll be able to identify the tear pattern having the horizontal cleavage tear or the fish mouth appearance with the superior leaflet and the inferior leaflet. Now, the stimulation part, again, various methods are there. So one of them is, of course, using a typical diamond rasp to rasp the area so that expect some bleeding to happen from the capsular side. The other few modalities are maybe you can use a needle to define the capsule on the superior, on the inferior leaflet area. The other method is, of course, doing a marrow vent with the contral pick in the anterior part, in the intercondylar area, anterior to the ACL. Some surgeons also prefer to inject maybe PRP or even some kind of growth factor into this defect before you do the repair also. Now, coming to the repair part, all inside, again, we have got two varieties of which can be repaired. One is, of course, using the self-retrieving device, something like a knee scorpion, where you take bite towards the capsule and then tie the knots intra-articularly. So basically take deep bites into the near the capsular portion of the meniscus tear, including both the leaflets, and then tie the knots so that the compression happens between them. So this can be progressed from the posterior horn area up to the body. And once we reach more anteriorly, maybe you can shift portals and the instrument go into the other portal and scope and vice versa, so that you can access up to the anterior part. But if it extends too anteriorly, then maybe we may have to add hybrid techniques like using a outside-in technique to suture those areas also. The number of stitches, it's about 3 to 4 millimeters gap, or the ideal way is maybe you can use a probe so that the probe does not enter between two stitches. So that's where you achieve that, and that's at the end of the repair of a horizontal repair. This is another method where this was a complex tear. After the edges were debrided, the horizontal component was sutured using a all-inside device. So where you take one of the anchors is passed up in the superior leaflet, and the second one is passed in the lower leaflet. And once you tension it, you see that it compresses and closes the fish mouth. And of course, as you come more anteriorly, you can use either the inside out or outside in techniques to close the fish mouth. So this is a relook arthroscopy where you can see that the sutures are all well synovalized, and you can see that if the repair was more rounded, here you can see a nice apex of formation happening, showing good healing of the horizontal tear. So literature, lot of literature saying that horizontal repairs are as good as any other repairs, up to 78 to 80% healing rates seen. And biomechanical data also suggests that when a repair is done, the peak contact pressures are reduced as compared to a meniscectomy alone. Of course, this is again a study showing up to 77% success of repair. So the take-home message is horizontal cleavage tears are repairable. Proper indications have to be taken. Should adhere to the principles and technique. Any of the techniques is viable, but has to be done in a proper way. Thank you.
Any questions for Dr. Mohan? I just have a quick question, Dr. Mohan. Now, when you're doing a horizontal tear, all inside repair, you put a knot. Have you noticed in any of your patients that's caused some irritation or nothing? No, nothing to the articular surface.
Capsular area.
Okay.
So I find it because it's a 2 suture.
Yeah. Okay. Thank you. Can we have Dr. Shreyas Gajja to talk on ramp lesion types and techniques of repair?
Good morning, and thank you, Sharad, for the invitation, and congratulations on this maiden effort. I work in Kokilabhen Dhirubhai Ambani Hospital in Mumbai, and this talk is on the meniscal ramp lesion. So this is an injury which involves the meniscosynovial attachment or the meniscotibial ligament of the posterior horn of the medial meniscus. The term was first coined by Michael Strobel from Germany. What is important to understand is that it's an under-recognized entity because it is located in the blind spot of the posterior medial corner, so we are not able to identify it unless we look for it closely through the AM and the AL portals which are placed anteriorly. And what is the significance? It has been shown that if the ramp is neglected or untreated, there is a high risk of failure following ACL reconstruction, leading to increased anterior tibial translation and rotation issues. So therefore, it's very important to recognize this to try and rectify the sagittal and the rotatory laxity, thereby reducing the risk of ACL graft failure. The prevalence, as we understand it better and we look for it, we have noted that the prevalence could be as high as 40%. Clinically, the patient would present with some sort of a valgus internal rotation and axial loading mechanism. Tenderness would be on the posterior medial joint line. The standard meniscal test may be positive. What is important and one of the key features is that there would be a high-grade pivot. So we need to suspect a ramp in that situation. However, the sensitivity and the specificity of the above tests need to be evaluated. As far as MRI goes, it was very beautifully highlighted in the first talk that what you see key features is the posterior medial bruise and also a high signal intensity. So if you see the posterior medial corner, this is what an intact ramp area would look like vis-a-vis the arthroscopy image on the right, which shows a meniscocapsular separation. So we need to pass the scope in the Gilchrist, using the Gilchrist maneuver and look for it, probe it to make sure that we are not missing out on this problem. There is a dedicated classification which divides it into 5 types. There are 3 options for managing this entity. One is to leave alone, just do some sort of a stimulation without needing to repair it or to repair it. So what are the decision-making factors? It depends on the depth of the tear, whether it's partial or full, the extent of the ramp lesion, and the degree of instability on probing. So generally, the partial tears, which are type 1 and 2 as per that classification, are stable and can be left alone as they do not contribute to increase AM translation or rotation. And this is the evidence supporting that management, wherein stable lesions did not kind of lead to any subsequent deterioration of the joint or the ligament reconstruction. The second option is to just abrade it or refine it. The idea is to initiate a fibrovascular response. This is once again reserved for partial and stable tears to ensure that it subsequently heals up. And again, studies have shown that this method is equally effective, and you don't necessarily need to surgically repair the low grade or the stable lesions. So when it comes to repair, it is generally reserved for types 3 to 5, which are unstable, as you can see in these diagrammatic representations. And there are two main techniques. One is the inside out, using the instrument through the posterior medial portal, and the other is the all inside, which we are all familiar with. And the idea when you do the all inside is that you extend the knee as you pass the all inside sutures so that you can reduce the ramp. So this is a video highlighting the inside out repair. In the posterior medial corner, it's helpful to use a cannula to try and allow suture management. There are dedicated lassos, although you can use your shoulder 25-degree lasso, and you can pass it first through the capsular area and then go on to the posterior half of the meniscus, as seen here, using a low profile suture like a 0 or a 2-0 fiber wire in this situation. And again, you tie the knots on the capsular side, so they are not onto the articular cartilage. So the easy trick is to start from the midline and go towards the periphery, so you don't have an obstruction of vision. And what we are trying to ensure here, in the interest of time, I'm just going to fast forward it. This is what we want to ensure, that there is a nice watertight repair. The rehab is pretty much similar to a meniscal tear, depending on the extent of the ramp lesion, but sometimes you have to do either partial or non-weight bearing. And the return to full activities should be determined as per your ACL reconstruction protocol, because most of these ramps are seen in association with ACL or PCL tears. So again, repairing these ramps has shown very high level of benefit and evidence that it reduces the laxity and subsequent risk to failure. It also improves the functional scores. And this systematic review published a couple of years ago showed that really you can improve various return to activity scores by addressing the lamp in conjunction with the ligament reconstruction. So in summary, when dealing with ligament injuries or meniscal injuries, it's important to have a high index of suspicion, look for the hidden areas. Arthroscopic probing and visualization of the posterior medial compartment in modern day management is extremely important and necessary. The size, character, and the stability determines the treatment option for the ramp lesion. Stable lesions can be left alone. You need to repair the unstable lesions because they have a high risk of failure of your ligament reconstruction. And repair with either techniques, the inside out or the all inside, has shown good clinical outcomes. Thank you very much.
Thank you, Dr. Shreyas. Any question? Yep, we have one question.
Can you hear me? Yeah. So the Gilchrist maneuver is what we do for our PCLs. So you need to have a posterior medial portal. So when the arthroscope is in the anterolateral portal, you maneuver it through the inferior surface of the PCL or the medial femoral condyle to reach in that corner. So you can use a light source. You shut off your OT light so you can see illumination, and from an outside in needle you can do that. The Thalassie test is the squatting maneuver. So when you do that, if the posterior part of the meniscus gets trapped, and you can the patient's pain is kind of reproduced. So, but again, these are not very sensitive. It does not necessarily mean that this is indicative of a ramp lesion. It could just be a meniscal pathology or some sort of a posterior medial corner injury. So these tests are not very sensitive, but the Gilchrist maneuver is very important, and it is commonly used for ramp repairs and for our PCL reconstructions when we want to visualize from posteriorly to see our fixation on the tibial side of the PCL, whether it's an avulsion or a reconstruction. Yes.
You rest for 3 weeks. Any chance?
So the stable tears have been shown to self-heal. That is why that study showed that there was no difference whether we repaired it or not. But most of these are in conjunction with ligament reconstruction. So if we are believers of an acute repair or a an acute reconstruction, then we deal with the ramp right away. Or if we are proponents of a delayed reconstruction, you want the swelling, pain, range of motion to recover in a month's time, it is good enough. But what is important to understand from this talk is you look for these. Don't miss out, because otherwise one of the reasons of failure of our ligament reconstruction.
The needle behind and lift the capsule.
So the posterior medial portal or the Gilchrist maneuver, the posterior medial portal is only taken if I visualize a ramp. But again, one should not hesitate to do so if required, to ensure that any kind of minor suspicion is ruled out. The Gilchrist maneuver is done almost every time, because as I showed you in that video of a normal ramp, that you have to go in that corner, which we never used to routinely do. So that is important, so you don't miss out. And you can use the probe through the anteromedial portal, like how we do for our root evaluation, and you can just check and probe, because unless you probe, there could be a capsular which could be overshadowing the tear, and you may miss it. Thank you.
All right. Thank you, Dr. Shreyas. Now I invite Dr. Sunny Gugale to deliver his talk on radial tear of medial meniscus, different techniques of repair.
Hello. Yeah, good morning all. Good morning, chairpersons. I am Dr. Sunny Gugale from Sancheti Hospital, Pune, to give my talk on the radial tear of the meniscus. So a lot of enlight has been going on to the morphology. So today I'm here to focus more on the radial tears. The commonest tear of these, commonest location for these tears is near the lateral meniscus, near the posterior root, which is commonly associated with the ACL injuries, as well as it is commonly seen with seen in the meniscus body, where the body and the posterior horn junction is there. So we have to identify these tears on the thorough diagnostic round. Before that, as it was highlighted in the morning talk, MRI, the sagittal images as well as the axial images through the meniscus does reveal these meniscus tears, and you have to watch for them. Usually they are not hidden because they are pretty obvious. The meniscus is going to be unstable. And once you have made a mind, seen these tears on the MRI, we proceed on to have a diagnostic arthroscopic evaluation. So probing these tears is very important. At the times when you're encountering them late at 3 to 6 weeks, you can find a partial healing in these tears. But thorough probing will show that the depth of the tear, it is extending from the white zone to the red zone. And you can see that you should also look for the meniscocapsular separation of the anterior or the posterior leaf of these type of tears. So it is very important to repair these type of tears, because excising them will lead to as good as a subtotal meniscectomy. Repairing these tears is important. And along with the suture biomechanics, providing a good biological healing potential is very important when you do with this type of tears. So there have been a lot of studies published in literatures, like we have seen in the past also, excising these meniscus. But there has been a more proposition for a radial tear or extrusion of the meniscus developing a higher risk of having knee osteoarthritis. So methods to repair this type of tears is an all inside meniscus repair devices can be used. We can also use a side-to-side stitch with the knee scorpion. We can also use inside out repairs at the body and the anterior junctions. Just one case example that I want to present. This is a 32-year gentleman with a 2 months history of trauma to the knee joint with pain and instability. Examination reveals Lachman's and Brower's test being positive. There is a McMurray's test which is positive and is often clicking in the joint which the patient complains of. The MRI reveals that there is a posterior horn. We have seen in details about the MRI assessment, but you can see a long oblique tear like this on the MRI, showing a tear at the posterior horn and the root junction. On a diagnostic arthroscopy, these tears would look like this. It is pretty obvious and straightforward that we can identify these type of tears. There may be associated secondary tears into the meniscus. Usually in the white zone, we end up excising them. But if a tear is extending right from the white zone to the red zone, it definitely needs a repair. Stimulation of the biology is very important. So we do abrasion with a diamond rasp, as well as an arthroscopic shaver can be used, which will debride the meniscus and the loose fragments. So in my setup, I usually do the ACL tunnels first and then go on to do these repairs to avoid manuring the knee joint during your tunnels. So I'm preferring here to do an all inside repair technique. So at the body and the near the body and the posterior horn junction, near the root junction, having a good bite into the meniscus is very important. Usually go 3 to 4 millimeters away from the tear margin in order to avoid cutout of the stitches. I had my equal share of cutouts of these type of techniques in the beginning phases, but gradually as you advance, you know how to take the stitch. A good bite in both the areas is very important. The penetration should be as posterior as possible to the meniscocapsular junction. I'm not worried about the further leftover tissue because after the approximation, you'll see a nice contact between both the leaflets. Advantage of all inside devices is near the posterior horn and the root junction. At the body junction, you can use the inside out devices as well as the knee scorpion. I don't cut my stitch right away. I leave some tensioning to be done later on. Usually a 2 parallel stitch technique, horizontal mattress would do here. The first is a reduction stitch and then a detensioning stitch a little away from the reduction stitch. Care has to be taken that you don't, when you're taking the stitches, you don't come in the same path as the previous stitch because you may at times cut through the previous stitch. Safe zones of the meniscus has to be kept into mind when you're doing this type of all inside devices. Lateral meniscus usually is pretty evident in a figure of 4 fashion, but the medial meniscus, as described in the previous talks, pie crusting is essential to see the entire depth. We may add on to a third crisscross stitch, which will start from the anterior edge to the posterior edge across the leaflets, or even 2 may do. We may add on one more third stitch, but I was happy with 2 of them. Knee scorpions makes your life easier at times where you want to reduce the cost of these all inside devices. This patient also had an ACL, so it went on to a hamstring ACL graft. Problem happens when you have a degenerated meniscus. So the meniscus, it's an old injury, neglected injury, and the meniscus shows signs of degeneration, as well as there is a significant parameniscal cyst formation. So this degenerated meniscus, there is an excellent technique which is described by Dr. Laprade, which shows that in addition to repairing this radial tears side to side, it is better that we anchor them to the tibial side with a transtibial tunnel technique, which will augment the biology also, as well as will stabilize the meniscus. So it has shown that the double cross vertical and the hybrid suturing techniques have shown to have better biomechanical stability. And the rebar repair has been introduced, which is very common now. To avoid to have a cutout, we use two vertical mattresses and then 2 horizontal mattresses to augment your repair. The superclot is essential, as we spoke about that stimulating biology. We can either do a superclot or we can use a microfracture in the notch, which will stimulate the healing of the meniscus. So the take-home message here is the radial tear repairs are a must, as excising it will lead to as good as a total meniscectomy. The double cross as well as the hybrid techniques lead to a better outcome. Does not matter what device you have, all inside, inside out, knee scorpion, or an outside in, best approximation is the aim. And augmented repairs are essential in isolated tears. I thank Dr. Sharath for having me over here. Thank you all. This is a good meeting that we should have a focused discussion on single parts of the knee arthroscopy so that we have initiate more detailed discussions. Thank you.
Thanks a lot, Dr. Sunny. Time for one question. All right, we move on then. I request Dr. Yashwant Kumar to please deliver his talk on reattachment of root of medial meniscus.
Morning, everyone. I would like to start my talk by thanking Dr. Sharath for this opportunity. So I'll be discussing on meniscal root test, focusing more on medial meniscal root repair. So we all know when we started our arthroscopy as beginners, at least in my first 4 to 5 years, I never repaired a meniscal root. So my focus was only on the ligament reconstruction. But later I understood the importance of the root tear. The incidence is also very much this thing. Almost 9.1% of all patients who undergone knee arthroscopy had a meniscal root tear. So by definition, it's a bony or soft tissue root avulsion within the 1 centimeter of the root attachment, either anteriorly or posteriorly on either side. So around these account for around 10 to 21% of all meniscal tears, which is a very significant numbers. So anti-horn tears compared to the posterior ones are not clinically significant. So the Choi et al. Has done a study on all the around 140 patients who has undergone the total knee replacement in less than 60 years of age, and they found 78% of all these patients had root tears. So the number is very significant. So root tears common in both acute and chronic settings. The degenerative tears are more common in the medial meniscus posterior root, whereas the acute tears, which are associated with the lateral meniscal posterior root tears, usually following a significant trauma. So the degenerative tears, which are more common, usually result from an acute trauma, usually resulting from hyperflexion or squatting injuries. So the medial meniscus, unlike lateral meniscus, is less mobile, and there is highest load transmission compared to the lateral, and hence the degenerative tears are more common on posterior root. So the meniscal root tears, they are important because they profoundly affect the dynamics of the knee biomechanics, because unrepaired root tear is almost equivalent to a subtotal meniscectomy. The forces which are there, so the compressive forces are transmitted into hoof stresses. This the mechanism is lost in case of a root tear. Unless we don't repair them, then invariably it leads to early degeneration of the knee. So earlier, the root anatomy was described with respect to the attachment of the ligaments, the ACL and PCL. Now we have various the cadaveric studies, which in turn identify the exact location of the each root: medial meniscus posterior root, anterior, lateral meniscus posterior, and anterior roots. Robert the Laprada in his the paper on current concepts on treatment of meniscal root tears as describe the anatomical location of each root. So the patients at high risk to develop these root tears are patients with varus alignment, old age, high BMI patients, and female sex, and patient with sedentary lifestyle. Of course, spontaneous osteonecrosis of knee, either it is associated or sometimes it is the result of the existing root tear. So clinical features, as I said earlier, the classical clinical features and examination findings are not there for a meniscal root tear. That's why we initially missed these root tests. So a history of trauma will be there in a lateral meniscus root tear. Usually it is associated with other ligaments, commonly the ACL injury. Whereas in a degenerative root tear, they rarely give an history. Sometimes a small pop in the knee while getting from the chair or during deflection. You will have a joint line tenderness. Sometimes they can present with mechanical symptoms like catching, locking, and instability. McMurray's test may be positive, joint line tenderness, and sometimes you can even palpate the part of the meniscus anteromedially in varus position. So the diagnosis is a challenging one because there are no characteristic history pattern. There is no characteristic symptoms, and there is no the MRI specificity and sensitivity is also less compared to other diagnosing the existing other ligaments. If you take the sensitive specificity is only 73% and sensitivity is only 77%. So we can miss this root test if you don't focus on them both clinically and on an MRI scan, and you have to probe them specifically, especially the posterior part of the medial meniscus is very difficult to see and probe. You might do a pie crusting of the medial meniscus to open up the medial joint space. With respect to imaging, again, MRI is the investigation of choice. The sensitivity and specificity both are relatively poor. And there are some classical signs which are described for a root tear. So all the views, the sagittal view, the axial view, and the coronal view, you can identify the root tear. The sagittal view, you can see the anti-horn. There is absent posterior horn. We call this as ghost sign. Again, the signal changes are there on the posterior part of the root. There is a discontinuity and hypersensitivity signals you'll see. On the coronal section, close to the attachment, you'll see the hyperintense signals. We call it as a truncation sign. So again, this is same this thing where apart from the signal changes, you will also see the bony contusions in the medial and lateral condyles of the femur and tibia. Again, you can very well make out extrusion of the meniscus if it is more than 3 mm on a coronal view. Again, classically diagnostic of a root tear. Again, this the well-known classification. So type 1 is close the partial root tear. Type 2, the radial tear within 1 centimeter of this thing. Again, it is subdivided into 2A, 2B, 2C. Most of our repairs are in this type 2. This thing, again, if it is associated to the bucket handle, it is type 3. Again, oblique tear type 4 and avulsion is type 5. So rationale of treatment of these tears to restore the joint contact pressures and joint kinematics and prevent the development of early osteoarthritis. So again, various treatment options. Of course, the non-operative and partial meniscectomy are not very much this thing because they invariably lead to early development of arthritis. Again, if the patient is having a tear and a surgical candidate, not a surgical candidate, do a non-operative treatment. If the patient is a surgical candidate, there is no contraindication, then acute meniscal root repair. If it is chronic, if there is a pre-existing arthritis, grade 3, grade 4 Klagren, then just a partial meniscectomy. If there is no arthritis, then root repair. So if you see here, either you manage non-operatively or you do partial meniscectomy, invariably is going to develop osteoarthritis around 95%, 99%. And if you do meniscal root repair, 50% reduction of the progression into the arthritis. So you should note that partial meniscectomy is worse than non-operative treatment. If you have to do a partial meniscectomy, you think about it, because so again, this is a small video, but again, with I'll just I cannot fast forward it. So the basic steps of this thing is you first diagnose a root tear, probe it, then do a pie crusting of the medial meniscus, curate the cartilage close to the root, then take a bite through the posterior and reattach. Can I show the complete video, Sandesh? So the gold standard treatment for meniscal root tear is transtibial pull-out technique. Either you can use a single tunnel or two tunnel technique. So take the sutures through the posterior root and fix it to the anterior part of the tibia, cortical fixation, either using a button, or if you use two tunnel technique, you need not use. So fast forward. Okay. I think I cannot fast forward this video. I'll just skip the video. So transtibial pullout is a gold standard, either single or double tunnel. So the pie crusting is very important. Again, pie crusting, there is one article by Dr. Chichunjit Bancha from Thailand, where he has described the magical point on this TU line he calls the posterior tibial cortical line extending towards the adductor tubercle. 1.2 centimeter proximal to this joint line is the magical point. So rehabilitation, non-weight bearing is very important. 6 weeks, you have to consult the patient in advance that he has to not bear the weight for at least 6 weeks, and range of motion in first 2 weeks up to 90-degree, followed by further this thing. So after 6 weeks, he can progress to gradual weight bearing in another 2 to 3 weeks. Of course, there are some contraindications to root repair. All root tears will not go to repair if there is an advanced osteoarthritis grade 3 and 4. Again, chondromalacia grade 3 and 4, obesity, non-compliant patients, and poor surgical patients are contraindications. Again, to conclude, root tears, Robert Laprade calls them silent epidemic because of their the prevalence. Proper history and examination is very important, and MRI is the investigation of choice. Non-operative treatment and partial meniscectomy does not restore biomechanics and anatomic root repair. Excellent results. Thank you.
Thank you, Dr. Yashwant. The next speaker is Dr. Bhupesh Karthik on complex meniscus tear repair.
Thank you, Dr. Sharath, for the invitation. Fantastic meeting, seeing a full hall packed here. This talk will be on complex meniscal tears. I've tried to avoid tears which have been already shown. I'm going to show you a few scenarios and what we can do about them. So this is a lateral meniscal tear. You can see it actually doesn't fall into any pattern. There's a lot of slough. You know it is a chronic tear. And then as I probe, you see some mucus fluid coming out, which was a parameniscal cyst. There is a small flap there. This fellow is only 22 years old, maybe a discoid lateral meniscus which has gone bad. So you try to trim things and try to understand what type of tear it is. Now you see a cleavage. I like to use the small shaver. This is the small 2.9 shaver. I use it to debride and create biology there. Of course, you bring in your diamond rasp and create biology. Now you kind of have an understanding of the tear pattern. But when you went in, you didn't know what was happening. So debriding and reassessing again is very important. Now I take the bigger shaver and then just do the suction. Both the leaf, the anterior and posterior part of the meniscus started closing in. So which means it is unstable. Now that is my first reduction stitch starting somewhere in the body to keep things in place. This is an all inside device. You've seen few of this. But what is important is you keep a probe there and then make sure you don't over tighten. You gradually tighten that and try and maintain biology there and don't squeeze it too much. Don't try to compress it too much. Now I bring in my knee scorpion and I take a transverse mattress stitch. It's a horizontal mattress stitch. I take 2 of this and tie that down. Now I do a different trajectory, a far medial portal to bring in my all inside device. Inside out device. So you have to be versatile. You have to think of all the options. You have to have all your armamentarium in place so that you can do a good job. And then I go on and do a outside in for the anterior on. And this is a very simple thing. You can do it with your IV cannulas or just a 21 gauge needle. So 1 loop and a stitch, and then I reassess. I think there needs to be another horizontal mattress there so that the horizontal cleavage there sits well. Like Dr. Mohan said, every 3 millimeters to 5 millimeters, you need to have a compression for the healing to happen. That will give you excellent mechanical stability. So I go ahead and then do that again, this time with a different color. That is again another horizontal mattress, and then retrieve it and tie them down. So before you, and now as I'm doing it, you can see the popliteal fossa and the hiatus being recreated in normal tension. You know that things are falling back in the periphery in the right level because you need the peripheral end of the meniscus to sit well so that the hoop stresses are maintained and OA doesn't happen. And then I understand that there needs to be 1 more stitch anteriorly. So I bring in 1 more anterior on stitch. This is again an outside in maneuver. And tie it down. Now I bring after my repair, I bring the shaver now. And now you can see that the anterior and posterior parts of the meniscus don't close in when I put suction, which means the repair is stable. So from how it started, I've tried to give him a relatively nice looking meniscus only in the periphery, and we have avoided cartilage damage during the procedure. Of course, again, to increase biology, go over the top of ACL in the notch and do the microfracture so that good material coming to heal. So this is another case. Again, lateral meniscus. This is a young fellow. You can see the root looks okay, but there is a bump. Again, I bring in my mini shaver to go and debride the undersurface, because without creating biology, you can never repair because it is going to fail. So biology first, mechanical stability next. So bring in your knee scorpion, a mattress there. These are 2-0 or 0 fiber wires, so they really don't hurt the knee. And this is a 32-year-old man. So again, he's neglected it for a long time. And you can see the ACL is also absent, so he's going to undergo an ACL. So I'm a little bold in repairing this because it's going to heal. Now you see a flap there, and one part of the flap has to go. That part has to go because that is completely avascular zone. That is the white zone. So your repairs chronic repairs might always be a combination of meniscectomies and repair. So I bring in my shaver and then the diamond rasp. Now I try and reassess the reduction. You see, I think that reduction is going to be nice to give us a circumferential meniscus there. So don't start deploying anchors or your scorpions without understanding the reduction strategy. So plan your reduction strategy, protect that knot with another all inside device here. Taking care not to over tighten it. The popliteus hiatus tension is maintained. You always have to look for that. And because now I know I'm going to do an ACL for him, I know these things will heal because there is good material going to come from the ACL tunnels. Always they allow it to heal well. So that's how it finished. Now, last scenario. 1 more minute, I'll finish. So this is a 49-year-old man. I have done some pie crusting. You can see the medial side opening up. This is the medial meniscus. And you see a flap there. Oh, I'll still finish. You see there's a flap there. Now, reduction strategy. I want to see how it reduces. This might not be reducible. So what will be my strategy? You can be godly. Don't try to play God. This cannot be repaired. So I'm going to bring in a punch and do a very simple meniscectomy. Yes, and that solves everything. So thank you very much. And I invite you for the LSD course in January 19, 20, and 21 in Chennai. Please do come. Thank you again.
Thanks, Bhupesh. Any questions? Yeah.
Okay, that was a nice presentation. My name is Hemant here. In both the cases you showed, there was ACL injury was there, so it was easy for you to open the lateral compartment.
First case there was ACL. Second case there was injury. First there was no ACL. That's why I went above the ACL, cleared the notch, and did microfracture drilling. Okay. The first one. So the trick, you want to know how it opens.
Yes.
Whenever you know that you're going to do lateral meniscal work, I do most of my ACLs in hanging down. Especially if it is PCL, it is always hanging down because I want gravity assisted fall of the tibia and then the posterior compartment opens. If there is a ramp, always I like to put it like that. But if I'm doing a lot of lateral meniscal work, I do it in TKR position. So I can just take the knee and put it on the other side. No need of assistance. It will open up because the gravity is going to push it down. Worst case scenario, you ask somebody to give a little bit of push on the this one. And it was easy because the first one was a 22-year-old boy, the discoid meniscus. And the second one was 32.
So in case of a tight lateral compartment, we have tried, it's quite difficult to open, especially when the intact ACL in the body of the meniscus, we know to try to repair. So in that case, what is your tricks?
So
and how do you use another photo?
Yeah, usually this kind of sorts it out. But there is a trick. I have tried it only once. There is a publication last year. There is a lateral side LCL pie crusting technique. So you have to take it to the, trace the LCL from the fibula to the lateral epicondyle and do small pie crustings. Be very gentle. Don't use the big needle because LCL doesn't heal as good as the MCL. But there is a lateral opening pie crusting technique. You can look it up. It's in arthroscopy techniques.
One more last one. Do you tag it to the popliteus tendon in case of the repair is not amenable? Do you tag it to the popliteus?
There are studies which say it doesn't matter. You can put even anchors through it, but I don't do it. I'm a little scared. There are studies that say you can put anchors through the popliteal meniscus.
Yeah, Bhupesh. Yeah, Harish. Yeah, in case you have a lateral meniscus tear and then you have a lateral meniscus tear right at that junction of the popliteus tendon. You have a split tear, a radial tear through and through. You're not able to approximate the edges together. Then what?
If you are really not able to proximate together, you can do a transtibial technique. But I will reserve it for the last resort when I really cannot do anything, because you're going to bring down the mobility of the lateral meniscus. The mobility of the lateral meniscus is very important to prevent OA also. But something better than nothing. So if I really cannot do a rebar there, 2 transverse stitches and 2 vertical stitches. That is going to be my plan for that case. But if I cannot do that, in one of the cases, I have done a transtibial pull-out stitch. And this will not be a big tunnel with a 4.5. You can still do it with your bead pin size, the 2.7 bead pin. And through that, just bring 2 fiber wires, crisscross, and then pull it down. So that a lot of additions don't happen between that spot and the meniscus.
Now that takes up to his question. Would you also think about reattaching the both ends to the popliteus tendon?
I have never done that. And of course there are studies that you can do it, but I've never done that. I think somebody else from the house can answer that. I have never done that. Looks a little crude to put things into the popliteus tendon.
Thanks. Thanks, Bhupesh. Great talk. Next speaker is Dr. Naveen Kumar, who's speaking on improving techniques of healing.
First of all, thank you, Dr. Sharath, for this wonderful conference. We are amazed. Right. So my topic is regarding how we heal the meniscus. All my previous speakers have already dealt into that, so they have made my job much more easier. But just a couple of things to ponder here. So we all have situations where patients come back to us after 3 months, 6 months, 1 year down the line, getting MRI scan done somewhere. Okay, so I'm still having the problem, still having MRI showing ghastly things. Nothing has healed. What have you done, doctor? So this is a very common thing a lot of us face on a regular basis. We still brag about ourselves that we are getting good results. But in reality, what are our results like? So even the best of the results range from anything between 80 to 85%. For us, we are happy because we have moved from meniscectomy to now meniscal repair, and we are doing lots of things nowadays, putting all sorts of stitches all inside out. And we are happy that we are achieving these kind of results. But are the patients happy with that? Probably not, because if we say to the patients, in all honesty, that we are achieving 4 out of 5 healing and 1 may not, then a lot of them may not even agree for the surgery, to be honest. So what do we do about this? Is there anything we can do? So in terms of when we start thinking about this, if you really look at your previous how many years you have done these things for, your meniscal repairs, whom you have done as a standalone, they are a lot more likely to come back and pester you rather than where you have done the ACL and meniscus. That simple thing, which makes a big difference in understanding why our people whom we have done ACL plus meniscus heal better and not the meniscus standalone. This is where we all started from. At least people started thinking as to why is this? So then, is there anything which happens when we do the ACL reconstruction to the meniscus? Yes, there is, of course. And one more thing which we all came across is regarding the effect of smoking on the meniscus healing. There is another thing which has been shown in animal studies, that the menisci which have been repaired, they don't heal well, especially if nicotine comes into picture. So these points do towards something that there is something which we can add on to healing. And to be honest, we all know tendon to tendon healing is a lot more difficult compared to bone healing. We all know that. And now this is next level, where in addition to healing this kind of soft tissue, in the background of all the joint fluid and everything. So meniscus to meniscus healing is a next level of thing. I would consider this as one of the most challenging in the orthopedic field. So now, is there anything we can do about it? So there are a lot of new things which are being talked about and being used as well, although we lack consensus about how much they improve and how much they really make a big difference. But there are quite encouraging studies in this regard. We are thinking about stem cells. People have used bone marrow, adipose, synovium, blood, all of these things. So these have different chondrogenic and osteogenic capability. Do they have a meniscogenic capability? We don't know yet, because meniscus is not just a structure where we have got some linear things. There are radial fibers, there are circumferential fibers. It's an architectural marvel which we are trying to replicate. So these are the growth factors have been said to improve these things. So these are the new things which are coming into picture. So initially, we all thought that, okay, we will start doing something different or more than our just a repair, and started doing meniscal rasping, trephining, or even rasping the parameniscal synovia around that area, and microfracture to replicate something what we do for the tip, to replicate what we do in the ACL. So then came the second generation techniques like fibrin clot, PRP, bone marrow aspirate, and adipose tissue, and even MSCs, which is mesenchymal stem cells. So now meniscal rasping is one of the techniques which was used even before we did we started doing the repair. So just to small tears sort of did improve by some scar tissue. So that's why this is one of the things which was commonly used. Sorry, my video is not working. Excuse me for that. But yeah, a lot of you have done that, and it's a very simple technique, meniscal rasping, or even trephination of the meniscus, where it is just a puncturing of it with small needle, where that will initiate some amount of healing response. So these are the kind of things which have been tried, and microfracture is one of the common things which nowadays a lot of us do. One good thing about that is, yes, I mean, you don't need to get a separate thing done. You don't need a PRP or a stem cell arranged for. It is straightforward right there, and just go and do the marrow venting kind of technique, which can actually improve the healing process. This is one simple technique. I think we all should be at least including in all of our menisci if we don't do anything else, or if we have not prepared or kept anything else ready. So fibrin clot is one of the things which is commonly tried by quite a few people nowadays, but there are limitations to that, because we can't use it in a radial tear, and it involves a bit more of technical things, because we have to have the stitches on both the sides, and then without tying that, leave it loose, and then introduce the clot inside. But the biggest challenge here will be how to introduce the clot into that area, because the clot is a very fragile structure, and it will just get lost in your portal if you are not careful enough. So for that, there are a couple of things which we can do. One is you can use the passport cannula or the normal cannula, and that can actually help you in railroading that by using a PDS. So the PRP injection, there are studies which are giving conflicting opinion regarding that. The latest systematic analysis says that PRP is not something which has been changing. It's not a game changer. That's what they're saying. So that is one thing which, and again, PRP comes from different ways of preparation. So is it good enough or not? We are not still very clear about that. PMAC is a lot more promising in that order. If you look at really, it has got a lot of chondrogenic property, although it may not be meniscogenic as of now. But yeah, that is one thing which has proven that it has done. It can give a better result. But again, it involves harvest site. We have to harvest it. Adipose tissue, I have not personally used it, but this is one of the things which has been promoted as a good thing to try, because it's very easy to harvest that. So mesenchymal stem cells, yes, there are more and more new studies which are coming into picture now, but this is still in the research phase, and it is two-stage procedure. So that is something which is really wait and watch kind of thing. So hopefully we all can reach from where we can clinically improve the patients and make the MRIs look better and beautiful, so that nobody can question us. So this was touch based upon by my previous speakers regarding anatomical reduction, biological augmentation, and circumferential compression, guys. Thank you.
Thank you, Dr. Amin.
Thank you, sir. Good morning, ladies and gentlemen. As we draw to a close on this insightful session, I would like to express my gratitude to our esteemed speakers, panelists, and all of you for your active participation. With this, we'll move on to the next session of cadaveric demonstration, where we'll have two demonstrations from the Ramaya cadaveric lab. One is the demonstration on medial meniscus inside-out repair, with release incision with the repair of the capsule, repair to the capsule. The other one being the demonstration of repair of root of medial meniscus plus or minus centralization of medial meniscus.
Can you hear us?
Yes, sir.
For this, I would like to call Dr. Bhupesh Karthik and Dr. Rajiv Raman to chair the session.
Can you raise the volume of it? Can you raise the volume of it? We can't hear that much. Increase the volume.
Hello. Check.
Hello?
Yes, sir, we can hear you.
Can you hear us? Huh?
Yes, we can hear you.
So Rajiv,
Yes.
Bhupesh is there. Huh?
Yeah.
Hello, sir.
Both of us are here.
First of all, let me thank Sharath for giving this program for us. And we was asked to demonstrate about inside out meniscus repair. Are you able to see the
No,
external picture?
Right now we can't see the video picture.
External picture and
ABT?
arthroscopy picture.
No, none. No, neither external picture nor the arthroscopy picture.
Can you tell me once you are able to see it, I will demonstrate it.
Yes. In the meantime, you can tell us what is your plan. Yes, now we can see the inside picture and outside picture also.
Okay, fine.
Yeah.
So
perfect.
we have this patient who has a little arthritic knee. He got a varus deformity also. Yeah. So I put an anterolateral portal, anteromedial portal. And through the anterolateral portal, I put a camera in. And you're able to see the anterior part of the medial meniscus with some arthritis there. And some medial part of the meniscus is also seen. This is medial side, okay? Medial meniscus we are seeing. A lot of arthritic changes with loss of meniscal tissue. So we are going to demonstrate inside out meniscus repair in a medial meniscus. Okay, yeah. I feel this is a very good technique for a lot of bucket handle tear, especially for horizontal cleavage tear with parameniscal cyst. Very nice technique for that one. And it's cost effective also. Okay. Let me just show some instruments first, because one has to be familiar with instruments for doing inside out repair. Are you able to, can you focus camera here for me? Over here. So we have some instruments here. Are you able to see the instruments?
Yes.
So this is a zone specific navigator. And we have several types of needle available with curvatures on the tip.
Picture, big view. Outside picture, make it larger. Outside picture.
Outside picture, please.
Yes.
So can you see there is a little knob here?
Yes, now we can see.
With this knob, we can actually try to fix this needle in any angle that we want. As you can you see that?
Yes, sir. Yes, sir. Nice.
This actually shows that you can do access 360 degree. So whichever way you want, you can fix it. Okay. So this is for posterior horn and middle area of the meniscus. And there is one more which has got a very high angulation. This is especially for anterior horn. Anterior horn of either lateral meniscus or medial meniscus, you can use that. Okay. So this also can be turned 360 degree as you like and fix it. And then there is a small switch here. This will try to advance the needle as you like. Each time we are advancing 1 centimeter. Okay, 1 centimeter of needle will go in. Okay. So where is the needle? So the device is needles in that. It's a long needle, two long needle with fiber tape, small fiber tape attached to that. Can you see that? So hold this one.
Yes, sir.
So we can actually put this needle through this hole, and with this we can keep passing 1 centimeter, 1 centimeter, 1 centimeter, and it will come out here.
All right.
If you pull the whole needle out, the fiber tape will come out. Okay. After passing one, we'll have to pass another one like this. So we'll have a loop inside the joint, and externally we'll have to tie with a knot. So that is a principle. The same principle can be applied for.
Sir, sir, can when you're pushing the knob forward, the needle goes in. Can you reverse it also, sir? Pull it back.
You can reverse it. So so now I passed it in. I can also come back. It will go out. Can you see it is going back?
Yes, sir. Okay. Okay. Thank you, sir.
So if you have passed too far, then you can actually reverse it and bring it back. And you can adjust the angles to the way that you like. Okay. It's a very sharp needle.
Yes.
Okay. And it can pierce the tissue quite nicely. So that is one aspect. Next aspect is the thing that worries me in inside out meniscus repair is damaging structures. Okay. If it is a medial side, I'm worried about the saphenous nerve. And if you are going too posterior, which usually we don't employ this technique for a high posterior on medial meniscus because of fear of the vessels and main vessels and nerves, we employ it for the posterior aspect, not for the total posterior aspect. Okay. So further, what we do is normally hold this one. I make an incision here. Can you see the incision here?
Yes, sir.
Show me the forceps. Give me the forceps and one scissors.
Subramanian sir, what are the landmark for your incision?
I'll show you.
Safety incision.
So I've made a marking of adductor tubercle here. That is adductor tubercle. Okay. Can you see that?
Yes,
that's
we can
adductor
see.
tubercle. Okay. Yeah. Here is the anterior part of tibia. Posterior part of tibia is here. So make a line between adductor tubercle and posterior part of tibia. We don't have to go through the whole line, but that is the rough landmark for you. And joint line is here. That's the joint line. Okay, make an incision about 2 to 3 centimeter, which I already made for you. Okay. And then this is the sartorius fascia. What I see? This is sartorius fascia. Okay, can you see the sartorius fascia?
Yes.
Here is the sartorius fascia. Okay. Now, once you are into the sartorius fascia, do blunt dissection like this, then you can see the posterior medial part of the capsule. This is posterior medial part of capsule.
Yes, sir.
And semi-membranosus is on this side. Semi-membranous is on this side, and the medial head of gastrocnemius is here. So this is what I am showing is a capsule only. Okay. This is a capsule, posterior medial capsule. So saphenous nerve, which is worry for us, isn't it always? From adductor tubercle, at least about 5 centimeters away. So saphenous nerve course will be somewhere here. Somewhere here, okay? Yeah. So
Okay.
from posterior tibial joint line, or adductor tubercle about 4 to 5 centimeters posteriorly, you will see the saphenous nerve. We're not going to go there at all. Some people have a habit of dissecting that. I think when you are doing a mini invasive, you don't need to do that. If you are able to bring your suture material over this area around the posterior medial capsule, almost you are safe. You don't need to go there at all. But be aware, saphenous nerve is about, make a drawing for saphenous nerve where it is, so that you are aware the needle does not go there. Okay, yeah. So let's now demonstrate one suture application. Okay, we have only 3 suture materials available right now. I have already done one just for, let's open the water now. So I have Vishal helping me here. Normally we will be able to do some valgus stress and do some pie crushing also. It will help us for getting medial exposure. Yeah, we can use zone navigator. But here, I mean, is a little arthritic knee, so doing medial pie crushing is not possible. Okay, yeah. So now, anterolateral portal. Are you able to see the
Yes, sir. Yes,
picture?
sir. Yeah. Zoom out, outside image, zoom out a little bit.
Okay, let's see.
Yeah, thank you. Thank you.
Let me just, there is some bubble there.
Yes, some debris are there inside
increase-
the knee joint.
Give the shaver for me. Let's just do some. There are some good points and bad points about doing in cadaver. Okay. Only good point is probably that also We have like
Whatever you want to demonstrate, you can demonstrate. But sometimes your life surgery don't get that particular case.
yes,
That is
yes.
the advantage. Yeah. So Subramaniam sir, sometimes you have ACL with meniscus repair. So how do you proceed with your sequence? First, you complete your ACL tunnel.
Usually, when you're doing ACL and meniscus, I try to put a ACL femoral tunnel, okay, and keep the meniscus ready. And meniscus, I do repair once the femoral tunnel is done, okay. So I have some marrow. So give that zone navigator to me. So now you can see that. Can you see the zone navigator here?
Yes, sir. Yeah.
This one you already loaded the needle, but you have not passed through the tip. You just loaded it. So I'm passing it through the anteromedial portal. It's going in here. So I'm going to do another stitch over in the middle part of the medial meniscus. Okay. So I've just kept it here. Now pass. I'm going to pass the needle. You can pass the needle. Okay, like this. So can you pass the needle for me? Just keep pushing it. Because you have to keep on the place where you want to pass. See, can the needle is coming out? Can you see that?
Yes, sir.
Can you see the needle is coming out? Okay, yeah. Keep passing. Okay, now 1 minute. So now the needle has come out through the skin here. Okay. Hold the scope for me. So now what you have to do is, I've gone too far in, you can bring it out.
Do you use something like a spoon, right angle spoon to deflect the needle?
I think definitely we have to use some instrument.
Yeah.
To keep our side not.
You can deflect the needle towards your incision.
Leave it.
The posteromedial incision.
And see the needle is coming back.
Yeah.
Okay. Now
outside image.
Outside picture we have to see. So keep seeing there. Are you able to see the outside picture now?
Outside image, make it no, the other image, the knee image. Outside camera.
Are you able to see the knee end?
No, sir. Outside cam.
Wait,
Yes,
1 minute.
yes.
We'll just.
Yes, sir. Yes,
so
sir.
now, so we have kept a Langenberg retractor here. Can you see that?
Yes, sir. Yes, sir. Nicely.
So if you having some instrument over there, it makes our mind safer that we are not going on any big structures over there. Okay. Yeah. So people use spoon. Some people have their own. They have a mopping pad or something to pull it, because these needle can be very sharp. Don't pull it with a hand. Okay. It can cut your hand. So now we have done that. Okay. So this is one done. Okay. I just get the other one focused for you. So one is come out through here. This is one set, we already done it. Okay, this is the next one, we are doing it. So just show the relax now. Come over here.
So you can put your vertical or horizontal mattress, whatever suture you want.
Yeah, correct.
Navigating your.
Yes. Now I'm going to readjust my area where I'm going to put. Okay. If it is a tear, which is like a vertical longitudinal tear, I'll put one here. Okay. If it is a tear, which is a cleavage tear, I'll put here. Okay. Next one. If you want to put a mattress stitch, then I'll put here. So you can change your configuration as you like. So now we are going to put one underneath the meniscus like this. Okay. Yeah. Yes. Okay. Now pass the needle again. Come. 1 minute. Keep watching there. So now are you able to see the skin external camera there?
Camera 2, big
camera
view.
2, please. So that.
Yes. Thank you.
You keep passing. Yeah.
Yes, sir.
So again, it's coming back. Okay. Over here. So keep pushing it in. So inside out is actually a fairly simple technique, which is also cost effective also. Yeah. And this is for the medial side. You are going in between behind the posterior capsule. Okay, thank you. I have an artery clip and pull it. In the lateral side, you have to be careful about the peroneal nerve. So you have to make sure your incision is in the right place. So now keep pulling it. Can you see this? See the arthroscopy picture there?
Yes.
Okay. So this is ideal suture pattern for if there is a cleavage tear like this, okay, where the parameniscal cyst or something, then you can close that cleavage like this with the help of one going above on the superior leaf of the meniscus and then below the inferior leaf of the meniscus, and try to bring the suture material outside through the membrane here. And now we have this, hold the scope for me. So, can you see this here?
Yes,
There's
sir.
no
Yes,
soft
sir.
tissue in between. There's only the posterior capsule is there. Are you able to show the external picture for me?
Yes, sir. Yes, sir. Nicely seen. Nicely
So
seen.
this is one of them. This is another one which I already done it. Okay, before. Okay, so we're putting knot here. I'm pretty sure there is no soft tissue. Okay, so this is one way of doing it. In the lateral side, so you have one more, but lateral side is very difficult to go now because we have not prepared the lateral side. If you want to go for the lateral side, we'll go for it. At least I can show the dissection on the lateral side if you want to. Or your how is the time getting on there?
I think
Dr. Sharath.
Show me. Hold.
Lateral already.
Sir, lateral there is a different demonstration, sir.
Lateral side, huh? Dissection.
Yes, sir. Yes, sir.
Okay. I'll show the dissection demonstration. Okay.
Yeah.
So, and now we are just going to put knot in between these two. The knot is just you put a as usual knot, okay, and hold it there and tighten it. Then you can see that I just put knot of one of them and then we'll go there. Cut this for me.
Sir, Sunny is I think showing a lateral demonstration. So
I'll just show how the lateral dissection is, okay? Because the worry for me in all these inside meniscus repair is trapping the tissues in between. That has to be cleared. And you usually make about 3 centimeter incision, 2 to 3 centimeter incision are comfortable. You are not on the nerve and all. So hold the knot for me. So inside out repair is actually almost we can call it as gold standard only. Because I think Jagadish also told earlier it's a gold standard. Because before inside out all inside came in, we did only inside out for a lot of patients. Cut this one. Come.
cost effective also, very much cost effective.
Very cost effective because
have a circumcision
with the cost of one all in, we can actually do multiple here. Fiber tape is not cutting. Okay. Okay, cut this needle also. Okay. Lateral side, the worry is peroneal nerve, isn't it? For all of us. Okay. Hold the knot. It is cutting through. That is because that is the. Okay, thank you. Okay, fine. So that is done. I just show the lateral side now. Okay. So can somebody show the camera to the lateral side here? It'll come here. So give me the marking pen. I have a gauze piece or something. So come to this side. Camera should focus this. Close.
Yeah.
So lateral side, the landmarks are fascists, head of fibula is here.
Subramaniam sir, Sharath has told we are already late, so we will go for root repair, and then later on we will go for laterally. Yeah. So Shreyash is there.
No. Okay. What I'll do is I'll do the dissection and keep it ready. You can just come for 2 minutes.
Yes,
and then
yes.
go back.
That we can do, sir. So we will shift for root repair now.
I'll do the dissection here and show it to you with the all pictures on. Okay. Yeah. Fine. Give me a. Has another marker pen? Because this marker. Oh, you are going to go in this one.
Cameraman.
Okay. We have only one.
Oh, one cadaver only.
Case,
Next, I think there is a separate station for.
Okay, I just demonstrate it like this only. Okay, because the problem is we have one cadaver. In that only root repair is going to be done. Okay, so Here is the head of fibula. That's the IT band. So we have to go, and the biceps tendon is here. Your incision is going to be between that IT band and Gerdy's tubercle, which is over there. Okay. And go in between IT band and biceps. And once you are in that layer, try to identify the lateral head of gastrocnemius and the posterolateral capsule. Peroneal nerve is far placed over this area. So as long as you are in this region, we make about 4 centimeter incision there, you are safe from peroneal nerve. No issues will be there. And each time the needle comes, try to make sure you keep a spoon or retractor over there and try to bring the needle out through that. So that is a brief demo for the lateral side. But peroneal nerve is here, far posterior, and don't go there at all. So because the incision is going to be over this joint line, IT band, and Gerdy's tubercle. Okay.
Yeah. So I think we will shift for root repair technique by Dr. Shreyas Gajjar. Cameraman.
Thank you, Subramania sir.
Thank you, Sharath, and thank you whole lab
Thank you,
team
sir,
here.
for excellent demonstration. Thank you, sir.
Thank you.
We'll now go ahead with the demonstration of meniscal root repair by Dr. Shreyas Gajjar.
Can we hold this, please? Yes. The suction का डालो please. Oh, it's going to be challenging immediately. Sure, needle.
Shreyas sir, can you hear us, sir?
Yeah, Bhupesh, just give me a minute. I'm just trying to see if I will be able to demonstrate or not, because as Subra mentioned, it is a arthritic knee. So I just need to clear to see. Just give me. So I'm just looking through the AL portal.
All right.
Just trying to see.
I think lots of dilation are there. Cut degenerative changes are there. So you have to debride all those.
Shreyas sir.
Yeah.
Just a thought. If you require some time to set the things corrected, can we finish one talk and come back before that?
Absolutely. I thought so too.
Yeah.
Okay.
All right.
Thank
By that time, you can prepare. You can create your root tier also.
Yeah, sure.
Yeah.
If there is a route.
There is a route. Okay. Thanks.
So meanwhile, we'll carry on with the next session. I would like to call Dr. Mohan and Dr. Uday Kumar on stage to chair the next session on lateral meniscus. Mohan sir and Uday Kumar sir. So the next talk will be on radial tear and root of lateral meniscus repair techniques by Dr. Sharath Kaya.
So we'll start our lateral meniscus session.
So good morning, everyone. So my talk on lateral meniscus radial tear and root tear. So the radial tear, the principles are the changing portals, viewing and working portals, posterior horn, all inside and end to end using first pass mini or scorpion, usage of passport cannula and several techniques. So I'll just run this video. You can run the video. Video. Play.
You can click there, yes.
So the click. So this instrument is called as knee scorpion. Similarly, there will be shoulder scorpion, and this red color handle with the needle is a knee scorpion needle. Brown color is a shoulder scorpion needle. So how to use this? This needle, this is a very useful instrument for meniscus repairs. This needle has to be passed like this, and this handle is fixed here. Now this needle is this scorpion instrument is ready for using. Imagine that this is a meniscus with a radial tear. We have to stitch like this. So one end is hooked here. And now when you press this handle, this gets closed. Okay. For example, we are seeing the scope like this. This is the scope, and I am going like this, and I am pressing the handle. When I go near the meniscus, I open. When I go near, I open it like this. I am pulling this. This thread has come out like this. You keep this thread aside, the other end of the thread, other end. So imagine that this is a meniscus. The scorpion needle comes from below to up, and the thread comes from below to up. Other end of the thread, you fix it. This is the thing. Now you have to put the knot outside. Friends, so with that, so run the video. So this is a radial tear, the posterior horn. So we have to make sure that the needle doesn't damage the cartilage. Whenever we are repairing the radial tears, the one end of the thread is to be held and use the passport cannula to avoid the entanglement of the soft tissues. This is with the scorpion. But whenever you are tightening, there may be overlap or irregularity between the ends when you repair it. So to avoid that, you can avoid tightening initially, later use all inside. So you combination of all inside and scorpion usage for the radial tears of the posterior horn is the best for the lateral meniscus. This is the final picture. Okay, so if we have to, okay, so run the video. So if the radial tear in the anterior part, so anterior part, the oblique radial tear or the parapet tear, you have to you can cut the white zone. Then as it was discussed, zone specific cannula, inside out needles and all inside both can be used. And as I was telling, you can switch the portals, working and weaving or weaving to working. So this helps in weaving properly where you have to see. This is all inside first, and then using the curved cannula to fix the inside out needles I have used. So this one all inside, then one inside out needle. So you can also have different configurations like rebar and other techniques to avoid the cut through of the stitches. So then the root of the then we'll come to the root of the lateral meniscus. So root of the medial meniscus is already discussed. The medial meniscus root is the tear of the root due to degenerative cause, whereas lateral meniscus is most of the times it is a traumatic and it is avulsion along with the ACL tear. Commonly it is along with the ACL tear, and you have to check for the lateral meniscus avulsion from the root whenever you are checking. And there are two techniques, transtibial or with a suture anchor. Transtibial technique is the best of that. And so, see, I am going to show one more small, run it. So most important.
So middle of the fiber wire, in the middle, you have to hook it like this.
We have to put the fiber wire in the middle whenever you are using the scorpion for the root.
The root.
So the end of the fiber wire.
Here. We go near the root, open it, go closer. Now the loop is coming. Slowly pull it like this. Keep the two threads outside the joint now. Pull it like this. Here, once again, you fire it, it will come out. Now this through two threads, you have to pass it inside this thread.
So the cinch knot, how to put the cinch knot.
Like this.
So run the video. Video. So this is the avulsion of the lateral meniscus. You can see this is with the ACL. So the fiber wire should be in the middle so that the loop is formed. The loop has to be taken through inside so that the cinch knot is formed. And whenever we are doing the lateral meniscus with the ACL, we have to take the cinch knot before and then pass the femoral tunnel and tibial tunnel and reattach the lateral meniscus, then pass the ACL graft. So with the specific jigs, you can use the ACL jig or root jig, which is adjustable for the medial and lateral meniscus. 1 minute, I'll take. So these are the two knots, and then this is the ACL tunnel. Then reattach the meniscus. Then after that, pass the ACL. Next. So exactly similar to that another one. I'll go. So non-weight bearing for 6 weeks, passive range of movement. A patient can be advanced for knee flexion as tolerated. And thank you for your kind attention.
Next, I call upon Dr. Rajiv Raman for his talk on discoid lateral meniscus decision making.
Laptop. Thank you, Sarath, for invitation. So I will be talking on discoid lateral meniscus. What are the decision making options?
So I attach it. Meniscofemoral ligament will be there. So I attach the avulsed part as it is now. I don't disturb the meniscofemoral ligament. But most of the times, as you rightly told, the lateral meniscus root, meniscofemoral ligament is very clearly visible. Yes.
So you repair it in situ, or you try to release and try to put it at anatomical position?
I repair it in because lateral meniscus always has one fiber coming from the actual body.
Yes.
So I attach to the actual body to the where it is. The fiber will be retracted. But medial meniscus, whenever it is retracted, there will be a gap. The study shows that you can attach to the gap wherever it is. But lateral meniscus body is there, it will not get retracted. So it is avulsion. Medial meniscus get retracted.
It's loaded there. Yeah.
Dr. Sharad,
Rajiv.
Yes, sir.
Can I ask
Two
one
to A.
question?
Yes, sir.
How do you differentiate or how do you prevent coalescence of the tunnels between
Yes,
your
very good.
ACL and the root
Root.
tunnel? How do you prevent coalescence?
Sir,
Any tips
ACL,
and tricks?
if we use root jig for medial side, we can direct it from lateral to medial side. ACL jig anyways from the medial to up to the tibial. Lateral meniscus, some of the papers and suggests that you can use the same tunnel for the lateral meniscus and ACL, but better to use a different tunnel. So with the root jigs, you can adjust the tunnel. And anyways, this is 4 mm tunnel. ACL will be at least 7 mm tunnel. So for 3.5 or 4 mm tunnel for the root attachment, and that may not be in coalescing with the ACL tunnel.
So the ideal way would be before, when you're doing a root repair with an ACL, before you make the tunnel, have two bead pins, one for the root and one for the ACL, and see the distance at the tibial side,
Yes.
and then go in for the
I
drilling.
think that is the best way normally we also follow. So for medial meniscus root tear, try to be your ACL tunnel, root tunnel, try to keep medial. For lateral meniscus, try to keep lateral, so that both the tunnels are parallel, it will not collide. And I think the bead pin technique is very good. That will help you out in collision of tunnels. So I will be talking on discoid making for decision making for discoid lateral meniscus. Next slide. Yeah. So normally most of these patients come in our clinic either with a pain, leak, third, locking, or a giving way. Sometimes a large discoid meniscus patient will come to your clinic with a giving way sensation also. Next. So normally it's working from here. Oh yeah. So normally it may be a symptomatic discoid or asymptomatic discoid. As you know, most of the discoid meniscus are there in the adulthood and childhood. The patient comes to in our clinic only when there is a history of locking episode. So how will you deal with this? So sometimes you can see this is a case of incomplete discoid. You can see the smoothing of the margin. Normally, the lateral meniscus covers 60 to 70% of the lateral tibial plateau. If it is more than that, it's a discoid meniscus. If it's covering whole of the tibial plateau, it's a complete. If it's covering up to more than 70% of the tibial plateau, it's an incomplete discoid. Video, please run. Please run the video. So you can see it's a symptomatic discoid meniscus. There is a tear here, complex tear in the discoid meniscus. To start balancing your meniscus, and don't try to use saver, because what will happen, you will not preserve the rib. So the basket punch is the best instrument to gradually you can see, and try to find the unstable layer. What happens? You have two cleavage there, superior and inferior. Sometimes you have a unstable inferior layer, sometimes you have an unstable superior layer. So with your probe, try to find your unstable layer and balance it. To try to keep at least it. And this basket punch is the best device to balance your meniscus. Start from the center and gradually go posteriorly and anteriorly, so that you have a after suturization. So you can see after balancing, you can see again, put your probe inside and see which layer is unstable. So gradually I am balancing it on the posterior side. And now you see with the saver, just take out this debris out and see the upper layer is coming inside at the middle point of the knee joint. So that layer is unstable. Again, try to balance that layer. And this is very important. If you keep this unstable layer there in balancing, when you are doing suturization or balancing of the lateral discoid meniscus, patient will have some amount of instability, click, or locking episode in due course of time. And now you see the inferior layer is stable, and you have done a perfect balancing of the discoid, incomplete symptomatic discoid lateral meniscus. So again, for discoid meniscus balancing, always try to use the basket punch. run this video. Normally, we have a straight punch, right, curve to the right, curve to the left, and backbiter. Keep all those 4 sets there. You can see the straight punch, it comes is a straight or a 15-degree up. And you can see this is curve to the right and the curve to the left punch. And keep all these 3 punches ready when you are planning for treatment or balancing or socialization of a discoid meniscus. What happens sometimes when you use saver, most of the time you save most of the meniscus, and sometimes in this patient you come up or you end up doing a complete meniscectomy. Here you can see this is a symptomatic discoid. The straight punch works better in the central part of the body, but because it's that direct, so you can see 15-degree up straight punch, and I am trying to balance the meniscus, just balance it. And you can see sometimes what happened, you can see the tibial spine come in between. What is the technique? Just rotate, and you can see, and again you can negotiate, and you can cut some part of the posterior of the meniscus also. This is the best way. Rotate your 15-degree basket punch down, and you can just negotiate through the tibial spine. Then take your right and left punch to, you can see this is for the posterior part. You can see balancing of the posterior horn is easy with the curve to the right, and balancing of the anterior horn is easy with the curve to the left. And now you see you have a good meniscus, you can rim there, which you have balanced. If you are using saver, most of the time you cut more of the meniscus there. Now you have to balance the anterior horn. Here we are taking the curve to the left punch, and you can see now I am balancing the anterior horn. So these 3 punches are important, and you can see you have a good stable rim of the lateral meniscus. So incomplete discoid lateral meniscus, don't try to use too much of saver. Try to balance it with your basket punch. Video. Sometime after balancing of the lateral meniscus, you will see you have a unstable rim, outer rim of the meniscus. And studies have shown, the biomechanical studies have shown, if you can preserve this rim also, that will prevent degeneration of the arthritic changes inside the knee joint. So here you can take a vertical mattress suture. You can use any of the self-retrieving suture passing device. And we are using orthocord suture here. So try to take a vertical mattress suture. 3 or 4 vertical mattress suture are good enough to stabilize your rim. And believe me, if you save 6 to 7 millimeter of the lateral rim, that will also prevent degenerative changes inside the knee joint. And try to put your knot toward the capsular side, as we were discussing in the first session, where you should put your knot. So try to put your knot. So first bite, second bite, and gradually you can see whole of your rim is getting stabilized. So after socialization of your meniscus, sometime if you see there is an unstable rim, put 3 or 4 vertical mattress suture. You can use your all inside device. You can use your self-fitting suture passing device. And you can see as a good rim of the meniscus has been stabilized. And this 6 to 7 millimeter of the rim is good enough to prevent arthritic or degenerative changes inside the knee joint. So discoid lateral meniscus, I think the most important part is symptom. Most of the patient, when they come, it is symptomatic. If there is no symptoms, I think keep them on close follow-up. Yes, if the patient is coming in your clinic with the symptoms of either locking episode or a third, if patient is adult with a complete discoid lateral meniscus, with or without pain, go for a partial meniscectomy, with or without meniscus repair, what we call balancing. At children, usually most of them come with a complete discoid, and mechanical symptoms is there, go for partial meniscectomy, again with or without repair. Adult with incomplete discoid, if they come with pain and with or without mechanical symptoms, go for socialization of the meniscus with meniscus repair. And if there's only click and no other symptoms, keep them for close follow-up. And I think this is the sequence you should follow when you are making decision making for your lateral discoid meniscus patients, seeing the patients of lateral discoid meniscus. Thank you so much.
To make a root tear.
Thank you, Dr. Rajiv. I think we are ready with the live demo there, so we can go there.
Or if it comes, it's fine. Yeah. Hello. Can you hear me?
Yeah, Shreyash, you are audible.
Yeah, hi. So we had to change the cadaver. This is a better one. So you can have the meniscus and all. So let me demonstrate the root repair first. So we have done the pie crusting to increase the space, the working space, but This is, I think, the maximum we are able to succeed, but it is reasonable enough. So first thing, so you imagine that there is a root tear at the back. What we are going to do now is make the tibial tunnel. So can I have the jig, please? So
Shreyash,
do we have both arthroscopy and the outside image?
Shreyash, can
Yeah.
you show the steps of pie crusting for benefit of delegates?
Okay, so needle, please, Venflon.
And at what point you do? What is your magic point?
So, you switch the OT lights off, there is a illumination. The other way is to just press on the outside and see where that area is. And then you just come in with the needle. So generally, I stick to the mid substance and the femoral side and more in the posterior half of the MCL.
And what
And,
needle you choose for pie crusting? What size needle?
16. The same I use for my outside in portals for a knee arthroscopy or shoulder. So I'm just making multiple through the same entry point on the skin. I'm going in different directions superiorly and in the mid substance to try and do these multiple drill holes. And then my assistant is actually applying a valgus stress to see how much it opens up. So this is reasonable enough. And what we need to see is if our instrument is going in well. But obviously, in real life situation, you will have a little more opening. But I'm able to negotiate. So, earlier in the question was about the Gilchrist maneuver. So, you go in from here, and you see that that's the ramp area, and that looks fine. So let's stick to the route right now in the interest of time. So we have a jig. I don't know. Do you have the outside image?
Yes.
Yeah.
We can see both the.
Yeah, so this is a second generation root repair jig. We already have a third generation, but basically there are markings, so you can decide where your entry point on the tibial joint side is going to be. So it is a low profile jig. It has a curvature to accommodate the contour of the femoral condyle. So we are just going to. Isko pakdo aap. Yeah. Can I get you on this side because it will be easier to hold the camera, somebody to hold the camera, yeah. So we are just negotiating the jig to the back of the tibia. And there's 7.5 and 10 millimeter markings on this. So you have to hook this in the back. Fluid is going in, yeah, good. So we just got to hook it to the back of the tibia like so. And then
First Shreyash, first you make your tunnel, then you take bite from the root.
Yeah, because I don't want my sutures to come in the way.
All right.
I always do my bites later. I just, so that the suture management becomes easier. So I'm just trying to get a good view. Suction karo re Rohit beech mein, so I can just see what is happening.
So what are your landmark for your tunnel?
So I'm just hooking onto the posterior margin of the tibia, as you can see here.
Yes.
Do you have a view? You can appreciate.
Yeah, we can see both inside
Okay.
and out.
So I'm going to go at the 5 millimeter mark. So can we hold the camera, please? On the outside, you make a percutaneous. So the sleeve of this root repair jig, you can just feel it on the tibia. Try and stick towards the midline because you're coming posteriorly, just like the PCL. You're coming closer to the midline. So we do that.
So this 5 millimeter is posterior to the posterior joint line. This marking is for
anterior to the posterior joint.
Anterior to the posterior joint line. Oh, that is.
So I'm just making a percutaneous incision on the tibia. You have the outside view?
Yeah.
Okay, good. So then we are passing the dedicated sleeve and locking it. I'm just making sure that the jig is not moved. We are sticking to the midline. Yeah, okay. We'll take the camera back a little. Great. The locker of 5 locked, no? Okay, good. So we have the sleeve now. So I make a socket rather than a tunnel, just a centimeter on the tibial side to minimize the potential concerns with bungee effect if you make a tunnel. So I've just hooked it here, and you have a good view. So what I'm going to do is I'm going to pass a beth pin to make sure that my entry point on the tibia is way posterior where I want it to be. So I can always kind of revise it. So pakado, please.
You try to put your root tunnel centrally.
Yes.
Yeah.
I'm just trying
And
to focus the camera. If you have a good view, yeah, that's good enough.
at
And
what
then,
angle you have set your jig?
so it just, so here it says 70, but I will, it's somewhere between 65 and 70, you know. Piche le lo, please. Good. So we can see that. Yeah. Again, it's, yeah. Drill, please, the wire. So we are passing the wire now. One of the important thing is to lift the jig and go as posterior as possible. And go slowly in real life situation. There you go. So you know, that's my entry point. Jig ko pakdo, please. Yeah, very good. So we're just going to make, you can use a shaver also to make sure you're happy with the entry point. I'm just going to double check. So this is good point, Rajiv. It's right
Yes.
at the back and towards the midline. It's not laterally onto the posterior body of the meniscus. So I'm happy with this. Please hold this. So once I commit to this entry point, then I'm going to use the flip cutter straight away. So I don't, if you have the outside image, so you need a longer flip cutter because you're going at the posterior part, not in the anterior. So we have a long flip cutter. And I've taken the smallest, which is 6.5, because I don't want to make a bigger socket. I just need something to allow my sutures to pass through. So we are just loading the flip cutter on the drill. You can see it outside. It's got these markings and it's got a grommet at the end. So I'm just going to go now and very slowly.
So what is the length of this
Suction
flip cutter, Shreyash? This is a
Length.
long flip cutter, I think.
Yeah, it is a long.
Yeah, longer. This is for
20,
root.
I think 25, yeah.
Yeah.
So you just keep this, Rajiv, and you can reuse it a couple of times, you know.
Yeah.
Because 6.5 will generally be used only for root. You won't use it for ACL unless you're dealing with a child or a small.
Yeah.
So I think we have, I can feel that I'm hitting the thing. Very good.
So what will be your tunnel size with this flip cutter?
6.5. The size is 1 centimeter.
Yeah.
The
So
length.
it's a
Length you mean?
Yeah.
You mean the length?
Length.
Yeah, okay. 1 second. Focus. Okay, good. So just checking. Hold it, please.
Yes, we can see. I think indirect sign is the fat globules. If it comes, that yes, it pierces the. That is the best indirect sign of.
Yeah.
You have dealt the second cortex.
Yeah. Just trying to get the camera, angle. Okay, yeah. So what has happened is, while I feel that my entry point is a little anterior, because the jig kind of moved. Okay, so we are going to we have to demonstrate the steps here. So that is important. So just hold the thing. We are going to unload the jig now, offload rather.
Yes.
And take it off the sleeve. Yeah, great. Yeah. And I need a shaver next. So just camera, can you remove? Yeah, very good. Fantastic. So we're just taking it off. We have left the sleeve there. Just can I have the shaver, please? Shaver de do. So I'm just going to see the. Okay. Focus. Yeah. Okay. Okay, so can we hold the camera now, please?
Yeah.
Yeah, so it's at the same entry point. That's good. Can we have the suction so we can see it? Yeah, one second. Just please hold this, Rohit. We keep the light lead. Yeah, so that's good. So I'm happy with that.
Yeah.
That's so what I'm going to do is just go a little bit more, advance it, and hammer, please. So we have to fix the sleeve onto the tibia. That there is a step so that if somebody is creating a socket, long socket, it does not become a tunnel. So we are just going to hammer it, engage it in the bone. You have the outside image, right?
Yes, yes.
Okay, good. So that's it. So now I'm going to advance the flip cutter. Suction, please. Thoda lightly chalu hi rakho so we can see what we are doing. Okay. So it's gone in. Dikh nahi raha hai. Can we have the shaver dalo na, please? So we can see what we are doing. Yeah, that's better. Okay, perfect. I want this view if possible. So we are going to now deploy the flip cutter like so. Okay. Can you see that it's deployed?
Yes,
Yeah.
yes.
Okay,
Just
good. Anytime the vision is not clear, please let me know, huh? Because I'm just
I think a central LED screen is not
central LED screen.
AV guy. Yeah, LED screen. It's coming in at the level of your jig only.
Okay, now it's okay. Acha, in the auditorium thing. Okay.
Yeah, now
so
it's okay. Yeah, just
good.
Just
So I'm now
zoom in
creating.
and show how you open the flip and how you close the flip. Yes.
Okay, okay. So
Just
yeah.
zoom in because yeah,
So, yeah.
everyone can see. Cameraman zoom in.
Yeah, one second, huh? One
Yes.
second. So yeah, so that is the essay pakado, please. Please hold it like this.
Oh,
So
this
it's
is
not
most
deployed
important
yet.
step.
I'm just going to turn it around. So it's not deployed. There is a
Yes.
button on the outside and I pull it towards me. You can see it now deployed.
Yes, yes. Fantastic.
Okay. Now I'm going to just come down to the plateau of the tibia. And then I'm going to use this
Inside.
grommet. You have the outside image?
Inside view, please. Inside. Cameraman
Inside is
inside view. Yeah, now we
inside.
can see it.
Yeah, and outside, you have the outside view?
Yeah, outside view. Can you
So
clean it? I think some debris is there.
Yeah, we'll clean the
You can clean
inside.
it.
Just one second.
Yeah.
Just hold
Yeah.
suction.
So
Chalu
that
to.
yes. Excellent.
1 second. Shaver de do. Yeah, it just clears in a few minutes. 1 second.
Yeah.
Valgus rakho na. Yeah, 1 second. Yeah, that's fine. I can't see the screen now. No, I can't see. No, I can't see. Yeah. 1 second. Hold this, please. Okay. Yeah, better?
Yes, we can.
Okay. Just hold the camera, please, now. That's fine. So I just want to make sure I have deployed the flip cutter, which I have.
Yes.
Now I'm just going to go a centimeter, okay, inside. So on the outside, there's a laser mark. So I've gone a centimeter. That is all I need. Then I'm going in again. Obviously, we want to do it under vision. We want to make sure that, yeah. So yeah, that's it. So now I'll close the flip cutter. Can you see, Rajiv? We have done that.
Yes.
And now I'm just withdrawing it because the purpose of the flip cutter is served. Okay. Now, shaver, please. Yellow, please. Thank you.
You have a good raw area with 1 centimeter depth. So
Yeah.
meniscus will land there.
Yes, shaver. इसको छोड़ दो please, कुछ नहीं
And this
करना।
is very important. If you don't create that raw area, there will be no healing. It's a soft tissue to bone healing. So there should not be any cartilage there. The whole of the meniscus should sit inside the raw area. And that is the advantage of this flip cutter.
So we are just cleaning the mouth. 1 second. ये और पकड़ो। So we are cleaning the mouth of the socket here. Okay, so that's curate also. We can use a curate.
Shreyash, you prefer single tunnel or two tunnel, double tunnel technique? Single tunnel, yeah.
So I have cleared the mouth of the socket, as you can see here. Okay. To allow that root to heal to this part of the bone. Shiver, please. Okay, now we're going to put a cannula for suture management. So passport cannula, artery first. Make sure that the portal is big enough. Somebody, good. So for suture management, I think a cannula is good. Knife. Make a bigger portal because we are putting a cannula. Okay. We have dedicated passport inserter as well. Okay. Yeah. And Prokar, please.
Yes, sir.
Making
So you
sure
can
that
see the advantage of passport cannula. So it gets locked inside also, and whenever you are passing a suture, the soft tissue will not get trapped in between your
air को
suture
इस तरफ
material.
लेना है, बहुत
It's always
important
better to put a
Good.
cannula before you are passing any suture.
You can come on this side now to help me. That will be great. Passport cannula pakado. Good. So we are ready with the scorpion, and I prefer the cinch configuration. So you have the outside image.
Yeah.
So one way to achieve a cinch is to preload the loop onto the shaft of the knee scorpion. Can you see
Yeah.
that? Is it
Suresh,
visible?
for benefit of audience, I think just show how to load the needle and
Okay.
how to load the suture, because I think they can see.
Yeah.
Yeah, just zoom.
Okay. You have
Outside
the
camera, zoom in. Yeah, Suresh.
So try and yeah, you can see it, right?
How to
I'll
load,
put it under
yeah.
the blue background. So because it's a
Yes.
white suture, is it better against the brown, or you can see it?
Yes, we can see.
Okay.
Yeah.
So don't waste the suture. Just go very close to the edge. Then you just feed it through the needle, and you can use the posterior shaft to just prime the needle.
Yes.
And
Always check
then
outside.
you can use it for the bite.
Yeah.
Make sure that it is sitting right in the slot, and then you go in. Yeah, the loop, we'll take the loop, cinch loop. Hope the cannula, please, Rohit. Cannula. So one way is that you can preload the loop on the shaft. So, you can see that cinch loop is being preloaded. Can you see it?
Yes.
Yeah? Okay.
So this is a very good self-retrieving suture passing device near scorpion, and it works very well in very small space also. You can see.
Cannula. Okay. Can you put another one? So the first cinch suture is passed. Okay. What I tend to do is can I have the fiber stick, please? So I tend to just deliver this through the socket. So again, it does not come in the way, or you can pass it outside the cannula. So what I'm doing here is, have you got the outside view?
Yeah.
So I'm using a fiber stick and getting my shuttle suture. Can I have the grasper? Suture retriever.
Yeah. So once you pull out, it will come down. Yes.
Hold this, please. Good. Hold it, don't let go.
So now you are pulling the suture.
Yeah.
Yeah.
So now I'm going to railroad. Can you put it in that? Can you have the outside image?
Yeah, it's there.
Yeah. So
Just
I'm
zoom in. Just zoom in.
there.
So the yeah. Yes.
Hold
Now we
karo.
can see. You can see
Yeah.
the railroading.
Yeah.
Yes. And just he will pass it through. Yes.
And you see how it.
We'll need it again. Can we load this fiber stick again, please? So
Yes.
that's, that's
You can see.
how it's going to
First,
be.
first bite.
Yeah. Now we're going to take the second one. Can I have the knee scorpion? So again, it's loaded.
So how much distance you keep in between two bite?
Half a centimeter.
Oh.
Depends on the quality of the tissue
Quality.
also.
Yes.
You should get the, but you want to come closer to the midline, not go away.
Yes.
So again, cannula, good. Yeah. Yeah, good.
Single tunnel, two sutures.
Yeah. So we are just passing the second one, the cinch. So that's it. Now we'll again pass it down to the tibia. Water. Yeah, we were just running out of water. Okay, good. So we'll pass the fiber stick through the sleeve into the joint. Okay, retriever. It's best to have different colors. Today we have a white color only, but two different colors would help in identifying easily, so you don't miss out. Okay, karo please. Barabar tha, don't touch. Yeah, okay. No, pull the fiber stick out. Okay. Lelo, please, somebody. Thank you.
Cameraman, just zoom in there. Yes.
Then now we are passing the second
Yes.
suture. Hold it. Hold it on. But that's it. Not so much. Just little bit. Yeah.
Yes.
And you're going to just deliver it, as you can see here. Okay, done. The suture retriever can also go. Good. So we've got the two cinch out. What I'll do is, one second, let me see where it is. Yeah, give me a probe, please.
So tibial side, what is your fixation method?
I use an anchor. Earlier I used to use a disc.
All
Now I
right.
use an anchor. Suture chodo, tight nahi karna hai.
So sometimes there is overlap also. So see with the probe, he is trying to.
Yeah, I'm just trying to kind of reduce the
reduce the root towards the crater,
Yeah.
and then he will pull it out and fix it over the tibial side.
Yeah, pull karo.
Yes.
Yeah, that's it.
Yes. You can use post disc.
Okay. Yeah. So that's it. And now I need somebody to hold the camera here for me. Okay. Anchor on the outside. So we need an outside image. Just hold this here. Drill. Have you got the outside image?
Yeah.
Okay, so I'm.
You will fix it with civil lock?
Yeah. Yeah. I'll fix it with a peak civil lock and in about 90 degrees of flexion. So I'm using a dedicated tap.
That is. Cameraman, can you show the laser mark there? There are two laser mark over the tap. Yes. End on view he is showing.
Okay, anchor. So it's best to use a peak anchor rather than a biocomposite for the tibia hard bone. You can see this. Are
Yes.
you having
You
the
pass your
outside?
suture
Okay.
and then put it there.
Yeah. Then the knee is in 90 degrees flexion. Good. That's it. And we just see the scopy image. So you see the root is nicely reduced.
Yes.
You don't want to over tighten it also. So the eyelet tip had gone to the mark. So we are just going to now screw the anchor in. It is soft bone, obviously, as we know. Then we draw it. Yeah, good. Cutter, please.
Yeah. Thank you, Suresh. I think we will go with talk and then demonstration of the lateral meniscus session by Dr.
Perfect. So
Bhupesh.
this is the end result.
Yeah.
Of the
Fantastic. Excellent. You can see the whole of the root has cinched inside and it's sitting there in the crater. Thank you. Thank you, Suresh.
No problem. Thanks.
So, Dr. Harish Chandran, he will be talking on anterior horn of the lateral meniscus outside in repair technique.
Go to the. Does it come here? Come here. It's not come. Please have a look. This is for changing slide. This one is for what? Okay. This one, okay. I'm not sure this works. Does it work? Yeah, it's okay. Yeah, that's fine. Okay. Good morning. Thanks, Dr. Sharath, for the invite. I think we're running short of time, so I'm just going to brush through a few slides. My talk is on anterior horn meniscus tear outside in repair. Basically, you need to know is that you need to treat your meniscus tears. You can't leave them alone because it causes osteoarthritis. You all know about it. So repairs are in demand these days. The incidence of an isolated anterior horn tear is about 1 to 3%. So that's a very minuscule. And another point that you need to take is the horizontal tears, usually that's the normal pattern, is always accompanied with a parameniscal cyst. Why anterior horn meniscus tears? Because it's shown to significantly increase the tibiofemoral contact pressures, and repairing these tears have restored these contact pressures to normal, and therefore surgical repair of meniscal lesion is indicated wherever possible. It's pretty difficult to diagnose sometimes because your patients don't give you that kind of symptoms, sometimes pain in the anterior aspect of the knee, and the MRI imaging may not provide you adequate details for the anterior horn to fully confirm the diagnosis. That paper in 2022 at AJSM with the clinical significance of anterior horn meniscal tears by MRI images, they did consecutive 947 images, of which 8% indicated tear of the anterior horn of the knee or lateral meniscus, and 31 of these patients underwent a subsequent arthroscopic examination, and only 26% true positive results and 74% false positive results. So finally, they recommended saying that when interpreting, you need to also have your clinical significance in mind. Couple of look at the MRIs, which is there. That's the anterior horn lateral meniscus tear, and that's the picture of a repair tear once that's done about a year's time later. Repeat MRI. Another one again. That's the coronal image also there, and that shows the healing of the meniscus.
Third image is the anterior horn there, which was left alone. And 1 year later, that developed into a parameniscal cyst. So your arthroscopic intervention and probing of the tear may be required to confirm the full diagnosis. Techniques outside in repair is the ideal anterior horn, is ideal technique for the anterior horn because it allows for the adequate access of the anterior horn and provides a stable fixation, and you don't have too much of intra-articular materials, and doesn't require any specific implants, so cost effective. Tears in the peripheral 2/3 of the anterior horn are typically indicated for repair because of the increased capacity of healing. And that's a schematic representation of the anterior horn repair, where you have two cannulas, 16 gauge cannulas going in, one with a loop and the other one is straight. Both are PDS. And you need to pass that PDS through that loop and pull this cannula, the loop cannula out so that it comes out. And then you can use a fiber wire if you want, or you can use the same sutures or railroad with the fiber wire again, and then do it vice versa. That's a video on the So all you require is a 16 gauge cannula. It's a normal cannula that you use, and it's got a white book, so you can pass your #1 PDS monofilament, absorbable monofilament through it, and pass on a couple of stitches. There's no restriction of stitches as you look at the tear. Sometimes if there's an meniscal cyst associated, you need to use a shaver and decompress that cyst, and then followed by the repair of that anterior horn into the capsule. No, I think you stop that. Yeah, okay. There we go. That's after the parameniscal cyst was decompressed. That's your first stitch. Like I said, then you pass it with the loop. And your second stitch goes in there with the monofilament. That's picked up with the grasper of metal. Make sure you don't scuff on the cartilage. That's very close to the cartilage surface. That's something that you ought to look forward to. And then that loop comes, and then you got to use your suture manipulator and take that stitch off through that loop. So you can have a couple of bites like that. That's very cost effective because PDS doesn't cost much. You can have 2 or 3 stitches based on that tear pattern that you have or the size of the tear that you have. So that's something that you can easily suture onto. And you also have something called as a meniscal mender or the mender device, which is usually used for the anterior horns. There again, the cyst is identified and decompressed, and you can see a huge void capsular tissue there along with the anterior horn. That needs to be approximated. So you debride that, and again, the cannula is passed along with the PDS. And the second instrument that comes in is the mender device, which has got a preformed loop. You can see that steel device coming in. That's the mender PRF. And that's placed onto the device there, and then it's grasped back onto the tissue. And it's pulled across into the capsule. So you have subsequent tissues coming in, and bites. You can have 2 or 3 or 4 bites based on the requirement. I think I'm short of time, so I'll push forward. Okay, and now for beginners, in case you have difficulties in managing the knots and kind of thing, you can always use that anterolateral incision and slightly extend that vertically down so that you can visualize the capsule and make your knots through half inches and kind of thing. So your pearls are the arthroscope is always placed in the contralateral portal so that you can visualize your anterior horn really well. Distance between sutures should be about 3 to 5. Either a horizontal or vertical mattress suture configuration can be used depending on the nature of the tear. Verticals are much better. and use of as many sutures as necessary to stabilize the tear. Post-operative recovery is 6 weeks knee immobilizers, partial weight bearing, physical therapy from day one, concentrating on passive range of movements, knee flexion limited to 90 degrees at the first 4 weeks, and strenuous activities after 4 months to avoid stress on the meniscal repair. Meniscus healing, the most reliable technique to assess meniscal healing is arthroscopy. MRI is not considered the gold standard because of signal changes persist for a very long time, often do not correlate with clinical symptoms. And when the healing status is uncertain, I think an MRI is much a better preferred choice. For those of you who really want to start up doing these cases and kind of thing, I think probably Leptard's article is a must read. Thank you.
Thank you, Dr. Harish. Any questions from the audience? Thank you. Yeah.
Thank you so much.
Thank you, Harish, sir. We'll break for tea now, and we'll be back in another 10 minutes. We'll have one more talk and the cadaveric demonstration to be followed after this. Thank you.
Check, 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 hey, hey, check, hey, hey, check, check, 1, 2, hey, hey, check, hey, hey.
Good afternoon, everybody. We'll resume with the next session in another 2 minutes. We'll be going ahead with the cadaveric session on lateral meniscus repair.
I request all delegates to please come and take your seats. We are starting the program. The next talk is bucket handle tear of the lateral meniscus, Dr. Pradeep Kochepan.
So I've announced that we'll be going ahead with the cadaveric session. I've announced one. I'll ask. Everyone, please take your seats. We'll go ahead with the cadaveric session for now.
Dr. Harish and Dr. Nirmal, please come on desk.
Tinga, 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 tinga. Ding, 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 ding. Ding, 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 ding.
Dr. Harish Chandra and Dr. Nirmal Kumar Singh, sir.
My audio is on.
Hello, Bhupesh.
Can you hear me?
Yeah, yes. We can hear you. We can see you inside and outside picture. Please go ahead.
Okay. So today I had a very interesting discussion with Dr. Hemant
Yes.
from UK. Me and Sunny were talking to him when we were having tea. So he was morning also he had asked, how do you see a tight lateral compartment? So first I wanted to show that you can see the knee is hanging down position here.
Yes.
Okay. Sometimes when figure of 4 does not work very well, okay, you can do, Dr. Vishal is showing me now. Can you see Dr. Vishal doing it? He's doing the opposite of medial opening. He's giving a varus and slightly internal rotating, and you can see the whole lateral meniscus here.
A very good technique. I think because lateral side is very difficult. You can't plan for pie crusting. So this is the very good maneuver to open the lateral joint line.
And this is the same, it is not, we have not done any pie crusting. This is a tight knee. And with just little bit of maneuvering, you can see the whole lateral side well with varus. And he's going to flex little bit. When Vishal flexes little bit, I can see even better.
Yes. So it's varus and internal rotation. Varus is stress with internal rotation.
Yeah.
Yes.
Minimal internal rotation. Mainly it is a varus. Okay. I can see all the way till the popliteal hiatus here. Okay.
Excellent. And you have got a very good meniscus, Bhupesh. I think you put some catch to the cadaveric lab.
So now we are going to put this in figure of 4. And I have made a radial tear. The other question that was asked was, what do you do when there was a radial tear? This is for Harish sir. So radial tear in front of the popliteus.
Yes.
Okay.
Fantastic.
So we are going to repair this now. So now first thing what I will do, needle. first thing I always take a needle. Whenever I have a lot of work to do in the lateral meniscus, I do a transpatellar tendon portal. Can you see the outside?
Yes, we can see.
And this is my third hand because I want a probe to come and hold the meniscus well when I'm tying the knots and stitching. This is my third hand to reduce. So this tip is very important. Always make a transpatellar tendon portal just under the lower pole of patella. Cut it vertically so it is along the fibers of patella tendon. Very safe portal, but this is your extra hand. Okay.
Yes.
Now, outside in. I am not going to demonstrate outside in. No, this is yeah. Sorry, inside out. Sorry, my mistake. So I'm not going to demonstrate this because Subra sir beautifully showed this already. But now, if you want to miss the popliteus tendon, you can take a bite there and then miss this and take a bite here.
Yes.
And you know you are not catching on it.
Yes.
Worst case scenario, nothing happens if you hold on it. That is what at least literature says. But my favorite here is to try and keep everything inside. So I will do the, first this one. I will do my all-time favorite, the knee scorpion. For meniscal repairs, the knee scorpion is the best because, no, the trajectory is different. Trajectory, Vishal, it should come towards, because it is extremely low profile. And always use a cannula like this when you're using it, because otherwise the anterior fat pad suture should not come and fall on it. Okay. So I'm going in like this. We shall extend a little bit. So as I want to go back, this is one more trick. As I want to go back, you extend the knee a little bit. As I want to come front, you flex the knee a little bit. Okay, stay there, stay there. Hold this slightly. We'll remove that bubble so that it's clear.
What suture you are using, Bhupesh?
This is a fiber wire and 20 fiber wire.
All right.
So my first bite is going to be there. I always try to see where I exit. Can you see the
Fantastic.
tip?
Excellent.
And then that is something I didn't like. This missed, I think I didn't load it properly. I will reload it. Hold the candle, load it properly for me. The fiber, what is this fellow's called? The scorpion never misses. I think I didn't load it properly. So I want to go back, stay there. Yeah. Hold scorpion. Give me a grasper.
It's there. You have taken the bite. I think it's not retrieved.
I can pull it out with the grasper. Yeah. No, we saw something small grasper.
So how far away from the tear you are taking the bite?
So
Bhupesh?
intentionally I have taken this close. Bring down the pump pressure. No, pump is too high.
So what is your preferred suture combination? It's a crisscross box or?
Yeah. Always first do a transverse mattress.
So you prefer a transverse mattress
20,
and then?
20, sir, 20. Yeah. So I don't go by great preference. I see how the suture wants to stay and then make a decision based on that. Okay. Now, thank you. Give me this scorpion again. Somebody load it for me. Sir, keep
the bubble is coming in. Just put saber blade inside. I think we will have a clear view.
Yes. So if you are lazy like me, the other way to clear the bubble is outside view. Just open a little bit and close like that.
Yes. Yeah.
Huh?
Good technique.
So again, I want to come as close as possible.
And towards the base of the tear.
Yeah.
Yes, we can see now it's
Yes.
it has retrieved.
Somebody hold the scope for me, sir. Can you hold the scope? Can you come this side, please? Non-pusher.
And just show the
Close the
technique
side.
how you prevent cutting of the cheese, cutting of the meniscus, the cheese cutting by the thread of the meniscus. How do you prevent it?
Yeah, yeah. Now, so, oh. Careful, careful, guys. Okay. Now, suture retriever first. Okay. So this is not uncommon, but don't worry about it as long as you know what to pull. Hold the candle, hold the candle. Yeah. Hold this.
Arthroscopy surgeon loves suture entanglement. Na?
Yeah,
You
yeah,
should,
yeah. Thank you. So one suture is free. Hold this. Hold the other one. Whichever is free now. This one. This is the one which came out. Yeah. Hold this one. Don't let this come inside. Our pump pressure is a little high. So we are. No, still, I don't know what is 20 and all. It's all falling on our face, no? So, yeah, I got that.
Yes.
Now, Dr. Vishal will come and show me this beautifully now with the scope, and I will take the probe. Probe. Where's the probe? Show me the probe.
So this is very important maneuver you can plan when you are planning for all inside or inside out also technique also. With this probe, you can see how you will prevent cutting of the meniscus tissue through, by thread.
Make the knee straight. Operator for me. So, whenever the thing comes out, however irritable we are, always take the operator and put it. Don't push the camera in. It might end up in breaking the lens. I'll take this one. I'll take that. You can just clean that one. Okay.
So all radial tear, Bhupesh, you use the knee scorpion or sometimes you use all inside?
Yeah. I like the knee scorpion in these things.
All right.
And
now we can see.
I would always say, please be versatile, use everything.
Yes. So one thing may fail, you should be used to use of using other device also, other options also.
So now you see this fellow will reduce it for me. He will make sure I don't cheese cut through.
Yes.
Make sure I don't over tighten it and all that. This is my third hand through the transpatellate tendon portal. Now hold this for me. Thank you. Sometimes my third hand will become the lateral portal and my viewing will come from transpatellate tendon. It depends on case to case.
All right.
Here, right hand there, left hand here. Okay. Thank you, Vishal. Vishal is, you can see how nicely Vishal is reducing it for me. And now.
Excellent. It's like hair like fracture reduction. Yeah.
Yeah, and I think the principles are the same. You have to reduce it well before you tie the knots.
And this is a very good technique. See, with the probe, he is just putting it there. So that when he's cinching it, it will be whole of the base of the tear will get, and that will prevent also cheese cutting also. You can see. So what knot it's a half inch knot you will put there?
Yeah, you can do whatever, half inch, or if the quality of the meniscus
Sliding.
is very good, I will do sliding.
Sliding.
I'm not very happy about the quality of the meniscus. Sometimes I do half inches. I'm going to try sliding now. If things go wrong,
because cadaver,
excuse me.
sometimes the meniscus tissues are very friable.
Yeah.
Yeah.
So the other trick is, never pull the meniscus. Can you see what I'm doing? I'm bringing this fellow, hold Vishal. Thank you, Vishal. I'm bringing this knot pusher down. This will act as my second stabilizer.
Yes.
I don't pull it from outside and allow a possible chance of things to go wrong. Okay. Yeah, it's okay. Yeah. Just hold it like that. Okay, this is cut through because the quality of the meniscus was not great. Can you see that?
In cadaver, this happens because you see,
Yeah,
most of these tissues are very friable, but these are the techniques.
Exactly.
I think we should know about the principle.
So now in real life, if this happens, you have a bailout. Okay. So you want bigger structures to take this. So I will do this quickly, and then I will now secure this with an all outside in.
All
okay.
right.
I'm going to secure this with an outside in. So I'm just going to push that knot down. Leave this. So in spite of all this, when things go wrong, of course, today we know it is the cadaver, we can blame the cadaver. In real life, you have to get out of it. One more thing is, in real life, if it cheese cuts like this, I know that meniscus is not going to heal. So I will take it off and come. But I'll just show you quickly another trick on how to do this. We will be doing the Mason-Allen principle only. Pull it out, it will come. Just take it out. That's all. Grasper. Grasper for me. Can you give me grasper instead of retriever? Okay.
So
no
you have
problem.
take that suture out. Yes. All
Okay.
right.
So give me the outside needle. I've done it. Give me the outside needle. So I'm going to Can you see that? I'm bringing in an outside needle. Now I'll do a vertical stitch here, and then my horizontal mattress will come behind this. This is like our Mason-Allen principle. So the vertical stitch will act like a mattress, will not prevent cut through of this. Give me grasper or suture retriever.
Nice technique, Bhupesh, to bail out yourself when you are doing
suture retriever.
inpatient.
Sure.
Yes.
So is this? Can you just angle the needle towards me? Just push it down. Push it. No, the other side. No, the other side. Push it towards the. Yes. Thank you. So I got this fellow out. Now, the other needle, please. You can take it out. Take it out. Take that needle out. Other needle with fiber wire you have? We put one needle with fiber wire and kept it here. It's come out. Put it from outside in. So this will be one. I will make one more here and then try to secure the stitch behind this. I would have loved it to be a little inferior. This is somewhere in the middle, but that's okay. Okay, yes, you put proline and it's okay. You put the same thing if you. No, give the same thing. Perfect. Push the leg down. Yeah. There's a thread there. Can you give us one more thread? Thread. The same thing. The same thing. Loop. No, not that. Yeah, thank you. Hold on to this thing. Thank you.
Can you show the inside view, Bhupesh?
Yeah.
Yes, now it's okay.
Now we are just focusing on not losing the outside threads. Okay.
Bhupesh, Harish here.
Harish sir, yes, please tell me.
Yeah, I guess we're just running a bit on time. We'll just go ahead with a couple of talks and then come back to you once you finish that. Is that okay?
Sure thing. I think that is the right thing to do.
Yeah, okay. We'll join you soon.
Yeah.
We'll come back to you, Bhupesh, okay? Yeah.
Sure thing.
Thank you, Bhupesh, sir.
Yeah.
We'll go ahead with the next session on PCL.
Dr. K.N. Subramaniam, Dr. P.C. Jagdish, and Dr. Yashwant
I thank Dr. Harish Chandran, Dr. Nirmal sir, and Dr. Rajiv Raman sir for chairing the session. I would like to welcome Dr. Balliappa. He'll be giving a presentation on PCL anatomy. And I would like to call upon stage Dr. K.N. Subramanian sir, Dr. P.C. Jagdish sir, and Dr. Yashwant. Audio.
Hello.
Good afternoon, everyone, and thanks for having me here. I'm going to start with a very basic topic, that's the anatomy of the PCL. The PCL, as we know, is one of the main central stabilizers of the knee joint. It's an intra-articular structure. It is also extra synovial, as it is covered by the synovium. We all know the PCL originates from the anterolateral aspect of the medial condyle of the femur within the notch, and it inserts onto the posterior aspect of the tibial plateau, approximately 1 centimeter distal to the joint line. On an average, the length of the PCL is about 32 to 38 millimeters with an average cross-section of approximately 11 to 13 millimeters. PCL is also the strongest ligament of the knee joint and has a maximum tensile load of 739 to 1,627 newtons. The average surface area of the PCL attachments on the femur is about 209 millimeters square, and on the tibial footprint is about 243 millimeters square. As a result, the insertional sites are roughly 3 times larger than its width substance. The PCL consists of 2 functional bundles. The larger one is called the anterolateral bundle, and the smaller, the posterior medial bundle. Arthroscopically, Dr. Laprade and his team have found distinct osseous morphology on the distal articular margin as well as the condylar notch. And there are three distinct points that are available along the distal articular margin. The first one is the trochlea point, which is the highest point on the distal articular margin. As you keep coming down from the highest or the trochlea point, the cartilage begins to, as it comes down more posteromedially, it starts straightening out, and that the central part of that is called as the medial arch point. And continuing along the articular cartilage edge, the most posterior extent of the cartilage margin of the medial femoral condyle is termed as the posterior point. There are three distinct osseous landmarks also on the medial condyle. The first one is the medial intercondylar ridge. This constitutes the proximal borders of both the bundles, the anterolateral and the posteromedial bundles. There's a medial bifurcate ridge on the medial condyle, which marks the separation between the anterolateral and the posteromedial bundles. A palpable and a visible osseous prominence is always present adjacent to the medial intercondylar ridge at the separation of the anterolateral bundles, and it is called the medial bifurcate prominence. There are certain anatomic landmarks on the tibia which indicate the anatomical sites for the PCL. It is located, the attachment is located below the articular surface of the tibia in a sulcus between two osseous prominences, which are the posterior aspect of both the medial and the lateral tibial condyles. This sulcus is called the PCL facet. The PCL tibial footprint is divided into two planes by a horizontal ridge, which is called as the bundle ridge. The lateral limit of the bundle ridge, the articular cartilage of the lateral tibial plateau, exhibits an abrupt dislolateral turn termed as a lateral articular point. The posterior aspect of the posterior horn of the medial meniscus has something called as shiny white fibers, which are anteromedial to the anterolateral bundle. The distal lateral corner of these fibers is another point called as the shiny white fiber point. The medial side of the PCL is bordered by the osseous wall descending distal to the medial tibular plateau, and it is called as medial groove. The distal portion, the distal border of the PCL is often described relative to the prominent ridge at the posterior aspect of the tibial plateau, and it is called the champagne glass drop-off, and that is the distal border of the posteromedial border. Keeping all these anatomical landmarks in mind, the anterolateral bundles classic anatomy is like this. The area of the bundle is between 112 to 118 millimeters square. The center of the femoral aspect of the anterolateral bundle footprint is about 7.4 millimeter from the trochlea point, 11 millimeters from the medial arch point, and 7.9 millimeters from the distal articular cartilage. And its tibial attachment is located 6.1 millimeters posterior to the shiny white fibers of the posterior medial meniscus root, 4.9 millimeters from the bundle ridge, and 10.7 millimeters from the champagne glass drop-off. The posterior medial bundle, the area lies between about 60 to 90 millimeters square in size. It is located between the anterior and posterior meniscofemoral ligaments. The femoral footprint is the center of which is located 11 millimeters from the medial arch point and 10.8 millimeters from the posterior point of the articular cartilage margin. The tibial attachment is located 4.4 millimeter anterior to the champagne glass drop-off and 3.1 lateral from the medial groove of the medial tibial plateau. So this diagram indicates the footprints of the femoral footprint of the anterolateral bundle and the posteromedial bundle and its center point from different osseous and cartilage points. And the picture below is on the tibial footprint. Another two important ligaments that accompany the PCL are the meniscofemoral ligament, the anterior meniscofemoral ligament, or the ligament of Humphrey, which slants across the distal aspect of the PCL in the flexed knee. It is attached on the distal aspect of the PCL on the femur and is very superficial. Its distal attachment is to the posterior or the lateral meniscus. The posterior meniscofemoral ligament or the ligament of Risberg, this extends from the medial wall of the femoral intercondylar notch and the posterior horn of the lateral meniscus. The femoral attachment is proximal to the posteromedial fibers of the PCL and it is superficial to the PCL. when viewed from the posterior aspect. Thank you.
Thank you, Dr. Pillappa. Let's move on to the next talk, which is about MRI diagnosis and decision making in PCL injuries. Dr. Rahul to do.
Good afternoon, everybody. I'm Dr. Rahul. I'll be speaking on decision-making in PCL injuries. The talk would be, okay, so coming off, so I'll be talking on the following headings: mechanism of injury, clinical examination, imaging, and management, both non-operative and operative. Coming to the injury pattern, it's usually either a blow to the front of the proximal tibia, particularly when landing heavily in the front of the flex knee, particularly in sports injuries, or it could be a forced hyperextension, wherein there is a more significant injury, which means to say that there could be an associated PLC injury also, or it could be a dashboard injury. Coming to the clinical examination, what we should not miss is the PCL laxity, or if there's an associated combined posterolateral laxity. Okay, so the classical physical sign which has been mentioned is normally the anterior tibia should have a step off when compared to the distal femur. So as you can see on the picture on the right, the anterior step off is lost. This is the classical physical sign which can be checked with the posterior sag test or the Godfrey test. The top one with hip and knee in 90 degrees of flexion. So you can see compared to the opposite knee, okay, you can compare where the proximal tibia is. Okay, the other test which is normally done is a posterior drawer test. Give a posterior thrust to the proximal tibia. Check, what you need to initially check is where exactly the tibia is stationed. So you need to correct whether that step off is there or not. You need to check and then do your posterior draw test. A reverse Lashman test is another way in which we can check it out. When we are thinking in terms of a combined injury, then the tile test becomes important. Put the patient prone, knee in 90 degrees of flexion, and give an external rotation to the foot or to the lower end. So that's called as the dial test, which is positive at 30 degrees of flexion in case of a PLC injury, and positive at 30 and 90 degrees in case of a PCL plus a PLC injury. So that would help us in finding out if there's any associated posterolateral injuries. In case of a chronic PCL injury, the patient will be able to demonstrate a quadriceps active test. When you ask him to actively contract the quadriceps, the tibia which is stationed posteriorly comes forward, correcting the sag which has been present. In a few cases, with the help of stress radiographs, particularly in the kneeling position, wherein the whole of the body is giving an anterior thrust and the tibia is being pushed posteriorly, the stress radiographs can be taken. So the measurement is usually done by a line drawn along the posterior aspect of the tibia. Extended superiorly, you draw one more, mark the point at the posterior end of the Blumenstadt's line, and the distance between these two is considered the side-to-side difference. If it is greater than 7 mm, we should consider it as a partial PCL tear. If it is between 8 to 11 mm, we need to consider it as an isolated complete PCL tear. If it is greater than 12 mm, it is indicative that there is a combination. It's either a PLC or a PLC or a posterior medial complex injury also. So with regards to the clinical grading, okay, so the first picture shows the normal one. Grade 1 is there is a posterior sag, but it is still in front of the distal femur. Grade 2 is the posterior sag is just obliterated. So it is at the level of the distal femur. In grade 3, it is completely posterior. Grade 1 and grade 2 are usually in case of partial tears. Grade 3 is usually a posterolateral complex plus a PCL injury. So coming to the imaging modalities, MRI is considered as the most accurate diagnostic modality, but only for acute PCL injuries where the sensitivity and specificity is nearly to the extent of 100%. It's not the case with chronic injuries. In acute tears, you can either find a focal discontinuity either at the level of where the attachment to the femur, or it could be a mid substance, or in a few cases where there is a tibial spine avulsion, you might be able to find that in the X-ray. So you will be able to find that in the MRI also, the tibial avulsion which is there, and the PCL is lax and redundant over here. So in case of a chronic tear, the PCL being extrasynovial has a very good tendency to heal. It heals, but it heals in the lax position. So you might find that the PCL is still present on an MRI, but clinically it is not functioning. So how do we find out that? In a sagittal image, if the AP diameter of the PCL is greater than 6, less than 6 is considered as normal. So greater than 7 is considered as there is probably a healed PCL which is still lax. So it's present but not functioning. So coming to the management per se, the acute PCL tears, non-operative management. Indicated in cases of acutely isolated grade 1 and grade 2 injuries. In a grade 3 injury also, we can try for a non-operative management if the patient is mildly symptomatic or is a person who is doing only low demand activities. There should not be any injuries to the secondary restraints, or in cases of a non-displaced or a minimally displaced PCL avulsion fractures, a non-operative management still works. As I said earlier, PCL has an intrinsic ability to heal. This usually is accomplished in a lax position. So our main work would be to make sure that the PCL does not heal in the lax position. So with the advent of these static or the dynamic braces, which help in pushing the PCL forward, pushing the tibia forward, so there is a good tendency for it to heal in the proper position. Rehab with focus on quadriceps strengthening is very, very important, and avoiding open chain hamstring exercise or for at least up to 3 months. The bracing may have to continue for up to around 12 weeks, so approximately 3 months. Coming to the operative management, particularly in case of multi-leg injuries or displaced PCL avulsions, what we need, it is important to make sure what the patient's demands are. So if there's a PCL repair which needs to be done, it probably can be done with the help of a scorpion or something, take a bite with the PCL and fix it onto the medial femoral condyle. You can augment it with the help of suture tapes. If there's a PCL avulsion, an option of fixation with screws or a fixation with suture tapes is also, suture fiber wires and a button in front is also available. With regards to the reconstruction, we can either do a single bundle or a double bundle. There's a lot of controversy with regards to which is best. In a single bundle, the only anterolateral bundle is reconstructed, whereas in a double bundle, both the anterolateral and the posterior medial bundle, helping in near native knee kinematics and better rotational stability. So that's a flow chart. I've divided it. So if it's an acute tear, grade 1 or grade 2 can be treated non-operatively in the initial part. If the symptoms are present, then we need to go in for a PCL reconstruction in grade 2. If it is not, then we can leave it alone. Grade 3 usually requires early PCL repair or a reconstruction. If it's a combined injury, this is where the problem arises. So if there's a vascular injury, that takes preponderance. That needs to be taken care of first. Then you might at the same time do an early PLC repair and then plan for a reconstruction at a later date. If there's a posterolateral coronary injury without a vascular injury, then probably you need to take care of the other ligaments also, the ACL and the MCL, either with bracing or a reconstruction. So coming to the decision making in chronic PCL tears. So a PCL deficient knee, it has been found there's an increased incidence of medial side osteoarthritis and changes in the patellofemoral joint. So leading to the medial compartment OA is commonly seen, and associated increase in the meniscus injuries also. So because of the PCL injury, the posterolateral structures might also become more lax because of the excessive strain. So the patient might develop a varus thrust gait. So we need to get scanograms done to rule out any varus alignment. And in those cases, we might need to do a HTO, probably a medial open wedge HTO, to make sure that correct the posterior slope also, and thus we may have to check later on whether PCL reconstruction is required or not at a later date. If there are any other ligament injuries, we need to reconstruct those. So the last flow chart. So if there's a chronic PCL tear with a varus alignment, we may have to do an HTO and then go in for a PCL reconstruction. With an isolated PCL tear with minimal arthrosis, then again go in for a PCL tear after a period of rehab. Combined injuries, if there is combined injury, rehab him first. Arthrosis is mild. Reconstruct all the ligaments unless there is a contraindication. So to conclude, non-operative management has picked up particularly for the PCL with the bracing option being available. Nearly all grade 3 injuries and some grade 2 lesions will benefit from from PCL reconstruction. PCL reconstruction results, surgery results are pleasing, but less predictable than ACL reconstruction. Thank you.
Any questions for Dr. Rahul? If no questions, then we'll move on to next talk on graft.
Thank you, Rahul, sir. We'll just get back to the cadaver lab for the final few steps from Bhupesh, sir.
So can you hear me?
Hello, Bhupesh, can you hear us?
Yes, yes,
Bhupesh?
yes.
Yeah, so shows what you have done.
What I have done is, I have done an outside in stitch to stabilize the meniscus here, right in front of the popliteus. This one.
Oh, yes, yeah, we can see that, yeah.
And gently down, gentle.
So the outside is the periphery.
Sir,
and,
sir, are you speaking, sir? Kane, sir. So this one is a vertical stitch. Now this one prevents cut through of this stitch that I have taken to reduce the radial tear.
Yes, yes.
This is like Mason-Allen principle. Because when I first put this, when I first put this stitch, this one cut through from this part, if you remember.
Yes,
when
yes,
I first initially showed. That. So I have made these two outside in stitches because there was one small, just to show how it came, I took this one. Then another one properly, I've taken this one. Now this stitch prevents cut through of this. Now I can do a decent radial tear repair, and you can see the radial tear repair is now neat. And the popliteus hiatus is not too constrained. You can see how the radial tear is sitting in place.
So, just one point to clarify, there are two stitches you have done, isn't it?
One sir, is this one, no, this one, this stitch you're talking about, the smaller one.
Yeah, the smaller one is going to the...
No, the smaller one is because when that cut through, it made a tear like this.
Okay, fine, we got it, yeah.
When the first stitch cut through from this point, it disturbed a lot of meniscus here. And we had time because talk was going on. So we put one to make it look nice. But the intentional one, what is required is this stitch.
This stitch which is stopping the ripping of the...
Yeah, this straight stitch, which is stopping the cut through of this perpendicular stitch.
Okay.
Because this area is too cheesy.
Yes, yeah.
That's all, sir. And that area, I didn't want anything because that meniscus is decent. If there also it goes out, I will put one more stitch from here to here, hold that one, and then put this one.
Okay.
I can put one more here, one more maybe here to there also, if required. But the ideology is a vertical stitch to prevent a horizontal stitch cutting through.
So this one, have you done in the outside in technique or inside out technique? What did you do?
This one is
for the-
outside in technique.
Outside in
in
technique. Okay,
Yes, sir.
fine. Yeah.
Anything anterior to the popliteus, you can do outside in technique.
Yes, yes. Okay.
And if you see the outside view, here, can you show this part? Sir,
Yes,
the
we
key line, key connect. And as you had morning showed us, sir, the nerve is here. So if you are in the level of joint line, not above and not below the biceps, you will not hit the nerve. And by doing outside in lateral meniscus anterior, I'm always more comfortable than inside out because I know the exit will not go down. With inside out, I'm always little worried that the exit can go down.
Yes, yes. Yeah, more predictable for not
More
having damage to
predictable
the
for
current.
outside in because I want to miss the nerve and then first pierce the skin. Then inside I can manipulate.
Okay, okay.
Sir, anything else, sir? Shall I take leave?
So it's a very good principle. What you have demonstrated is very nice, and how to stop the ripping of the original stitch is also very nicely done. So it's a big clap
Thank you,
for
sir.
yeah. People are all clapping for you, Bhupesh. Very nice.
Thank you, sir. Thank you,
Thank
sir.
you
Thank
very
you, sir.
much. Okay.
Thank you, Vishal. Thank you, sir. Thank you, team.
Thank you, Bhupesh, sir. We'll get back to the PCL session. I would like to call Dr. Girish Chandra, sir, on stage. He'll be talking about the graft choices in preparation.
Good afternoon. My talk is on graft choices for all the ligaments. It could be ACL or PCL or whatever ligaments surgery we are doing. In generally, I've covered this topic in a very small thing, and I've tried to condense it for 7 minutes. So the graft choices, there are various graft choices. This includes the allograft, autografts, and synthetic grafts. So today I'm going to talk only on the autografts. So autograft, what is an ideal graft? The ideal graft should be biomechanically, it should be similar to the native ACL, native ligaments. It should be easily harvested, and it should not cause morbidity at the harvest or the donor site, and gets well incorporated with the tissue or the bone. So among these, the BTP stands the first. The BTP is one of the oldest ligament was used in the ACL reconstructions. I think many of the younger surgeons might have not seen the BTP harvesting of the graft. So when 2005, when I started my arthroscopic career, the BTP was the graft of choice, and many centers in UK only the BTP was done, and hamstring was occasionally done in few centers. So it is a gold standard for the ACL reconstruction, and BTP is time tested. So just a small video of BTP graft harvesting. So usually the harvesting is done in knee flexion of 90 degrees. So 2 parallel lines are marked about 1 centimeters apart. The ligament, the patellar ligament is cut, and then the 2 drill holes, around measuring about 1 centimeters apart is drilled. So this is to take the stitches to pull the graft inside the joint. And the very important point you need to be noted is you need to use a saw which is thin. So some of the handheld, the battery operated saws the blades are very thick. So you fracture the bone plugs. So use a very thin saw and use osteotome, a flexible osteotome. Again, the flexible osteotome is very thin. So by using this, you can avoid the fracture of the patella as well as the fracture of the bone plugs. So after harvesting, usually you harvest the patellar plug first and then the tibial plug so that it may not fall down. So after this, you need to take a stitch into the preformed hole of the bone plugs. So this is how it looks when you see in the hand. So the next is the advantages of this bone-patellar bone grafts. So it allows faster healing in the bone internals because the bone-to-bone incorporation is much faster than the tendon-bone interface. The long-term results, the 83% of in a 2 years follow-up, 83% of the people will have a near normal or a normal knee strength, and it is easy to harvest. The failure rate, the load failure is around 1,785 newtons. The disadvantages, as you know, it's a long incision. It's a minimally invasive incision where you incise around 8 to 10 centimeters in front of the knee, and anterior knee pain is very common. the risk of patellar fracture, risk of tibial tuberosity avulsions, and increased chances of OA when compared to the hamstrings. Why? Because whenever you harvest the graft, some people have tendency to suture the ends of the patellar tendon. So never suture that, leave it free. So once you leave it free, the pressure over the patellofemoral joint will be less, so that the risk of osteoarthritis will be reduced. So the complications, as I said, the patellar tendon rupture, fractures, all those things which I mentioned, difficulty in lean. And other thing is there is numbness because of injury to the infrapatellar branch of saphenous nerve, and should be avoided in patients who are uses their knee as a kneeling down position for their day-to-day activities. So the next comes is the hamstring graft. This is one of the, again, most commonly used graft nowadays. So this includes semitendinosus and gracilis. Some of them are only semitendinosus and a combination of these two things. The advantages of this, there is no injury. It is a very, very minimally invasive. There is no injury to the bones or injury or the fractures. And the graft site morbidity is less. The load failure rate is around 2,422 newtons. So disadvantages includes, see, it is you are harvesting a semitendinosus, which is a stronger flexor of the knee joint. You may reduce in a highly competitive athletes, the power of the flexion may be reduced. So that's why, again, this is one of the disadvantages. Injury to saphenous nerve, when you are harvesting, if you put your scissors deep inside, you may injure the saphenous nerve and the patient will have numbness over the anterior aspect of the leg. So the long-term results of 2 years follow-up, there's 75% of the people will have a near normal or a normal range of strength in the knee. Re-rupture rate is around 17% when compared to 7% in BTV, whereas in hamstrings, the re-rupture rate is around 17%. So this is, again, the harvesting technique. This is my own technique where I inject 10 ml of saline into the bursa. So once I inject this bursa, inside the saline, the bursal surface, the sartorius fascia gets elevated, it bloats. So you can easily pick up with the Adson's forceps and dissect it. So once you dissect, there is no injury to the underneath tendons, and you can easily dissect it. This has been published in, just everybody knows how to harvest. Just I want to show this portion, how I dissect the sartorial fascia and harvest the tendon. So like this, yeah, I harvest. This has been published in Evidence-Based Medicine in 2019. So this is called hydrodissection. So the indications recently many of us are moving to quadriceps tendon when compared to peroneal tendons. So again, it is very commonly used nowadays. It's quadriceps tendons are used whenever we need a very large ACL, when there is a large ACL footprint. And the people who rely on the flexors of the knee, like splinters, athletes and laborers who spend more on their knee flexion and extension, like people who squats a lot. So such people need hamstrings. So that's why the quadriceps tendons has been used. So this is how we harvest the quadriceps tendon. The knee is kept in flexion. Around 1.5 centimeters incision is made over the anterior aspect of the thigh, and the incision and mark the tendon, and incision of about 1 centimeters breadth is taken, and it's incised. It is detached from the patellar tendon. So just a small video. So then the stitches are taken. I cannot fast forward this. So just a whip stitch is taken, and so use a closed stripper to harvest this one. The open stripper, sometimes what happens, it cut through the tendon. So that's why I always use a closed stripper to harvest this one. So everything is done in knee flexion. Whenever we keep in knee flexion, it will be very tight. That quadriceps tendon will be very tight, and it will be very easy to harvest. So incise it beforehand, at least whatever the tendon is available, which is visualized, cut with and dissect the undersurface, whatever the structures are attached to it, detach it, and use an closed stripper. So this is a closed stripper. So push and pull technique, push it inside gently, So once it goes inside, it harvests the entire length of the quadriceps. See, you get a very thick graft. So advantages, lack of the less risk of infection when compared to hamstrings, injury to the saphenous nerve. Again, it is avoided, low donor site morbidity. One of the disadvantages is prolonged quadriceps weakness and extravasation of the fluid whenever you are not stitching it properly near the joint. And sometimes you may have a rectus femoris retraction. So the peroneus, everyone knows about the peroneus graft harvest. Just I'll fast forward it. And why nowadays most of the surgeons go for peroneus longer quadriceps graft is because it decreases. See, some people argue for the peroneus longus, and some people are not with the peroneus longus. For the why it is not used is because it is a powerful flexor of the first tray of the foot. So that's why the people who are in competitive sports who uses their foot like sprinters, the first tray where the push-off phase is weak. So that's why in a long-term results, the push-off of phase of the first tray is weak. That's why many people are not harvesting the peroneus graft. And also in long-term studies, there is weakness in the ankle instability. It may cause ankle instability. So that's why many of us have moved to quadriceps graft. So disadvantages, hypoesthesia, then in 2 cases they were reported as compartment syndrome and transient peroneal nerve palsy. The graft preparation, so I'll just speed up. Allografts. So allografts are used whenever you need a multiple in a multi-ligament injuries, when the ligaments are less, when the graft you need more of ligaments. So during that time, allografts are used. And patient preference also you can take it into this. Advantages, less surgical time, predictable graft size, decreased morbidity, and multiple types of grafts available. Disadvantages, cost, infections, diseases, transmission, delayed incorporation, higher failure rates, and lower return to sports. About 43% failure rates are there. Thank you.
Thank you, Dr. Girish Chandra. Sir, quickly, can I ask one question?
Yeah, please.
Yeah. So you said peroneus longus harvesting will cause compartment syndrome, 2 cases. Just highlight on that, sir.
No, it has been suggested because of the bleeding from the surrounding tissues. I think it has not been clearly mentioned in the article. Only it is said that it can cause compartment syndrome, and even the peroneal nerve palsy. If the harvester, when you push the harvester inside, it should be directed towards the fibula rate. If it is going posteriorly, it may cause injury to the peroneal nerve.
So if it is isolated grade 3 PCL injury, what is your first graft choice?
I usually use
primary.
I usually use a quadriceps tendon rather than a peroneus longus.
Suppose if it is a posteromedial injury along with MCL, you are doing a PCL reconstruction, what would be your?
If it is an acute injury, I try to repair the MCL first.
Chronic, sir.
Chronic.
Reconstruction.
PCL with, if hamstrings are there or any other graft, the last choice will be the peroneus longus for me. Thank you.
So we'll next call upon Dr. Sandesh for his talk on posteromedial portals.
Good afternoon, everyone. I'd like to thank Dr. Sharath for this opportunity. And my professor is here, Dr. Naresh Shetty, still makes me nervous. Anyway, so my talk is on posteromedial and posterolateral portals of the knee. Once considered the dark side of the knee. So not anymore because of a lot of cadaver studies, and we have now know the safe zones. So this is a nice cadaver study that was done in the University of Louisville in Kentucky, where they said that you can safely establish 4 portals on the medial side. This is on the posteromedial aspect. All right, A, B, C, and D.
the only. So A is the soft spot between the tibia and the femur, gastrocnemius tendon, and the semimembranosus tendon. But you can see the picture on the left with the highlight with the black marks. That is the saphenous nerve. So what they found out in this study is that A and B, that is A and B, can be established with without any issues. But then D, if you go inferior, then you're hitting on the saphenous nerve, and C, you're piercing through the gastroc tendon. So if the portals are not positioned properly, if the saphenous nerve is injured, then all these patients end up with saphenous nerve neuritis. It's quite they always keep complaining of these neuritic kind of pain on the medial aspect of the leg. All right. Then you can see on the picture on the right, the C portal, which goes to you can see the arrow mark there, goes through the gastroc tendon, the medial gastroc tendon. Again, these patients can have prolonged period of pain in the posterior aspect of the knee. All right. Again, so you can see the picture in the middle there. Once you enter the posterior medial compartment, the MFC is medial femoral condyle. That's the adductor fold, the gastroc fold, and the semimembranosus fold. What this paper said was we can safely establish 2 portals, which is sufficient to do most of the work at the back of the knee, where you want to have access to the back of the knee, be it root repair, be it ramp lesion, be it PCL. All right, mind you, these are all 5 mm cannulas. All right, so they can safely put 2 portals. So we just quickly move on to the video of establishing this portal. I'll go back. You can see we can marking the posterior medial portal. This is the left knee on the medial side. You can see now what is more important is how to get to the posterior medial compartment. I think the take-home message from this talk will be how to get to the posterior compartment. If the PCL is absent, it's quite straightforward. Now just go through, and then you can you'll hit the posterior aspect of the knee. Now the problem arises when the PCL is intact and you still want to get to the posterior compartment. That is when Gilchrist maneuver helps, where you have to go underneath the PCL and the medial femoral, between the medial femoral condyle and the PCL, and then you can go to the back of the knee. All right, we can let's watch this video. Marking of the posterior medial tunnel, as I said, is the medial aspect. PCL is absent in this case, so that's the medial femoral condyle. Make way there, then you can just drive the scope through, and you're almost there. So you can see the gastroc fold. Palpate from outside the soft spot before you insert the needle. Just make sure that you're in the right place between the back of the medial femoral condyle and the gastroc fold. Insert the needle. So inserting the needle is very important. So you'll have to plan beforehand how many portals you want. You want 1 or 2, and plan accordingly. All right. If you want to use 2 portals, you can put the needle a little lower and then plan for another one superiorly. All right. Now, once the needle is there, you just railroad, put a Wissinger rod, and then now you have access to the back of the knee. This is okay. Now coming to the safe zones for the posterolateral portal. Posterolateral portal is still probably a little more difficult to establish compared to the posterior portal. We have the lateral collateral ligament, IT band, biceps femoris, and more importantly, the common peroneal nerve. I think common peroneal nerve isn't the back of everyone's mind when you're doing this. So, but if you know the landmarks, it's quite safe. The common peroneal nerve is at the lower end, posterior to the biceps femoris tendon. Okay, so you can see in this picture, the cadaver study here, LCL, the lateral, you can see the biceps femoris, IT band. There is safe place to establish a good posterior lateral portal as well. All right. Now we'll go on to the video and see how we establish the posterior lateral portal. There are various ways where you can establish the posterior lateral portal. First, I'll demonstrate the inside out. I've established the posterior medial portal like how I showed you in the previous video. Once you've established the posterior medial portal, you can use a Wissinger rod and always visualizing from the anterior aspect. You can see it here. I've established the needle, portal is established. Then once you can drive the Wissinger rod through the septa and come out on the lateral side. So this is inside out technique of establishing the posterolateral portal. All right. So otherwise, you can also use an outside-in technique where you can use similar to the posterior-medial establishment of the posterior-medial portal. We can visualize the posterior aspect of the knee joint and then use a needle to establish the portal. What is more important again? So if the ACL is intact, if the ACL is torn, it's again quite straightforward to enter into the posterolateral compartment. If ACL is intact, that's when it is tricky to get into the posterolateral compartment. All right. So what you can do again, like similar to the Gilchrist maneuver, go underneath the ACL and between the lateral femoral condyle and the ACL, and then drive the scope through. You can reach the posterolateral compartment. All right. So this is we saw this part, establishment of the posterolateral portal inside out. Then as I mentioned, we can use the needle from and then establish the posterolateral portal from out using the outside in technique. All right, quickly you can see we put the Wissinger rod from the medial side, taking it out to the lateral aspect. So this bit shows how to go into the posterior portal when the ACL is intact. All right, so we push the ACL aside, then gone to the posterior aspect of the knee. You can see the Wissinger rod there. All right. Another, you can see this is the picture showing where to establish the posterolateral portal. This picture shows there's a potential space triangle between the ACL and PCL. We can go through this space and enter the posterior compartment to visualize the posterior compartment to establish the portals. Right. Thank you.
A very nice demonstration of the transeptal approach.
Yeah, transeptal. Yes, thank you, sir.
Any questions, please?
Right. Thank you.
We'll move on to the next speech, which is going to be by Dr. Madan Balal, going to tell about all-inside PCL reconstruction recorded live surgery.
Thank you, Dr. Sharath, for the invite. Since most of my co-speakers have covered most of the topics, I'll straight away go into the surgical aspect. What is this here? So all inside PCL reconstruction. So I'll divide my talk into, first is the portal, then I'll come to graft harvesting, then the femoral tunnel, tibial tunnel, and then the graft resting. So this is examination under anesthesia. You can see here, I'm testing the posterior lateral corner. You can see there's a posterior lateral corner injury also, along with PCL. Coming to the portal placement. So first I begin my scope with high anterior lateral portal. Then the operating portal will be the anterior medial portal. So then usually I use 5 portals. And when I come posteriorly, it will be 2 portals. One is a high posterior medial portal and a low posterior medial portal. So this high posterior medial portal becomes a visualizing portal and the low posterior medial portal becomes a operating portal. This is for the tibial tunnel. And anteriorly, there's a low anterior lateral portal. So these 2 portals are for the femoral tunnel I'll be using. So I'll move the. So these are the portals. Now I'm doing an anterior medial portal. Once I've done the anterior medial portal, I do a diagnostic round, confirm my diagnosis, see any associated injuries. Once this is done, then you can see the next video. This needle is from the low anterior lateral portal, which is coming. So this is for the femoral tunnel. I keep testing the trajectory, whether to go inferior or through the superior portal. Now I come transcondyle, I come posterior medial. So these are the two portals I established for the tibial tunnel. One is the low posterior medial portal. So this is the operating portal for the tibial tunnel. So I place two cannulas here. One is, both are 6 mm cannulas, which I'm going to place. This is the high posterior medial portal, which I'm establishing. Try to move it a bit. So you can see the Wisinger rod coming in. And you can see the outside picture also, where I push the 6 mm cannula into the portal. So there's already the inferior portal is established. So I have two portals for the tibial tunnel. So graft harvesting, Dr. Grish is already spoken, so I'll try to move it a bit. So I take two grafts here, semi-T and as well as gracilis for the PCL, and for the PLC I use the, for the PCL I use semi-T and as well as the peroneus. For the PLC I'll use the gracilis. So once this is harvested, I'll show you the preparation for the all inside. So here we pass the graft between two loops of the button fix, and both the ends are held with the zero fiber wire. So you make it into a closed loop. And here there's a triple bundle of PCL, the peroneus, as well as the semi-T. So it's totally a 6 bundle graft where you hold with the zero fiber, all the strands are held together with circumferential loops are passed. So there's one loop on the femoral side and two loops on the tibial side. So usually on the femoral side, it's always around 2.5 millimeters of socket is created, whereas on the tibial side, it is around 30 to 40 mm of socket is created. So I go to the femoral tunnel preparation. Here I'm viewing through the anterior lateral portal, and the operating instrument is through the anterior medial portal. So I am preparing the femoral tunnel now. So once this is prepared, you can see the high is the anterior lateral bundle, low is the posterior medial bundle. So assess the bundles. This is the footprint. So here, closer to the anterior lateral bundle, I'm going to make the tunnel. So it should be close to the articular cartilage. So here I'm viewing through the anterior lateral, low anterior lateral portal, and I'm operating through the high anterior lateral portal. See here I split the footprint. So the graft saddles into the footprint. I'm using a spade tip guide wire, which drills across the medial femoral condyle, which comes out through the outer cortex. If it's a 10 mm graft, I always do a sequential reaming. It is 6, 8, and 10 millimeters reamers I use. So up to a depth of 25 millimeters. So now I'm using the 10 millimeter reamer. So once this socket is done, the edges are blunted out with the shaver. So then I deploy a number 2 ethibond in the femoral tunnel. Here I create another space between the ACL and PCL. So to get the suture of the piece, the tibial tunnel through this. See, this is the creation of the tibial tunnel. Here I'm weaving through the superior posterior medial portal and operating through the inferior posterior medial portal. Here I clear the septa, and you can see in the tone PCL, I debulk the tone PCL. So once this is clear, I go to the lowest point of the PCL attachment. So you see how low is the PCL attachment here. So you try to create a tunnel at the lowest point of the PCL attachment. So you get the complete length where the graft sits on the remnants. So you need to debulk a bit. Then I use a cautery to mark a point where I have my tibial tunnel is going to come now. So you can see here, I'm just marking that. So here I'm weaving through the superior portal and the inferior portal is doing the work. So once this is marked, then I use a rasp to freshen the edges. So I freshen the edges of the footprint. So once this is done, the tibial jug comes into place. So that sits on the lowest point of the tibial attachment. The guide wire is there now, which you can visualize. Then I use a 4.7 mm reamer to create a tunnel. So I can pass my all inside reamer through that. So now you can see a all inside reamer which comes anti-clockwise where the phalanges is closed. Once it comes, then once it starts rotating clockwise, the phalanges opens. So you ream inside out. So you can see it's open. Now you ream inside out up to a depth of 40 millimeters. So then you take out the suits, you clear the edges. So you can pass through the tibial tunnel also and blunt the edges with the shaver. So now we've seen, I've taken the suture out through the low posterior medial portal and I've placed it there. So I come anteriorly through the anterior medial portal. I've gone between the ACL and the PCL and I've take the suture and I shuttled it out through the anterior lateral portal. So now I'm viewing through the anterior medial portal. So I take both the sutures from the femoral tunnel as well as the tibial tunnel and I shuttle it out through the anterior lateral portal and I place it there. This is the graft placement now. So you can see that the number 2 ethibond is in the tibial tunnel, which will take the the femoral side of the endobutton into the femoral tunnel. As I'm viewing through the anterior medial portal, I will see that the endobutton crosses the tunnel. Once it flips, so it's going through the femoral tunnel. Once it flips on the outer cortex, then I reduce the graft into the femoral tunnel. Now you can see to the depth of 25 millimeters, which is marked on the graph. So this reduces, and now you can look at the tiger fiber wire, which takes the tibial side of the endobutton into between the ACL and the PCL and goes posteriorly. Try to move it forward. See it stay. Now you can see the endobutton is shuttled through between the ACL and PCL. And now my camera comes into the posterior medial portal, and you can see it's entering the tibial tunnel through the posterior medial, through the tibial tunnel, and it comes out through the anterior aspect, and the graft sits on the remnant. So once this sits, then you can see the outside picture where I tighten the endo button on the tibial anterior part of the tib. Here you can see anteriorly the graft is sitting between the split where I made a split on the footprint, saddles into it. And now I tighten from the outside. And you give an anterior thrust and you tighten. This is the post-op. Thank you.
Very nice. Step-by-step demonstration of all this. But you routinely do all inside only, or doing routine technique or the other technique?
I do other techniques also. Once in a while I do all.
What is your indication for all inside?
There's no indication as such with PCL. Any PCL also, most now I've shifted from outside, like most of my cases are all inside, both ACL as well as PCL.
Is there any specific advantage or conventional?
Yeah, see here, as a conventional PCL, you require a graft length. So most of the time we fall short with the graft length, and you have to fix it with the screw. Peroneus, but you get only, and it's a 6 bundle. So you get a length of only 10 centimeters or 9.5 centimeters. So you get in the tibial socket, you get only 30, and on the femoral side, it's only 25 millimeters. So intra-articular, it is most of the time it's 3.5 to 4.
What is diameter of the graft? How much?
It's around 9.5.
Yeah, I think you definitely will get 9 mm easily with this type of technique. Yes, yeah.
You killed the killer
So it's better to go as low as possible than stay higher, because once you drill, when you're high, you become more anterior. So the killer tunnel is more when it's placed more anterior.
Any other questions from anyone? Thank you. Thank you, Madan. Thank you for your excellent demonstration. I think we thank all the speakers of the session. And we are coming to the conclusion of the session. Yeah. Thank you,
Madan
everyone.
sir,
Thank
and
you.
Thank you, Subramanian sir and Ishwan sir, for chairing the session. And now we'll go ahead with the much awaited inauguration ceremony of the program. Center. It's an honor to call all the dignitaries on the dais. We'll start with our founder patron, Dr. Naresh Shetty, senior professor, an eminent leader, mentor, and he has mentored more than 1,000 orthopedicians here. I would like to call Dr. Naresh Shetty sir on stage. I would like to call Dr. Bharat Raju sir, Secretary General, Karnataka Orthopaedic Association. It's an honor to have you on stage, sir. And I would like to call Dr. KP Raju sir, President, Bangalore Orthopedic Society. We'll start the ceremony with the invocation song. It will be sung by Dr. Namrata.
Shri Mahaganapate Shri Mahaganapate Surapate Shri Mahaganapate Surapate Siddhi Vinayaka Namostute Shri Mahaganapate Surapate Siddhi Vinayaka Namostute Shri Mahaganapate Karan Shrit Jana Kushala Vicharana Vishwa Vandita Charana Karanamam Kripaya Pahi Shubha Varanavadana Janati Arana Bhavatarana Vigna Nivarana Varaguna Sapa Sani Pamagama Pamagamari Sa Gama Pani Pamagamari Sari Samaga Pamani Pasani Risa Nisani Sani Pani Pama Pamari Sari Riga Gama Papa Dadani Nisa Sari Gamari Sani Pamagamari Nisa Mamari Sari Sa Ma Pani Sani Pani Pani Samamari Sari Shri Mahaganapate Surapate Siddhi Vinayaka Namostute Shri Mahaganapate.
Thank you, Namrata, for such a melodious rendition. So now, with the blessings of Lord Ganesha, we'll go ahead with the light lamping ceremony. With this amazing start to the first Bangalore Knee Conference, I would like to call the organizing chairman, Dr. Sharath KR, to address the gathering.
So, very warm welcome to all of you. I welcome all of you to this first Bangalore Knee Conference. When we had the thought of doing this, I discussed with Dr. Naresh Shetty sir. He is my mentor from last 12 years. From the day I joined Ramaya, till the time I was staying in Ramaya, sir was mentoring and guiding us. So I requested Naresh Shetty sir, Dr. Satish Sharvegar sir, and to be the patron for this course, and also to Dr. Sanjay Pai sir. They agreed. The concept was to have a focused meeting of the particular part of the knee. So in that way, we decided to have a PCL and meniscus this year. So after we decided, I requested Dr. Bharat Raju sir and KP Raju sir. So they really supported, and they helped in patronizing this with the Bangalore Orthopaedic Society and also Karnataka Orthopaedic Association. That really gives support for any conference to have a support of the association, which is a state level and also the level of this Bangalore. So I thank both Bharat Raju sir and KP Raju sir. So with that concept, we started. Since it was very short notice, we decided to have a cadaver session. So hopefully we will be continuing to have some particular topics and to continue to have the recent advances of the knee surgeries. So with that, I thank all of you, and I thank Bharat Raju sir, Naresh Shetty sir, and KP Raju sir for having here, and they out of their busy schedule, they've come here and they supported and for this inauguration ceremony. So I thank you all three, sir. And with that, I request Bharat Raju sir to say a few words, and then Shetty sir and KP Raju sir.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. Respected seniors and my dear friends, I bring greetings from Karnataka Orthopaedic Association on behalf of Dr. Edward Nazar sir, KOA president, who is unable to attend this meeting. The efforts of Dr. Sharath are seen in the audience. So he was a little skeptical when he wanted to start this course. I think specialty courses like these are a flavor of the day. And I congratulate Dr. Sharath and his team for a wonderful program which has been drafted out. I'm sure it's going to be very informative and educative. And I wish this is going to be an annual event henceforth. And we'll be there with Dr. Sharath in supporting this event here on. Thank you so much.
I would like to call Dr. Naresh Shetty sir to give his pearls of wisdom to the gathering here.
It's nice to be in the gathering of young crowd, and I really feel young actually. Sharath actually has called me only twice in his lifetime. One, when he wanted to start his family, he said, "Can I go ahead?" I said, "Go ahead." And now he's got a successful family life. And then he said, "Sir, idondu knee course ಮಾಡ್ತಾ ಇರ್ತೀನಿ. Are you ready for coming?" And said, "What do you think?" I said, "Go ahead, don't worry, you'll be successful, don't worry. Once you're done the family, this should be just a cakewalk." So that's it. Anyway, congratulations, Sharath, for a brilliant effort in such a short time. Number two, in our days, Uday and all are there. So we're all interested more about things around the hip. Interestingly, we are all young and, so the crowd was young and we also looked at a lot of things. So everything around the hip was interesting for us. But suddenly I find that the younger generation are more interested in knee. They came down and I'm not sure why. And so maybe that's the flavor of the season for the young crowd, and maybe it's true. And keep it going, no problems, absolutely. We'll stay at the hip and you stay at the knee. And the best things can happen around wherever it is, okay. The third part which I wanted to say was that most of us were talking about scopies. In our times, we used to go open, and now you closed it and just had an open window. But I think right from our ancient times, when Vatshana talked about certain things in life and said, you also look through the window, you also look through the window, and all the good things you can see through a window, you cannot open the door and see it. So keep it up. I will not tell you what you're talking about, but that's how it is. So I think you need to keep things interesting. Only then and then only I think we'll learn. And most important for the younger crowd, I want to say that we must learn. We must unlearn and then probably relearn. One of the fascinating part of this thing is, I always say that in a conference, there are three kinds of people that usually come in. The stalwarts, they're wandering around the stalls. There are more people inside. Then there are outstanding people. They stand outside only, they never come inside. And there's a third group, is the Nirvana group, which is always in deep meditation with a good AC and all, they go to sleep and come with a lot of this thing. Here I saw none of them, and that itself is a great feat. Thank you, and keep it going, and thanks, Sharath and team. Have a wonderful time. Thank you.
Thank you, Naresh Reddy, sir. I would like to call Dr. KP Raju, sir, on the dais.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Greetings from Bangalore Orthopaedic Society, and I congratulate Dr. Sharath and his team for this wonderful CME on knee, and good to see that there is lot of subspecialties doing good with the mother, that is IOA, and under the banner of KOA and district Bangalore Orthopaedic Society. It's nice to see that, because previously they used to do on their own. Now it is in one umbrella. Thank you for that. Thank you very much. My humble pranam to the dignitaries on the stage, off the stage, faculties, junior consultant, and everyone. And all the best to Dr. Sharath and his team. Thank you. And one announcement, because the last 2-3 days are there, whoever is not member of Bangalore Orthopaedic Society, KOA or IOA, KOA and IOA, it is done online. So if you can register now within 3 days, so next year you can vote, and second, you will be the member in this year only, because next week we have got general body meeting of IOA. So please do. Online registration is there. Kindly do it at earliest within 3 days. Thank you very much.
Thanks a lot, sir. Thank you, Naresh Reddy, sir, for gracing the occasion. It's an honor to have you, Bharat Raju, sir. Thank you, sir. Thank you, KP Raju, sir. I would like to call Dr. Sharath, sir, to give the vote of thanks.
So I thank Dr. Bharat Raju sir for coming all the way and gracing this this inauguration ceremony. And I thank Naresh Reddy sir, and I thank KP Raju sir and for coming all the way and gracing the ceremony. And I thank all of you for coming here, and I hope there will be a fruitful discussion, and I will continue to have this type of scientific sessions in future. Thank you, everyone. Sir. Thank you, sir.
With this, everyone must be hungry by now. We'll move for lunch, and we'll be back in another 40-45 minutes.
Check, 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 check. Hey, check, check, check. Check, 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 check.
A very good afternoon, one and all. Hope you all had a sumptuous meal. So we'll be moving ahead with the next session. It is PCL reattachment of an avulsed PCL fragment. This will be demonstrated by Dr. Chirag Thwanse. I would like to call Dr. Madan Balal sir, Dr. Chidanand sir, and Dr. Rohit Ponnanath sir on the chair, on the dais to chair the session.
Chirag? Chirag?
Chirag sir, can you
Hi.
hear us?
Yeah, I can hear.
Chirag, can you hear us?
Yes, am I audible?
Chirag?
Hello. Kindly let me know if I'm audible. Madan sir, kindly let me know if I'm audible.
Chirag sir, can you hear us?
Yeah, I can hear. Am I audible?
Yeah, Chirag.
Yeah, am I audible?
Yes.
Yes, sir,
Chirag.
you're audible.
Yeah, fantastic.
Can go
So
on.
we are back after the interval for the second half, and the movie gets exciting there. So here we are after the superb demonstrations of all the meniscus. We are in the PCL session, and I would be demonstrating the PCL reattachment. Of course, the PCL of this gentleman is intact, so I'm going to be in situ demonstrating the PCL reattachment technique. Now, first and foremost, I would like to thank Dr. Sharath and the entire organizing team for hosting this wonderful event. And it was lovely to see all the doyens of arthroscopy of Karnataka this morning present there with all the enthusiasm and zeal. Now, this basically, I'll run through the few steps. While we were waiting for all of you guys, we have done a few things here. I have Dr. Sumant, Dr. Akshay, Dr. Pratima, and half Dr. Madhuri assisting me for the case, which will probably make my things easier. Quickly, let me run about the portals. Am I clear here?
Yeah, Chirag.
Yeah, if the vision is clear, let's quickly look into the outside picture, please. So in a PCL, by rule, I take 4 portals, maybe PCL attachment, PCL reconstruction. I would take a standard anterolateral portal here. I would take a kind of a lateralish and a superiorish medial portal, which will be more towards the midline. Outside picture, please. I would take a standard posteromedial portal, and I would take a posterolateral portal. Now let me look at the picture inside. This is my ACL and PCL. How do I put my scope into my posteromedial portal? I would drop my leg down. This will give me a better trajectory to enter the scope. Flex it a little bit, please. Since this is a cadaver, it's a little tight. Okay, can you see this? I have easily entered my scope through the ACL and PCL window. The window what I've created here is between the ACL and PCL. Can you see that? That's the ACL on the lateral side, there's the PCL on the medial side. I seep in my scope here inside, and I'm in my posteromedial compartment. Now here, I would then flex my knee to 90 degrees and then readjust my scope according to my needs. Here we are. I have already put the portals. I have already put the cannulas. If I can just run through a few things here, okay, a few landmarks to be kept in mind. One, as we enter here, you will find a fold of synovium, and my portal will be superior to that. Can this be appreciated?
Yes, Chirag.
Yeah, so this is the synovial fold, and my portal, posteromedial portal, is just above that. Of course, this is a cadaver, so it's not that great, but of course, we can well appreciate that. Next comes the root of the medial meniscus. If one can appreciate here, the root of the medial meniscus is seen here, and that is a medial femoral condyle. So this is a triangle I form, and my scope will be here. Next, what do? I need to enter into I need to have a portal on the posterolateral side. So give me a Wissinger rod, please. So keeping this portal intact, I would then take a Wissinger rod, the sharper end of that, I would introduce it through my posteromedial portal, and then just go, and hit a spot on the posterolateral side. Can I have this picture outside, please? On the lateral side, please, camera 2. Fantastic. No, camera 2, here. Huh?
Yeah.
It's been shown? Fantastic.
No,
so this is where it comes. The landmarks what I need to keep in mind is my biceps tendon here, and my peroneal nerve will be below that. So until unless I'm above that, in this sweet spot, this is my fibula head, this is my biceps tendon, that's my common peroneal nerve, and I'm in that sweet spot where my trajectory is right. Can you see that inside picture? When I put in my scope here, I should just be flush to the posterior part. Now, what next I do? One would like to, hey, no talking, please. I would like to release my posterior capsule. This is the most important trick, and this is the most important step. So as we're working here, I would put my Wissinger rod through my posterolateral portal, who ask my assistant to hold the capsule out so that I do not damage any neurovascular structures. Then I put my RF here, enter the RF through the posteromedial portal, visualizing I do not have a 70-degree scope here. If somebody has a 70-degree scope, that would be ideal. I would then probably start releasing the capsule way down. You may encounter some small bleeding here, small bits of bleeding. Since I've already released this, it's a good habit to keep your RF probe facing towards yourself so that you do not damage any sort of neurovascular structures. I would then release the capsule, go down till I see my, can you see that? That's my soleus. Can you see that?
Yes.
Can I get a revert back from the?
Yeah, Chirag, we can see that.
Yeah, fantastic. So if there are any queries here, I could take that. Dr. Rohit, Madan sir, anything added on at this point, I would be glad to take the feedback, and I probably would do that accordingly. So we clear out that. Now, what do we do next? I would remove my scope from here. Put a Wissinger rod, please. Shift my scope. Since I have my cannula in place, it becomes easier for me to shuttle my scope in and out, as in where I want to see. Okay, here I am viewing to the posterolateral portal. That is the PCL stump. If somebody can appreciate that, that's my PCL stump. So I would take a probe. Can somebody see that PCL?
Yes,
I
sir.
usually take a posterolateral portal because from here, I'm visualizing it end on. I am not using that driving in the wrong side. I am driving in the right side. I am seeing this portal from this portal as it is. That makes my body and mind work in sync rather than having a mirror image which is seen on the posteromedial portal. If you see here, this is the footprint of the PCL, and I would like to go still a little lower and clear out these tissues. We will do that. Shaver, please. I'm using a shaver here because these are tough tissues. I'm not able to get rid of them so easily. It's a cadaver, but kindly make sure that you're not using the shaver very aggressively when it's in a live surgery of a alive individual. Okay, I'm just making things faster here. One could well use an RF probe and kind of release all these fibers, release all these adhesions. I'm going down. My visualization should be as much as 1 centimeter below the joint line. Here we are. Now let me just quickly look at where the joint line is. The joint line is somewhere there, and I am well below that. That should be good. I can now take a jig. Can somebody give me a jig, please? I will shift my portal again. So the only thing
can you
about
hear
this,
us?
yeah.
Chirag, before placing the jig, can you show the landmarks once?
Landmarks of the PCL?
Yeah.
Yeah. So definitely, I would love to do that. So here we are. I am in the posterolateral portal. Through the posteromedial portal, this is the root of the medial meniscus. This is the medial femoral condyle, and that is the PCL stump. That is the PCL stump here.
Okay.
That's the PCL stump here. That is the PCL stump here. We need to remember that the PCL, as we saw in the talk, what Dr. Belyappa beautifully described the anatomy of the PCL. PCL is a wide kind of a reverse champagne bottle structure, which has a broad attachment to the tibia, and that spans beyond the midline. It is the 30% of your fibers or 50% of your fibers is past the midline. So it's very important that we clear out these inter septum of the two chambers and then go past midline. Here I'm going past midline. That's your capsule. That's your PCL. If you want to see the PCL, I will demonstrate that as well. This is a PCL fibers. Can we see that? That's the PCL fibers running there. It's a degenerative knee, so it may not be as good as an individual. So can you see that? That's a PCL fibers, and that's where we are. Okay. So now let me quickly shift. I'll just clear off these debris. Let me make visualization a little better. Let me just clear out this debris, Little tough tissues here, since it's a cadaver, but I'm okay. Great. That goes there. I'm able to kind of, are we able to appreciate? There's a little bit of fatty infiltration into the PCL, but if you see this kind of mild vascularity there, that's your PCL. That's your PCL. That's your PCL fibers. Here we are. Let me just clear out this as well. Let me just clear out a little bit of this debris. I'm going down the capsular attachment. Dr. Sharath has graciously given me 20 minutes to finish the surgery. So let me see if I can speed on up. Here I am. That's the capsule. I'm going down here. Resecting out there, using that fibers. That's my capsular attachment to the PCL, just below the PCL. And here you are, soleus. So I am good with this release. I wouldn't want to release much for the benefit of the youngsters. See my probe. Probe is always facing towards the articular surface. It's never facing outside. And this is your PCL fibers here. These are the PCL fibers running medially. Now let me shift my scope and let me introduce the jig. It is very important that you have a good switching stick because it makes your portal switching easier. I am switching into the anterolateral portal. I need to visualize that because we have an intact ACL and a PCL. My jig needs to go between that window. I'm here. Where's my jig? My jig is placed at about 70. Here we are. This is the window between the ACL and PCL. My jig goes there. And here I am. Now this is going to be the lateral tunnel. So I'm going to make two tunnels on either side of my PCL stump. So this is going to be my lateral tunnel. I am placing it here. This is the 10 millimeters mark. I'm going to go down there at the 10 millimeters mark. Can I have a shaver, please? I'll clear out those debris there so that my vision is still more clearer. Yeah. Is the inside picture clear enough, Dr. Madhu sir?
Yes, Chirag.
Yeah, fantastic. So I am going to clear out a few tissues here so that my vision for the audience becomes a little more clearer. I'm very thankful to my ex-fellows to come and give me a helping hands. They're my hands for today. Since I'm growing old, they told Chirag sir, we'll give you a helping hand. And I have Dr. Pratima also, who is a young dynamic arthroscopic surgeon here in Bangalore, assisting me. Here we are. So I have placed my jig or guide a little lateral to the footprint of the PCL. Now what I would do, it is about 10 millimeters from the joint line. Here it is. We have kept it at about 70. Can we have a knife, please? Outside picture, we will take a oblique incision so that we can accommodate it a little better. Here we are. Place it firm. Give me a Vissinger rod, please. I would then ask, Vissinger rod, please. I would then ask somebody to hold the capsule away from the site. Okay, hold it, please. Fantastic. Can I have grabber board next? Yeah, it is locked. Can I have a tunnel drilled? I mean, guide pin drilled. Dr. Pratima, can you help me out with that? Mallet? Okay, we're there. Not yet. Are you finding it hard? Yeah, somewhere there. That's fine. I think that should be good. It's just hitting on that. The jig mismatch maybe sometimes. Okay, let me just take a tap. Tuk tuk. That's fine. Give me my mallet. Out with this. Chuck. It should actually exit through the center, but for some reason, it's not exiting out through the center. Let me see if I can just mallet it, but I could, Dr. Pratima could just see that. Yeah, it should have exited out by now. No, no. Mallet, please. Going in, out, pull it out, please. There's this gentle mismatch there between the jig and the, can I have it again, please? No, remove that. Remove the guide pin. Chucky. The guide pin should ideally exit in that slot there. Dr. Sumant, can you just help? Yeah.
Chirag, are you using a flexible guide wire and a
Not
reamer?
a flexible guide wire. It's a regular beath pin. Sometimes it does happen with the usage of the jig. It can be a small mismatch there. Okay. Can I have it again? Can I have the We'll take, come on, firmly attach it, please. Yeah. This is not locking, so maybe that's one of the reasons why. Can I have the tunnel a little more lateral? Yeah, fantastic. Yeah, it is not locking. This jig is not locking. Okay, come on. Yeah. Come on, drill Manpo. No, no, no. We are having a little tough time here with the jig. The jig has a mismatch. Come on, out. Yeah, it's taking some other route, which is not expected, but I'm not sure why. Can I have the jig again? Yeah, come on. That's good. Hold this, please. Put it in the dustbin.
Chirag, what angle have you kept on the?
I've kept 70. So here I am. Okay, fine. There we are. That's my lateral tunnel. Look at that. That should how it should lock. Yeah, come on. The cadaver body also has a very strong bone. Impressed. He must be taking vitamin D and calcium. Huh? Not going? Give me a sharp breath in, please. Give me a sharper breath in. This is the least expected step where you can get stuck up. But of course, without, come on, can I have Chucky? Chucky is inside. Guys, is there a phone? Neeraj? Chucky is inside. Chucky and Dr. Ranji. See the Chucky, please. Yeah, come on. Easy. No. Yeah, yeah, done. Okay, this is what was all expected. Chucky, please. Out. Gloves for Suman, please. Yeah, we are good. Now what I would do once I've exited out here, I would then keep the jig there and drill a 4 millimeters. Can you see the bead pin exited out there? Can I have a tuk-tuk? Mallet? Mallet? Yeah, okay, fine. So now I would take a 4 mm guide pin. Yeah. I would drill a tunnel on the lateral side of the footprint. Keeping this in mind, one could also use a kind of a grabber. Can I have a grabber? One could use this Wissinger rod to keep the capsule apart, away like this, or else protect this with this jig like this. That is what I would do. Come on, drill. Or use a grabber and hold the tip of the guide pin.
Chirag, this tunnel is on the lateral side of the PCL?
Yeah. I'm making the first tunnel on the lateral side. Yeah, come on. Yeah, we can go. Yeah, done. Out. Out, just keep out. As much, 1 second. Don't remove completely. Give me a bead pin, reversed. Since I've drilled a tunnel here, lateral is what? Tunnel, lateral, blue. Okay. Can I have, hold this please. So it's very important you plan your surgery. Can I have the chart there shown? So there you are. In the PCL tunnel, I would use a blue thread for for the tunnel, blue thread for the lateral tunnel, and ethibond for my medial tunnel. So I will show what exactly it is, and I'll show you the importance, why you need to do that. Now here is my bead pin reversed with a kind of a blue thread, and not to lose the hole, out, 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 out. As you are here, out. As that breath pin is exiting out, I'm here. Can I have a grabber? Messenger rod out. Not a, I needed a grabber, not a nice tongue. Here I am. That's fine. I need to catch hold of one of the threads and pull this. Wait 1 second. Retriever, please. Switch retriever.
You
Here you are. Okay. Fantastic. So I have pulled out my lateral tunnel thread. That is the blue one through my posteromedial portal. Now I keep the jig there. As I've kept my jig there, I will then make a medial tunnel which is medial to the midline. Can I have the switching stick, messenger rod? Are people following what I'm doing?
Yes, Chirag.
Yeah, fantastic. Can I have this thing here? Here we are. I'll
Any
hold the
questions
capsule
from the
down.
audience?
I will keep the jig there. Now we need to have another tunnel.
Any questions from the audience?
80 dela Paraj. Are there any audience left after lunch, or are they still having lunch?
All are present.
That's nice. Then I should hear some questions. Yeah, here we are. Hold this. Can I have the bullet? Now this is very important. See, you always use a locking bullet. Can you show the bullet? See, so the first thing why we struggled was they gave a smooth bullet. Especially in these cases, you cannot afford to have a non-locking bullet and to lose your tunnels. Madhuri, come here. Hold. The bullet with the ratchet here, that goes and locks. It's very important that we have something like that. This is the medial tunnel. So let me go middle. Yeah, fantastic.
Chirag, what is the distance between two tunnels?
There's no set distance as such. So I would just eyeball it. I would just be medial to my PCL. Can you see that? That's the edge of the PCL. That's the medial border of the PCL. And I'm in the medial, just medial. Can we appreciate that? That's the medial margin of my PCL. And I am just flush in the medial border. And this is your 10 mm mark. Okay, come on. Yeah, can I have the drill? Second cortex. Are we there? Should we? Yeah. Come on. Give me a Chucky, please. Chucky and a mallet. Go. Yeah. I just lost the track. 1 second. Let me just get rid of this. Dr. Akshay, don't just leave that a little free. Okay. Now let me just have a look at the breath pin. Where is it? Yeah, exited out there. Good. Can I have a grabber? Give me a grabber, please. Out. This thing out. Out. Yeah. I will grab this so that it doesn't penetrate further. Yeah, 6 mm, reverse breath pin. I will always color code my tunnel. Yeah, go inside. Go. out, 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 out. Not fully. This is a blue ethibond. So my lateral tunnel is with the blue colored ethibond. As I'm exiting out, exit out, exit out. It's very easy that we lose the tunnel sometimes and get stuck up with this. So it's very, yeah, out. So I always keep that between, and here we are. The thread. Can somebody rotate that please for me? One second. Can I have it rotated? Yeah, I need to grab that. I would have preferred an eye stong rather than this. Yeah, here we are. So I have done with the half my job. The major chunk of my job is done. 2 tunnels on either sides of the PCL. Can you see that? That's the PCL fibers. Can somebody appreciate that? That's your PCL fiber in between the 2 threads. Since it's an intact PCL, so the PCL fibers are there. Next, what we do, what is important? Yeah. What do you want? Can we just show the outside picture here?
We can see.
So here also, I have adequate space between the 2 tunnels outside. So the tunnel is not coalescing. So I can either use this as a suture bridge later, or else probably there's about, I have about 4 millimeters apart from the 2 tunnels. Now let me go into my intra-articular work of the PCL fixation. Come on. How do I do that? I will show you a simple trick to do that. I would, yeah, that's a PCL fibers. Drop the foot down. Come on, guys. The table is too down. Come on. Give me a loaded, the medial portal one. The medial, can I have that shown? PCL blue for the medial. So if my blue will go with the PCL. I will take a shoulder scorpion. Can somebody show me this? Outside picture. A shoulder scorpion loaded in the center so that I get a luggage tag suture. I would introduce it through my medial, anteromedial portal with a cannula in situ. There we are. That's my PCL stump. I would take 1 suture here. It's not taking a bite. Load it again. Load it again, please. Instruments sometimes is a challenge. Center part. Come on, put it in the center. Put it in the center. Yeah, come on. Give me. Keep another scorpion ready in case this is not working. So here we are. I am taking the shoulder scorpion and taking a bite through the stump. I'm taking a larger chunk on the medial side of the PCL. This doesn't seem to be working. Come on, shoulder scorpion doesn't seem to be working. Shoulder scorpion doesn't seem to be working. Yeah. I'd open this, take a bite. Here we are. I've taken a bite rounding up the PCL. And can I have the outside picture? Outside picture, outside picture. Look at that. I would then put this inside like a luggage tag suture and then pull it. Now inside picture, look at that. That takes the entire stump of your PCL, 1. Now, what I will do is I will take another, one more, ethibond loaded. I'll take an ethibond loaded for the medial side, for the lateral side. Here we are. Can somebody flush it, please? Can somebody flush it, please? Yeah. Okay, fantastic. That's done. Hold this, please. Again, the same replica. I'm going to use it like a luggage tag. suture. Yeah, good. Now what I'm going to do here, kindly give me a eye stong. The blue is for medial or lateral? Blue is for lateral. Blue tunnel. Blue tunnel, lateral. So this goes, no, this goes into the medial side. This goes into the medial side. So the blue PCL medial, here we are. I am pushing it in there. And the ethibond, I'm going to be pushing it in there. Now I would shift my portals again into the posterolateral portal. Come on, guys. I would then retrieve my blue thread. I need both of them. I need to grab both. Yeah, come on. Only the blue. I've got one. Okay. Here is the other one. Yeah, here. I've got that. So this is my medial. And what is medial here? What is medial here in the tunnel, which is medial?
Ethibond.
In the tunnel, ethibond is medial. Hold this. So I will tie this to the ethibond. I'll tie this to the ethibond thread, which is outside.
You
Can I
mean
have the
the
outside
blue,
picture?
Chirag, you
Yes,
mean the
sir.
blue fiber wire goes into the ethibond?
Yes, yes. So tunnel, which is the medial, medial tunnel? Ethibond, no? Okay. Here we are. Can somebody give me an artery, please? Here we are. Sometimes even I do get confused, so I usually write it off so that, and then pull the ethibond down. Here. Okay, fine. Fantastic. Now give me that, give me the eye stong. Or else it's fine. Pull one porche. Okay. Now next, I need to find my ethibond, which is inside. Where is that? Can somebody find my ethibond? Can somebody find my ethibond? My ethibond is in the center. So I need to retrieve this a little bit. It is between my ACL and PCL. So let me see if I can push it a little further. I will then change my viewing portal. My ethibond thread, which is here, that needs to go in. So I will, this is a little tricky part because you are, okay, fine. Now if I can get through yeah. And can I have this thing coming in here? Can I get it coming in here? Am I good? Yeah, fantastic. Done. Now, can I have the outside picture? I have drawn yeah, can we get it tied? My ethibond gets tied to the blue thread. Outside picture, please. Outside picture, please. It gets tied here. Yeah, so PCL avulsion fracture is probably not a very common surgery which we do, not a day-to-day procedure which we do. Can I see that? Can you see that? Coming in. Yeah, fantastic. There we are. So I have had a crisscross configuration here. Let me just show this here again. Can you see that? There's a crisscross configuration of my
Yes,
Can
Chirag.
this be appreciated? So
Yes,
my
Chirag.
blue thread, give me a probe, please. This is the posterior part of my PCL. This is my PCL stump. This is my PCL stump. This is my blue thread going into the medial tunnel and my lateral thread going into the lateral tunnel here. It's a crisscross configuration of my tunnels and my threads. Can you see that? We are just pulling it down. As we pull it down, this is the PCL stump, which is just sitting down. Of course, it's not an avulsion, so I cannot really show an avulsion for you, but this is how it would fix. And next, let me go. You may be having a doubt, like what happens? I have taken a bite where superior. What happens to the threads? Can we see that? See this, this is the PCL. And the threads have gone sunk well below there, down. It goes down like the luggage tag is gone, holding the stump of the PCL in either ways, in either sides of, this is the blue thread and this is the green thread, which is gone down and sitting down into the tunnels. Now next, how do you fix that? I would keep the knee in 90 degrees of knee flexion. Swivel lock, please. Hold this. Knife, please. Hold this. I would usually fix all my avulsions, like my root avulsion, my ACL avulsion, PCL avulsions, everything with swivel lock. I don't like that the suture disc because you may tend to lose the tension. So here we are, SL, 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 SL. Give me a swivel lock. Okay, this is a modified swivel lock. So they have some innovations here. Knife, please. Knife, please. Artery. Outside picture, please. Indenchina Madhuri. This swivel lock is handmade. Okay. Come on. Yeah. I don't think the threads go inside this. Can I get it pulled? Yeah, fantastic. So here we are. This. Wait 1 second. One more. All the 4 threads. Can I have the outside picture? The swivel lock is compromised somewhere. Eyelet. Yeah. Eyelet is sitting now. Yeah. Can I have the outside picture? So here we are. I am going to hold this. I'm not going to over tension it. Just hold it there and introduce my swivel lock. Punch, punch, punch till there, and then lock it with the screwing mechanism. Sometimes if it's an osteoporotic bone, it's better to have your other modalities of fixation. But for me, knife please. For me, swivel lock in younger patients is the go-to fixation modality for these kind of avulsions. Here we are. Of course, this is probably just a demonstration of the fixation. My PCL there, the stump there, and probably looking into the posterolateral portal. Here we are, the threads well seated and with a good tension. If I would just feel for the PCL here, that's your PCL with my sutures well below. This is about the joint line. The tunnels are almost about 10 to 12 millimeters below, and that's a crisscross configuration where my footprint is seated back. That gives me a wider coverage area than having your kind of a parallel configuration of your sutures. Yeah, saying that, I think I should sign off now. Hope I didn't confuse the audience too much with this too many suture managements. Yeah, of course, it's a little difficult surgery to understand and to probably perform. So I think I've done my best to make it look and sound easy. Thank you, guys.
Very nice demonstration, Chirag.
A wonderful demonstration, Chirag sir. Thank you. Yeah, yes. Thank you, Chidanand sir, Madan Balal sir, and Rohit Punana sir for chairing this session. Now we'll go ahead with the next cadaveric demonstration of PCL reconstruction by Dr. Rudra Prasad sir. I would like to call Dr. Niranjan sir, Dr. Chetan Nagraj sir, and Dr. Anand Galgali sir to chair this session.
Dr. Rudra Prasad, can you hear us?
Hello. Hi, Dr. Anand.
Yeah, Dr. Rudra Prasad, can you hear us?
Yeah.
Yeah.
I can
Okay.
hear you very well. And I just came inside and I'm just preparing. So what I
You
suggest
request-
is you guys can finish some of the talks by the time I get ready with this setup. Okay?
Oh, yeah, good.
Thank you.
We'll start with the next talk here. Once you are ready, let us know.
This can go off.
Can we call Dr. Shishir SM to talk on a meniscectomy, partial medial and lateral meniscectomy, pros and cons and outcomes?
Can you load the presentation, please? Good afternoon, everyone. At the outset, I would like to thank Sharath sir for having me here at this august gathering. It's in the laptop. Right. Slide change of this. I think arthroscopic partial meniscectomy is one of the most commonly performed surgery. I think most of us also do it quite often. But how useful it is. Okay, let's go through the indications. Let's see some literature and then have our own conclusion. Change ಮಾಡ್ತೀರಾ? ಆಯ್ತು ಮಾಡಿ. Yes, please. Okay. So the most common indication for which a partial meniscectomy is done is degenerative meniscal tear and also a neglected traumatic tears. Next, please. A displaced or an unstable meniscal tears that are not amenable to repair, especially in the red-white zone and the white-white zone, the complex tears, the segmental tears with concordant joint line tenderness and reproducible mechanical symptoms such as popping, catching, locking are the common indications for arthroscopic partial meniscectomy. The other indications include, change please, the tears which are not responded for conservative management. You wait for a while, you see the patient is still symptomatic, he has classical symptoms and signs, then you go ahead and do a APM. Next, please. The untreated meniscal tears, including macerated tissue tearing, as you see in the picture, has been reported to be a known risk factor for development of arthritis over 2.5 year time, with almost 5 times increased risk of arthritis. That's the reason you do a APM. What are the advantages of it? The one, I think the foremost and the most important advantage which most of us notice is an immediate relief of pain and early return to activity and sports. Apart from this, we now come to the disadvantages which actually outweigh the advantages. It is said that the arthritic changes can initiate as early as 2 to 5 years after a APM. This added to this, there's an altered gait mechanism which happens due to lack of meniscal support. Patients who have undergone partial meniscectomy, especially the medial meniscectomy, have been reported to have increased external rotation while walking, which can overload the cartilage. This small increase in rotation over a period of time may result in increase of progression of arthritis. In an RCT by Goffin et al. In 2014, initially, at the end of 1 year follow-up, he concluded that arthroscopic partial meniscectomy is much better than non-operative management. But at the end of 3 to 5 years, the same authors concluded that all the positive effects of arthroscopic partial meniscectomy had diminished and radiological deterioration had begun in almost all the subjects in their group. Lubran and Etner et al. In 2017 added an inflammatory response theory to this. In addition to the mechanical and the shock absorption function of the meniscus, inflammation usually develops after an injury. This inflammatory response often sets off cytokines, specifically interleukin-1 and tumor necrosis alpha, which can lead to the development of cartilage wear and breakdown. This invariably adds to the pain of the knee. So it's very difficult to make out whether the pain is actually from a torn meniscus or from the inflammation per se, which has happened due to the trauma. Next, please. Previous slide, please. And also there's a, thank you. There's a limb alignment, realignment or the disarrangement which is happening because of the arthroscopic partial meniscectomy. It is well known that in patients with varus knee alignment, there's a greater medial cartilage overload, and the same is true for valgus aligned knees with lateral cartilage being overloaded after APM. There's a huge study, randomized control study, which is called as the Fidelity study, the Finnish degenerative meniscal lesion study. It was done by Shivan et al. In 2013. It was a randomized control study where they had two procedures. One was arthroscopic partial meniscectomy and the other one was a placebo surgery, which was like a diagnostic knee arthroscopy. They included 146 adults with a mean age of 52 years and with knee symptoms consistent with degenerative medial meniscal tear, which was verified by MRI as well as arthroscopically, and they had no clinical signs of osteoarthritis. They were randomized into two groups. They concluded that there was no clinically important difference in pain or the function when APM was compared with placebo surgery. They also inferred that exercise-based physical therapy remained non-inferior to APM for patients' reported knee function. They suggested that physical therapy should therefore be the preferred treatment over surgery for degenerative tears. Another cohort study by Ranjan et al. In 2017 suggested that patients who undergone APM were more likely to have a knee replacement later on during the follow-up as compared with matched patients without APM. High quality evidence suggests that APM does not provide meaningful benefits in patients with degenerative meniscal tears and may even be harmful on longer run. Degenerative meniscal tears are a part of osteoarthritic disease and do not contribute to the symptoms independently or in isolation, and the symptoms are not treatable with partial meniscectomy. If you see this graph, basically, if you put all the severity of progression of degeneration on the x-axis and the y-axis, which represents the likelihood of poor prognosis, and the partial meniscectomy is at the lower bottom of the spectrum, whereas total meniscectomy is the top of the spectrum, the outcome of partial meniscectomy is inversely proportional to the degenerative process which is happening. That means if you want to give an asymptomatic knee, you need to remove more of meniscus of the patient depending on the symptoms. Lesser the meniscus you remove, more function-wise, patient is going to not improve if the condition is worse. So lesser the meniscus you remove, better is the prognosis. That was the conclusion from this. But as the condition of the patient has got more severe effects, you need to remove more and more meniscus to give him an asymptomatic period. That was the paradox. Compared to repair, partial meniscectomy, even though arthroscopic partial meniscectomy yielded significant immediate relief, post-operative relief, Isolated meniscal repairs have better prognosis on a long run. There is high level evidence to suggest that, and there is no contradiction to that. So just to conclude and a take home message, try to save the meniscus as much as possible. The lesser you remove, the better it is. Have your indications clear. Arthroscopic meniscal repair improves significantly the symptoms in isolated traumatic meniscal tears as compared to degenerative tears. No significant difference in functional outcome was noted in degenerative tears with partial meniscectomy as compared to that of a physical therapy. Thank you.
Yeah, Shashir, that was a very nice talk.
Thank you, sir.
Any questions for Shashir? How do you explain the paradoxical effect of removing the meniscus? You say more meniscus you remove, it's better, and in the
Sir,
long term.
It's the x-axis had the severity of the disease, and the y-axis was the loss of can we go back to that, please? That was the severity of. Can we go back to that slide, please? So if there's a severe involvement, you need to remove more meniscus in order to make the patient asymptomatic. So the lesser you remove, the patient is not going to recover. So in the process of recovery, you're trying to remove more and more meniscus, which is more harmful on a long run. So that was the paradox there.
No, I think during the procedure,
yes, sir.
See, removing more and more or less. So when how do we make that criteria actually?
So that's
how much to remove?
Exactly, sir. So that is where this partial meniscectomy fails, sir. You don't know how much to remove. The lesser you remove, better the prognosis. And that's why the graph says that the meniscus is not the only one which is responsible for the pain factor there. There are many other factors which result in the pain, especially in degenerative knees. So there is no limit as to say what is partial meniscectomy. There is no definition to say removal of 50%, 60% is called partial meniscectomy. There is no actual line which separates a near total to a partial.
So, and also the last sentence, whatever says, can we take it? Yes, especially in degenerative tears, elderly people, can we give a trial of conservative management for all of them?
Yes, sir. Yes, sir. That's the thing, because literature suggests that there's no advantage on a longer run with arthroscopic partial meniscectomies. I think in one condition, for example, you have a discoid meniscus tear. That's the condition where a partial meniscectomy works really well.
I think in degenerative conditions of the knee, the only indication will be a locked knee, meniscal tear with a locked knee, which might be an indication for a arthroscopic surgery. Otherwise, just a debridement, as when it has been come in the media and all, it's the most unwanted surgery, arthroscopic lavage, meniscectomy in a degenerative knee. So I think that as a take-home message.
Yes, sir.
Probably the balancing of the knee meniscus during meniscectomy, again, is a very subjective decision taken by the surgeon.
Yes, sir.
Right? And the more damage, the degeneration and damage, obviously you have to remove more meniscus to balance.
True, sir.
So with that, I think with this of late, more and more, the threshold is becoming more and more to do a meniscectomy as such.
True, sir.
So even as it was in the red zone, it has now come to the white zone. As much as possible, we try to save the meniscus.
Yes, sir.
And sometimes they have shown good results even in the white zone also.
Yes,
we have got quite a few high volume surgeons who are doing different types of suturing techniques and trying to save the meniscus, especially in the young adults. So thank you very much, Shishir.
Thank you, sir.
We can go on to the next talk.
Thank you, Shishir, sir. I would like to call Dr. Hemant Kalyan, sir, Dr. Gautam Kodikal, sir, and Dr. Rajkumar Amravati, sir, to come on the dais to chair the next session and the few talks. In the meantime, I would like to call Dr. Dhampal sir for the next talk on reconstruction of lateral meniscus.
Good afternoon, everyone. So today I'll be talking about my first case or very rare case of a lateral meniscus autograft reconstruction. Wait a minute. Shall I? Keyboard setup. When is it? Is it? It is there. So this is a case. See, first I'll brush through the anatomy and biomechanics of meniscus. All of you know. So meniscus tears can cause profound functional, biomechanical, and kinematic derangements within the knee joint, leading to accelerated degeneration of the articular cartilage. So just now, Shishir threw a very good light on about the preserving of meniscus. So here we are discussing about reconstruction of the meniscus. The menisci are a crescent-shaped fibrocartilaginous structures with wedge-like cross-sections that function to deepen the tibial plateau, transmit load through the joint, provide shock absorption, and increase knee joint stability. As a result, any deficiency of the meniscus can lead to accelerated degenerative changes, and resection of as little as 10% of the meniscus can contribute to development of chondral lesions. So lateral meniscus measures about, since I am talking about lateral meniscus reconstruction, we'll focus on lateral meniscus. It measures about approximately 35.7 millimeter in length. The lateral meniscus width is more posterior when compared to anteriorly. And the thickness wise, it is thicker more posteriorly when compared to anteriorly. And study shows lateral meniscus covers up to 59% of the lateral meniscus, lateral tibial plateau. So lateral meniscus are attached to the tibial plateau through their anterior and posterior roots and are stabilized by the popliteal meniscal fascicles, posterior superior anti-inferior, transverse ligament, meniscotibial ligaments, meniscofibullar ligaments, and meniscofemoral ligaments. And the uniqueness of these attachments is it will allow the lateral meniscus to be more flexible and mobile. The role of meniscus roots, very important. It helps the meniscus to preserve the biomechanical ability to convert axial loads to hoop stress and prevent extrusion and decrease the load placed on the articular cartilage. So its effects, the avulsed meniscus roots lead to increased contact pressures on the articular cartilage that is comparable to the forces of a knee in a knee after a total meniscectomy. Clinically, this progress to a rapid progression of osteoarthritis. So blood supply, as all of us know, meniscus has got deficient blood supply, but it gets 25% in the periphery through the middle geniculate and inferior lateral geniculate, particularly for the lateral meniscus. The biomechanics, the load distribution properties of the meniscus allow for greater contact area and decreased contact pressures within the tibiofemoral joint. This is particularly important in the lateral compartment because 70% of load is transmitted to the lateral meniscus when compared to 50% of the medial meniscus. So we'll discuss about our case. It will like almost like a real life surgery. Is a male patient, 32 years, moderately active, well built, not obese, and had ACL reconstruction long ago with near total meniscectomy in 2006. So patient presented to us with on and off pains, and which is quite chronic now, almost 1 to 2 years of time, and he did not had any instability symptoms. His ACL was performing well. X-ray and scanogram were normal. So this is MRI, which shows his previous ACL reconstruction status. And here we can notice there is a absence of posterior horn and body, and there is no root as well. So there is only anterior horn present, no mid body and no posterior root. This is a coronal section showing there is actually no meniscus in the mid body and posterior root. Anterior horn is partially intact. So what are the treatment options? My treatment options were to do a tendon autograft, semitendinosus or perennis longus, meniscus allograft or a scaffolds. Scaffolds are not available with us. You can have an option of meniscus allograft, but the problem is it is expensive and there are certain risks involved. And I discussed all these things with the patient. Patient wanted to go with a tendon autograft. So this is the plan what we made. There are a lot of papers on semitendinosus, and I chose perennis longus for the lateral meniscus because it is thicker and it is more consistent in diameter when compared to semitendinosus. For the lateral meniscus is more thicker when compared to medial meniscus. And also patient did not agree for allograft. The advantages, as I described, elaborated earlier, easily available, no immunogenic reactions, no risk of disease transmission, and reasonably economical when compared to allograft, and technically easier as well. So I referred few papers. So here all the papers are supportive. All the early and midterm studies supportive of transplant survives and adapts to a shape and capabilities to the original meniscus. And yes, it also performs well for all the biomechanics, equivalent to the meniscus. And I chose this particular paper and then went ahead with this surgery. The surgical technique we did in supine position, tourniquet control, the standard anteromedial and anterolateral portals. I harvested the perennis longus graft and prepared it, doubled it to 15 centimeter, obtained length of 15 centimeters, and 6.5 to 7.5 millimeter was the diameter. So 6.5 millimeter, I used it for anterior, as anterior horn is less thicker when compared to posterior horn. So this was whip stitched and wrapped with size 0, and this was soaked in vancomycin. Traction sutures were put, and anterior and posterior bony tunnels were prepared, and graft was passed through the anterolateral portal. At first, graft was dunked into the posterior bone tunnel, followed by the anterior bone tunnel. So graft was properly aligned with the help of bird beak and suture retriever. Mid body of the graft was first fixed with the inside out sutures, followed by fixing the posterior horn with multiple all inside suture anchors, and anterior horn was fixed with outside in suture techniques. Fixations were continued until the stable fixation achieved, and finally I fixed the posterior root and anterior root with suture buttons. Can I have a voice? Is it possible? There. This video has a voice. You don't have a jack. Ilwa?
Dharampal, you yourself can comment.
Okay, sir. I'll make. So this is the graph. So this is the graph which I have prepared. This is the perennis longus. So the point where I'm marking is for the posterior root, P is for posterior, A is for the anterior root, and on that just below my hand I marked L. That comes towards the lateral. So these three are traction sutures. And first I'm giving the outside picture. I'm passing the graft. So we'll go to the. Can I continue?
Please.
Okay, so this is diagnostic arthroscopy. Absent posterior horn and body of the meniscus, lateral meniscus. ACL graft was intact. So I did a good debridement and freshening until I saw some blood. So here we can see there was a residual anterior horn, and I removed that segment completely. Now I'm drilling the posterior transosseous tunnel in the anatomical area. It is size to size match, 7.5 millimeter. And this is anterior transosseous tunnel. So I retrieved the sutures, ethibond for the anterior, and I used ethylon for the posterior. That's actually suture retrieval. Check that there is no suture bridge in between. Now I'm going to pass the graft, the posterior one first. Followed by the anterior. So I brought a bird beak from outside to pull the tension sutures, which I had put 3 numbers in between. With the help of tension sutures and these instruments, I'm positioning the graft properly into the respective place. The first suture what I'm going to use is the inside out meniscal suture in the mid body. And followed by that for the posterior horn and the body, for multiple fast sutures I used. Quite a lot of sutures were required to stabilize the graft. I'm checking whether all are stable. Wherever I felt it is little loose, I continue to use the fast fixes. I made company people happy on that day. The point is, fix the graft as much stable as possible. So this is my assessment of the graft stability. I had to cut the tension suture separately. That was just it was just to assist me to put the graft inside. So this is the post-operative X-ray. So the lateral joint line is maintained, and there is no arthritic changes because of his previous changes, near total meniscectomy. So my post-operative protocol is 0 to 6 weeks. First 0 to 6 weeks is non-weight bearing walking with knee brace and walker, assisted range of movement exercises up to 90 degrees. I even started him on CPM, static quad exercise and SLR exercises. And for next 6 to 12 weeks, now he's only 2 months now since his surgery. He's in his second month. He is toe touch weight bearing and progression of knee bending to 120 degrees and strengthening exercises for the quadriceps. So my next protocol will be after 3 months, after 6 months to be precise, I would like to do a repeat MRI, and at 1 year again post-operative do repeat MRI. Thank you for your attention.
Thank you. Thank you, Dharampal.
Thank you, sir.
This talk will definitely invite a lot of questions there because it's not a very commonly done surgery, and the surgeon has to have a real courage and to do this particular surgery, not very routinely done.
Thank you, sir.
I think there will be a lot of questions which you can take later on. I think, Sharath,
Sure.
if Rudra Prasad is ready. Rudra, you are ready?
Rajkumar, sir.
Yeah. Anand.
Okay, Rudra Prasad, you are
Hi.
audible
So
here.
what's happening? So you have how many talks more?
We have one by Dr. Rajkumar and then one more panel discussion on meniscal.
Okay. See, and now what I have done is I've just harvested the graft for the PCL reconstruction. And just for the understanding purpose, I have not harvested a bigger graft. I've just harvested only one graft. Basic idea is to show the technique because it's a cadaver demonstration. And right now, I'm just preparing the bed where the guide wire has to come. I don't know, all of you are able to see the screen?
Yeah, it's very clear, both inside and outside.
Okay, see now, you just, I think somebody can focus on the outside picture.
Yeah, there is a window which is seen, the outside picture also.
No, what I'm trying to tell you is, see now, this is the outside picture you're able to see.
We can see
Just
both
a minute,
inside
I'll
and
just show you
outside,
because I have kept it in flexion of 90 to probably less than 90 degree. And this is how I do usually PCL reconstruction. It's on a table with a sandbag in the down and a lateral thigh support. And this is in flexion. So I don't hang the leg down and do for PCL. So it's a surgeon's choice how they do it. This is how I feel comfortable. So what you see here is the patellar marking. So this is a standard anterolateral portal, slightly higher, what I'm showing you. And then here, this is again a standard anteromedial portal. This is for the working and this is for the visual portal. This is the left knee we are operating. And I'm assisted with Dr. Pratima and then Dr. Alfie and Dr. Santan. Both are PGs and Pratima is an orthopedic consultant. And now I've already harvested the graft and this is the posteromedial cannula, what you're able to see. So I just took the telescope into the posteromedial between what I call as window 1. That is, window 1 is nothing but, you all can see the medial femoral condyle and you can see remnant of the PCL, which is completely intact. I have not destroyed it, just to make all of you understand what's going up and also to get a good orientation. And this is the ACL, which is there. So it's a tough cadaver. If you can see that the tissues are quite hard here. It's not a very soft cadaver. So I will be little struggling, so bear with me. And this is a window 1 between the medial femoral condyle and the PCL. So what is this fiber and what is this fiber? This is a anterolateral bundle. This is a posteromedial bundle. So you can't really differentiate many a times the junction, but definitely you can make out the lower bundles are the posteromedial and this is the anterolateral bundle. And if you understand, I think since morning we've been listening, majority of the PCL stability is given by this AM bundle, AL bundle, sorry. So whenever we are doing a single bundle reconstruction, we concentrate on this bundle, okay? And of course, recently we had been to Jaipur where the anatomical reconstruction by Rob Laprade was discussed at length, where he feels that always the femoral insertion should be double bundle and then single bundle for the tibia. That is the understanding. But of course, we have literature support for both single and double bundle. That again, in what setup you are doing, what kind of a patients you are dealing with. If you are probably dealing with a high-end athletes, maybe you may have to take all those considerations. But here, so what we are doing is, this is a window 1 and this is a window 2 between the PCL and the ACL. So I've not yet cleared it, but so I'll go to the posteromedial gutter through this window. So I'll have to take it out because this is a tough cadaver, as I said. Just give me a time. So I'll enter. So when I'm entering, so I just palpate with my, this is just a blind procedure, but you have to feel the femoral condyle, and very next to that, whatever is the rent, you can enter there. So once you enter there, you are in the, you can feel sudden roomy feel where your trocar cannula goes inside. And then for your, just to lessen the time, we have already made the posterior medial tunnel, and you can appreciate, if I rotate my light source, you can appreciate the capsule where, you know, the cannula has come from. So this will help for various reasons. And Madan was talking about nice talk and demonstration in the morning. He showed that 2 portals in the posterior medial. Okay, this is a good method because you can visualize in one portal what's happening in the proximal tibia posterior surface, and also one other portal for managing your suture and clearing the footprint and whatever. So what we have done is we have put a cannula, and I tried to show you from here. If you have a 70-degree scope, probably you can see it very nicely. What Rob Laprade has described, this picture which became so popular, that champagne glass drop. So that will be very classically visible. But here, I'm trying to show you from here itself. So we will go ahead and clean this. So I am keeping my shaver blade facing to the tibia, not this way, because you know the reason. This is the capsule where all the vital structures are there. So we will start preparing the proximal tibial preparation. And you can't see completely, but you can definitely feel. And if you are planning to take out the complete PCL, it's no issue. You can also use radio frequency in between so that preparation is quite clear. So that is the upper surface of the tibia I'm touching upon. So now, after some preparation, what I do is I'll shift my telescope to the cannula, what I have put already. So that should be enough. Hold this here. Get the Wissinger rod, take it out fully. You will keep it here. Yeah. So this is quite a tight cadaver. Things are not so easy here. Yeah, hold it there. Yeah. You can take it out and put it there.
Dr. Rudra Prasad, do you routinely remove the PCL tibial attachment when you're doing
No,
it?
I never remove it. Even on the femoral side, also I don't remove it. I just make. Can I come that side? So for this step of the surgery, if you have 2 viewing screen, probably it will be useful, because if I come on this side, I won't be able to see that very well. So you're seeing from the posteromedial portal, and that's my Wissinger rod. Just I have placed it because I'll not be struggling to come every time. So now let me get the shaver. If you have a curved shaver, it's very useful. Okay, see now you can see that the shaver can go quite down. So it's not that mandatory that you have to put 2 cannulas all the time. You can manage with 1 cannula. So under supervision, I'll just go under the footprint of the PCL area. And keep the radio frequency ready. So here, some fibers are coming in the way, which I'll remove for the demonstration purpose so that you all get oriented properly. So there are a lot of youngsters I saw in the morning. So you have to get used to these portals from the anteromedial, anterolateral, especially posteromedial and lateral portals are not routine limit. Suction is not working. Can you put the suction a little bit? Saline also can be better.
Rudraprasad, 2 questions for you.
Yeah.
Number 1, how inferior you want to go from the tibial plateau?
Yeah.
That's the root
So
of the
if you can
meniscus.
see some muscle fibers of the popliteus, you know, that you have gone quite inferior. And Madan also was showing in the morning, you have this champagne glass drop. You can appreciate from here also. If you go down there, so generally the measurement wise, if you use the, you can see, give the PCL jig now. So how far down you can go is by measurements, probably 20 millimeters. If you go, it's a fantastic one. And you can appreciate the PCL now so nicely at the insertion. So basically you can definitely go till the lowermost fibers of the PCL. And the whole point is to avoid being very superficial. That is on the top area. So if you start seeing here, this is the slope what we generally see in the X-ray, and the slope suddenly drops on this area. So what you're trying to see. So if I use this radio frequency, you can definitely appreciate the sudden champagne glass drop. See, from there suddenly it drops. See that? So till here I can see the bone. So probably from here till there it's maybe around 10 or 15 mm, and I can go 15 millimeters, definitely minimum what I would aim for, not less than that, measurement wise. But of course, when you're seeing in the arthroscope, you can definitely see the PCL insertion, and you can place your jig. Okay, get the jig now. So this is the jig by Arthrex. And so we'll come from there only, same whatever. So I'm coming from the anteromedial portal. My jig is going. So this has got a marking. You can see the marking. So it's already 15 mm. So if I go here, probably I'm fine. Okay. And now how medial and lateral is another question. So if you see the medial most border of the PCL fibers, you can see very well. If you stay on that, probably you're right. Or you can try to stay little on the lateral side. So this is almost like 16 mm, you can say. It's even more than that. And we are quite sufficiently down. So Dr. Pratima will come with the jig. Okay, go ahead. So this jig has got a nice pointer here down. You can appreciate where the wire will not come throughout the jig. It will stop there. So by feel, you can go by the feel. I think you're there. Just a minute, stay there. You can rotate the light source, slightly go back. So that, yeah, you can see that. So you can always protect. Yeah, that's enough, that's enough. You can take out this, take out the jig. So my jig will be there. I'm not going to take out the jig completely. It's 8 mm we can drill. So the jig also can act like a protection sleeve so that by mistake, you don't enter the posterior capsule. I hope till now things are clear. But any other way of doing, Dr. Anand, you do the same way or you have any different technique? And Dr. Niranjan, all of you can share your experience. Dr. Hemant sir, good afternoon.
Yeah, we
Nice
have
to
Dr.
see you.
Gautam Kodikal also, Dr. Hemant
Yes,
here.
yes.
All of us, we
So
can share
all
that.
of you can comment about your experience and your way of doing it, while so that it will benefit the audience. Go ahead.
I think Rudra Prasad is similar thing, but as far as going medial
slow.
Or center, what do you prefer in the PCL attachment? You go more towards the midline or more towards the medial side?
Yeah, more towards the midline.
Yeah.
So you have any difference of opinion on that?
Oh, I think that's what I think, that it should be more towards the midline, medial
Yes.
to midline kind of a border, around
Okay.
15 to 20
You can take
millimeters
it out.
down. Yeah.
That's good. Anand, you go the same way? You have any difference?
Dr. Prasad, Niranjan here. So,
Niranjan.
how to determine where
It's not
exactly
yet
we
gone
are?
completely. Sorry, I didn't come again, please.
Yeah, see,
Get the guide word.
when placing the jig,
Yeah.
so how to determine how medial or how center we are?
So yeah, no, I'll tell you.
Any
See,
tips on that?
so we discussed in the morning also that the PCL, unlike the ACL, doesn't disappear completely. ACL, if you see after 3 months, 4 months, you hardly see. Sometimes you'll just see some fibrous tissue. No, you have to drill again. It has not gone through. So you definitely see the fiber, like the way I showed in this case. You saw that whole. You can see it from the linear fiber so nicely from there. It's dropping down and all the way down there. So you can definitely see the fibers like hugging the tibia posteriorly. So you can identify and place your jig exactly on that. As Dr. Hemant also shared, you can just go exactly in the middle portion of that.
Okay, thank you.
One more thing, Dr. Rudra Prasad, do you like to take your tibial jig between the PCL and the tibia, or you would place it on top of the PCL? Or do you want to take it between the PCL and the tibia, between the bone and the remnant of the PCL?
Go again. Come.
When you're putting in your tibial jig,
Yeah, while putting the tibial jig,
do you want to place it on posterior to your ligament, remnant of the PCL that is left?
Yes, posterior to
Or
it. Because see, anteriorly you can't retract it. Otherwise, you'll have to destroy it.
Or would you like to go between the bone and the remnant of the ligament?
Exactly. If your PCL is absent or it is not there, probably we can do what you say in between the remnant of the ligament and then the tibia. But most of the time, what happens? The whole PCL is intact. Okay. So you can go ahead. Yes. Go slowly. Go slowly. Go slowly. Slowly. The last bit, in fact, you can do with a hand, because if you are going with a power drill or something, especially if your assistant is not used to that and they can go inadvertently and puncture, that will be too dangerous. The last part of it, you can use a very slow, controlled hand drill. Yeah, take it out. I think you're in now. Good. Enough. Take it out. Take out the guide wire. Take it out. It's stuck. Even that is stuck. Use the drill. It's okay. No. Use the drill. It's okay. So what has happened is to the jig, this guide wire has gone and locked. You can see that. So probably it was slightly a bigger size and it is actually meant for protection so that the guide wire doesn't pass through that. But Dr. Pratima ate a nice jamun and she was very powerful. So it went in. Okay. Nice. Thank you.
An expert can unlock it very well, Dr. Prasad.
Okay. So now what we'll do is just the preparation of the tibial tunnel, especially the top portion of the tunnel, you try to do some kind of a preparation or blunting or whatever you call reaming, rasping, whatever, so that the killer curve becomes little smoother and there is no bony edge which can damage the graft once you pass it inside. So I think it's very clear now. That's the tibial tunnel. Okay? All fine? So you get the
Prasad.
suture, what we have loaded. Yeah, Anand, come on.
Prasad, one more question.
Yeah.
Getting this posteromedial or posterolateral cannulas inside is quite challenging for the beginners.
Absolutely.
And even not even beginners, even the experienced persons also, seniors also, it's quite a big challenge and sometimes quite frustrating also. Even
Yes.
after you get into the posterior
grasper?
compartment,
Yeah.
the view, the fibrofatty tissues, the clearing and all, it takes a lot of time.
Yes.
So what do you think
What did
of
you-
doing the PCL from the anteromedial and anterolateral portals? Is it possible?
So just before answering your question, let me finish off this, what I'm doing so that people will understand. So I've put a beath pin with the suture there, and I've come from anteromedial portal, withdrawing my suture. All right. So the suture is out through the anteromedial portal and except next viewing through this portal how the graft is. Otherwise, my job with the posteromedial tunnel is finished. So I'll come back now. So to the question of yours, I know it is difficult, but it is not impossible, I think. And posteromedial portal placement has to be learned by any arthroscopic surgeon because, see, I have seen these synovectomies. You know, you can never do a complete synovectomy by open surgery. I'm sure many of the open surgeons will agree because the access to posteromedial and posterolateral gutters is always better in arthroscope. So a surgeon who is deciding to go for arthroscopic training has to be well versed with posteromedial and posterolateral gutters. And it is well established because we are seeing the footprint and everything. It's better always in this approach. So you have any difference of opinion?
No, Dr. Prasad, maybe I think you can briefly explain. So how you enter your scope through the window one, see the posteromedial capsule, and maybe then.
So basically,
you
see,
can
this is the femoral condyle, and this is the window one I was telling you. So in this cadaver, of course, it was difficult. In fact, all of us should be very well versed going in this window. It's not only for this. We are talking about ramp lesion, what in the morning we were hearing. The ramp lesion is appreciated only by this approach. Otherwise, you can never see the capsular and meniscal junction. So this window, you basically, by chance, if you are not able to see that window and opening, probably you can use a little bit of force, but you should know where you're going. Little bit of controlled force, and you can enter between this and the PCL. Certainly, you will land up in posteromedial gutter. And window two, it's only, you know, if you are passing the ligament and if it is too bulky, in this case, it's too bulky, then maybe for suture management, you may have to use it. But here, I'm not going to use this window now, right now. Okay. So probably from here only, we will manage it.
So for the window one, place your scope there with the scope present there, remove the scope, put in the trocar, and then plunge it forward from there.
Exactly. So now, so anterolateral bundle, as I shared it, so this big bulk from here till there, probably. You can say, for understanding purpose, even though they talk in diagrams nicely, this anterolateral bundle, posterior medial bundle, all those things, you can never differentiate them in practicality. So, but what I say for my understanding and for my teaching also, you say 80% of this whole thing is anterolateral bundle from here. So I'm marking this area. So 80% is anterolateral bundle. So in remaining 20-30% probably is your posterior medial bundle. Okay. And see now this guide wire, which is going to come here, is almost near the articular cartilage. You can see that articular. So just probably 1 or 2 millimeters posterior to that, because in this case, we can see nicely. And as the graft has to come, I will prepare by the radio frequency. And I basically create some space so that the graft is comfortably sitting. Madan also showed that he's cutting this fiber so that it can accommodate the new graft which is going to come. You can do all those things. Again, your choices. But majorly, I think one should stick to the basic things like creation of the portal and suture management. That's what is important. So now for this next tunnel, what I'm going to do is give me a knife. So this is an accessory anterolateral portal, which is very, very low. So you can show the camera here on the knee from outside.
Yeah, we are
So
seeing.
what you're able to see. So
Yes,
now
yes.
this is the front of the knee, what you're seeing, and this is the anterolateral portal where we are viewing. And from here, probably little downwards, and you can see, identify some soft spot, and then go with your knife. So I'm going to cut only the skin, not completely deep, and you can observe my incision is horizontal. It's never vertical. If you go vertical, probably you should go upward facing the sharp edge, because your anterior meniscus is there, and certainly it is at risk. So I made my incision there, and so keep the reamer ready. Get the guide wire. Yeah, thank you. Everything is in this position. So just show me where. Yeah, you can see that I'm using this diamond tip drill guide, diamond tip drill from Arthrex again. So you can see that I'll enter that spot which I discussed now. This will also give me an idea how much is the length. So now the length is totally 40 mm. Okay, it's stopping. If I pull it strongly, it will come out. Yeah, get me the reamer. So different people do it in a different way. Of course, there are many ways of doing PCL reconstruction. And for the femoral tunnel, many people do it from outside in or all inside like Madan showed. And you can always see different techniques and then adapt. So now, yeah, you can see that nicely. So I'm planning to send about 25 mm of the graft, quite hard bone. Surprising break. Oh, suddenly went in. I don't know how much I went. So it's almost 40. Probably hope there is a cortex for my, sorry for that. Suddenly it went through. Yeah, if we can feed the suture.
Dr. Rudra Prasad.
Yes, sir.
Would you, at this stage, would you like to view from the medial portal, or you would continue to view from the anterolateral?
I think I can see very nicely. Don't you think, Chetan? See now very, very nicely I can see. And viewing through the medial portal, I don't feel any, I don't see any advantages. So feed the suture here. We will feed the suture again, and then we'll pull it out. Pull it out, pull it out. Yes, stay there. So everything is happening. So because you can go on changing in and out, you can do whatever comfortable, but minimum the better. So there are two sutures. This suture has come from, yeah, you can stay there. No, this is here. Okay. So I'll bring. So now at this stage, probably I can change my portal for the purpose of, managing the sutures. Hold it here. So we'll take, say, Chetan's suggestion. So, but you can do however you feel comfortable. So basically, I want to send all the sutures to one area. Hold there. Somebody is holding there, that suture. Okay, Pratima, give me that. This is the loop. Yeah. Yeah, you're holding that? Okay. So one of you can feed this into this. No, not like that. Hold it here. Just a minute. What the other? I think it is inside, I think. Yeah, full. No. Oh, 1 minute, 1 minute. Create it. One upper didn't give me finally plastic apron. I'm getting drained. Ban agidya. Okay. Yes. Yeah. Now you can see that. So we have one suture going from tibia to the femur. All right. So that's going same suture, whatever we parked and we got it. And this is going inside. And this, at this stage, probably you can go on, preparing some more. Can you mark 40 mm there on the tape? The tightrope tape, you can just mark it. So both for ACL and PCL, I use one thing, that how to confirm the button, whether it is flipped or not, whether it is come out of the soft tissue or not. There are 4 methods according to me. So one is by the feel of the surgeon when the button is going inside the tunnel and then suddenly it comes out. Then you get the feel that something is coming out. One is you can directly visualize like this. And the third is the marking, what we are going to do. Hold this here. Third is the marking. You did it. Okay, 40. Yeah, that's enough. That's enough. So you can show the graft here. Hello. You can just show the graft. So the graft, we are sending it now. And to control the killer curve, you can either use some kind of a Wissinger rod or something. And you can see the marker here. The marker is at 40. Can you mark it a little more dark? You have a dark marker? Because Anand had nice lunch and I'm sure he'll face problem seeing it. What is that? Okay. So you made a note here? Very nice. Thank you. Okay, pull. So now we are pulling the suture threads. Oh, what happened? Got cut. So almost I came, but something went wrong. Okay, we are just there. But anyway, I have to remove it. So we'll have to repeat once again. Just bear with me. If you have some talks, probably you can do it. We'll come back. Otherwise, you can keep watching us. We'll finish it. Get the diamond tip and suture passer. I'll have to come again here.
Rudra, we'll take a break for 10 minutes.
Yes, take a break.
You take your time to
By the time I just pass it, the sutures and be ready.
Yeah, be ready and wait for
Dr.
Rajkumar to finish his talk.
Definitely. I can't see from there.
Good afternoon. I would like to call Dr. Rajkumar Amravati, sir, to go ahead with his presentation.
Bigger. I think my mic can go off because they have.
Good afternoon, ladies and gentlemen. And thank you, Sharath and his team for having us here. And it's a great honor to share our experience with the learned faculty on dais and my colleagues here in the audience. Doing meniscal hollow or autograft is a challenge. And I thank Dr. Dharmpal for, preceding my talk and, making things clear of where we stand with allo or autograft. My charge today, as discussed with Dr. Sharath, was to give some indications and some contraindications about when we do your allo or autograft and what are the limitations, who are the person who traveled the moon first in this space. So if you look at this, all starts when Fairbank first told us that when you inadvertently remove your meniscus, those days, it will cause you an osteoarthritis. And that was very true nowadays. And that is when we started realizing with the campaigns which all the big companies started saying, save your meniscus. The Save Your Meniscus campaign is because we need to have the life of your knee for a longer period of time. The first gentleman who started doing this was Loki and his team, who really did with a proximal total allograft with the meniscus in place. Khan was a gentleman who really had a massive, you can say, list of surgery follow-ups, wherein he did 20 cases with the quadriceps tendon. And we can call him as a pioneer of who pushed the limits to do arthroscopic transplant in meniscus. We all know that the key structure for the knee is the meniscus. It gives us life and what are its function. But what we need to know nowadays is what happens when the knee becomes deficient with the meniscus, and where do we head when the meniscus is not there in the knee. The biomechanical changes, the micro motion instabilities that are there in the knee will cause a lifeline of the knee to reduce, and everybody nowadays wants to be active and on their toes. They need a knee to function well. So yes, preserve your knee for a longer period of time. That will be the basic goal of managing your knee. If you know who are the patients we need to select that need to undergo a meniscal transplant, of course the meniscus should be absent, and you should be a young guy who has got a knee which is in functional capacity without much of malalignment in the knee. And I urge all the august audience who are present here to read this manual by Dr. Lob Rapad and his team. And it is they who have really pioneered in the earlier stages when everything was dark and gray, saying that, yes, this is the line you have to travel, and then do a process called as the meniscus allo or autograft. So kindly get hold of this copy of book and then read through it. There are a few salient indications that have been given in this book and also by the Association of Experts who are really laid down the guidelines for how a meniscus transplant has to be done. Out of the few that are mentioned in the book, it is unicompartmental pain the patient should have. Of course, meniscus should be not there. Age of the patient, they say it is less than 50 years. But if I look at only the age as a criteria, we would not be right in choosing in that way, because there are many other things that you need to look at when you try to do a meniscal transplant. For me, the most important thing that I look at is the alignment of the limb and the cartilage that we see when we put the scope. If I find the cartilage is as smooth as my bald head, I am in for a meniscal transplant. If my bald head has got some ragged surfaces, then I do think about whether this gentleman really benefit with a meniscal transplant or not. The indications will also come with some contraindication that we should be aware of. If the patient is asymptomatic, but you see a knee where there is no meniscus, so you need to know why the patient has come to you and choose your indications appropriately. Yes, if the wear and tear in the knee is not much or it is too much, then yes, that becomes a contraindication. Apart from that, inflammatory arthritis and general contraindication for a knee procedures are the contraindications for knee transplant of a meniscus. Graft preparation, what are the kind of graft that you have to choose? You should be knowing. Fresh frozen graft or a freeze-dried graft. Fresh frozen has a time limit. You need to do within this many hours. So yes, if that is a situation where you are working, or if you are working in a center where that is freely available, that would be the ideal thing to do. But the success rate and the downside of it, everybody should be knowing. And that is what dictates when you use a freeze-dried graft. Because we are living in a situation wherein we don't have access to all of those. Few of us have tried to venture and tried doing an autograft, which is feasible for our patients, both for the purse as well as the way we do these kind of procedures. The graft sizing has to be followed basically by two methods, a radiological method as well as by assessing with CT scans. The radiological methods have been earlier described by Pollard and his team, where they do various kind of X-ray imaging. Both the lateral and the medial compartments are measured. Okay, and based on the percentage of length of the tibial condyle as well as the medial side as the lateral side of the tibial condyle, the assessments of the meniscus can be made and chosen appropriately. Yes, nevertheless, you do your scopy assessment appropriately and then plan your surgeries in a way that is to be done. Now to come to the techniques, there are various ways to skin a cat. On the medial side, preferably, the literature has shown that you can do both with the all soft tissue part of the meniscus allograft or a meniscus allograft with the bone plug. Both will give great results. And on the lateral side, generally, because there is a chance that the results may go down, they want to go on the safer side and try to create a trough for the bone plug that go and sit and then give you a good coverage. We have seen our good colleague, Dr. Dharnpal, very nicely demonstrating just a peroneus graft for the lateral meniscus. You can do in such a fashion also. But these are the literature studies that are available. You should be reading this and then know how these results of whether using only a soft tissue part or only a ends of the meniscus with bone plugs give results. Now, when we do these kind of procedures, we should be also mindful of reading what the outcomes are of these procedure. Any new procedure in the market, we should not be happy to go and put our hands on. Sometimes they are too hot. You will get your hands burned and then you'll cut a sorry figure in front of a patient. One bad patient in your clinical practice will land you in trouble. So kindly work with people who are doing or having these experience of doing this, or attend those kind of cadaver courses or do some saw bone model studies and then try to practice these kind of procedures. The transplant that survives longer is probably on the medial side. You can see that it survives when you do a meniscal transplant. The life can increase of the knee by 8 years. And I'm sure when your knee survives for 8 years, there is many things that you can do, not only by hopping shops, but you can hop many other places as well. Lateral meniscus has got a little lesser life. It is around 7.5 years. That is good enough. And you can see that the patient outcomes, whether you do lateral meniscus or a medial meniscus, allo or autograft, the lifespan is good and patient does have a better outcome. He is thankful in the end for what you have done. But mindful of all the reoperation rates that are associated with any kind of procedure. Even this procedure has reoperation rates, so it is not foolproof. So when your patient comes to your clinic, you sit him down, talk to his near and dear ones, because there are many things that are associated when a graft is being put. The first thing that can happen is the body can reject it. So you should be telling him all the things in black and white. You cannot hide anything when you talk about a transplant to a patient. Rehab is a standard protocol you follow for all the rehab procedures, but the main aim or the goal for you would be to get by 6 weeks a 90-degree range of motion. Weight bearing is always guarded, and then you should have a good rehab team as you need for any procedure that you do on a knee, because as I say always in my lectures, your role in any arthroscopy surgery procedures of the knee is only 50%. You need not boast about what you are doing. The next 25 depends on the patient, and the another 25 depends on the physio that rehabilitates the patient. So having said that, there is always a downside for these things. So you should be very clear in what you are doing with the patient. Autologous grafts have also got the same indications as the allograft, but the advantage is it is less costly on the purse. We can titrate the size of the graft as required because it is a soft tissue graft. We can titrate the length of the graft as we required when we are drilling a tunnel so that we can accommodate the extra length of the soft tissue in the tunnel. When we are doing an allograft, it comes as a pre-designed package. So you have a very little margin of error for you to do these kind of procedures. Whereas with these grafts, you are used to harvesting a semity, you are used to harvesting a peroneus longus, you are also used to harvesting a gracilis. So all those are well known to you. So only thing is you have to just deviate from the near normal that you are doing and accommodate those skills that you have developed already doing a meniscal repair or a ACL reconstruction or a root repair to advance and do a procedure which is called as a transplant. ESCA has clearly come out with guidelines and they have shown that great results can be expected with these kind of procedures. But the earlier papers that have come out with these, especially with Khan and his team, has come out with mixed results. So this is the pioneer who really did the first transplant with the use of quadriceps tendon. This is another paper by Lanny Johnson and John Fusion. There are other groups which are from the American and the Canadian based group which did lateral meniscus transplant. But if you see how the patients were chosen for a transplant, there are the indications which are not of great support for the procedures that we do. So yes, when we read a paper or when we try to do a procedure or read through what a gentleman or a lady has done, you need to see the small print, like what we say in mutual fund. Mutual fund sabhi ke liye sahi hai, but in the end he says dastavez ke adhin hai, meaning the small prints tell about the loopholes in a procedure. Okay. This is gentleman whom we are working with frequently, and we are in touch with them to know how a meniscal allograft or autograft does. And these are the people who have got a long-term result of how the meniscal allograft with the semitendinous is. They have reported great results in the literature, and we are also in the follow-up of our patients, trying to match what people in the world are doing and trying to learn from them, and hope our results in the coming days also will be matching to these guys who have come out with wonderful results, which is economically viable for the patients of our country. Yes, when we do such a procedure, we always want to know, bhaiya, ye natural knee jaisa ho sakta hai? This is the word the patient will ask to you when he comes to your clinic. Ennappa ipdi nalla irukida operation aprom. So all this he will ask, wanting you to tell whether there is a 100% guarantee, whether the load bearing will be guaranteed. So yes, there are studies that have come out and trying to say that yes, the middle compartment pressures are equally normal like the lateral compartment, and the pressure studies done after doing allograft transplant or the autograft transplant are giving great results. So yes, science is advancing. We need to catch up, but yes, catch up slowly. The tortoise and the hare story should be remembered. Don't be in a hurry. Have patience to graduate yourself to doing these kind of procedures. This is an example I would like to illustrate. A young gentleman who is 39-year-old school teacher who waited as long as 20 years to get his ACL reconstruction done. When he came to our hospital, he has definitely a loss of meniscus which he had. There is grade 3 pivot shift and all those things. We counseled the patient. Yeah, we counseled the patient for ACL surgery. And then in the primary case, we did an ACL reconstruction because the cost of the surgery is huge for an allograft as well as for an autograft. We sat the patient down along with his relatives. He's got a young family. Okay. So he said, I'll come back for the procedure second time. So when he came back, alignment X-rays was done. And this is the pre-op X-ray. His range of motion was great. And these are the images to show that there is a near total absence of the medial meniscus. Though he had also on the other leg, the medial meniscus absence, we are going to show you only the full meniscus that we did on this side. So this is how the images will be taken. You read through the images. You already done your scopy. You know how the cartilage is inside. So when you go, this is what you will see, a grade 3 outer bridge cartilage lesion. But if you can see the femoral condyle was good looking. And that is when you make your choice. A 70-year-old gentleman or a young gentleman with a good cartilage, both are same. So you need to give them good life with their knee when they are, involved, when they are involved in sport, when they are active, they want to live by themselves. So we chose a meniscal allograft using semi-T. And we stitched periosteum at the ends of the meniscus. And this is how it looks once you finish your meniscus autograft. If you see, tunnels are drilled for the meniscus root repair, both in the posterior side for the posterior root and anterior side in front of the anterior flare of the tibia. And you will require many sutures, as Dharmpal was telling, to secure your meniscus. The most important thing is a centralizing suture, which will drag your meniscus into the knee. And that is like the lighthouse, which takes the path for the meniscus to go inside the joint. So this is the 3-month follow-up of our X-ray. If you can see, and if you can want to critically assess what happened to this patient, you will always see that the meniscus will be extruded in the joint. That is quite natural. Extrusion of the meniscus is natural when you are 3 months old. But a longer follow-up, say it is 1 year or 2 years follow-up, will be advisable for anybody to see these kind of patients. However, the patient is doing very well. His range of motion of the knee is good. And subsequent follow-up of these patients will be sharing with you as and when the scientific forum allows us to present. And a humble request for all of you gathered here. I would be contesting for the IAS Vice President elections in the coming year. If you are free about, all the politics that is going around, and if you want a chance for a person to be given other than the state that is already got a representation, kindly choose Dr. Rajkumar as the Vice President of the Indian Arthroscopy Society, and I'll be greatly obliged when you do so. Thank you so much.
Okay. Are you guys there? Can you hear me?
Yeah.
Anand?
Rudra Prasad, yeah, we are very much here.
Can you see the images? Can you see the picture?
Yeah, we can see the picture.
We are just waiting for the graph to go inside. If you say yes, Pratima will shoot. Okay?
Yeah, before I say yes, I would like to thank Dr. Rajkumar for his wonderful, comprehensive talk on the allograft transplant. It was very much in detail. Thank you, Dr. Rajkumar. Yes, Rudra Prasad, please go ahead.
I was just telling you that there are ways of confirming whether the button is flipped on the cortex or not. One is the marking. The marking, when we put it, it was here. And so we slightly started pulling it. It is gone there. So that is one confirmation. Second is when the graft is going inside the feel of the surgeon, when the button just comes out, that is a second confirmation. Third confirmation, of course, you can always see through it when the button is passing through. Fourth is the C-arm picture. And now Pratima can go ahead. Yeah, so that's the marking. We had marked it and the PCL is completely gone in now. And you can see that. So outside picture, please. So I'm almost done. And hold this here, doctor. So when you're fixing the tibial screw on this side, it will be 60 to 90 degree flexion. And one of your assistant has to put his forearm completely below the, behind the proximal tibia and pull it anteriorly and give some more thrust and then fix it. All right? So I'm done. Thank you so much for giving this opportunity. Sharath, I congratulate you and thank you for this opportunity. Thank you very much.
Thank you. Thank you, Rudra. I think you will be hearing the big round of applause from the audience. Thank you very much.
Thanks, Raghu. Everybody. Yeah, thanks.
Thank you, Rudra Prasad, sir. Next, we'll go with the next talk, a demonstration of a meniscal allograft transplant by Dr. Raghunagar.
Any questions regarding the meniscal allograft?
Dharampal is there? Dharampal, we would like you to quote the literature as well as what you think are the long-term results, outcome of the tendon transplant, which you are replacing for the meniscus.
Sir, literature, actually it is little limited, but the principle is, it is just like an ACL. When you put an ACL graft inside, it is going to integrate. Similarly, meniscus, because this has got a good remodeling potential, the tendon. Also, the same kind of technique is also used for labroplasty in the glenoid, in case if you want to build a Bankert labrum, or even in the hip as well.
There are, with the limited availability of literature, and you don't have, you have to do something for the patient, and he has to get rid of the potential to develop arthritis. So I think this was a good idea to go ahead and do a tendon autograft.
Yeah, I agree with you because you have no other option. Because the meniscus, no meniscus is there to act as a shock absorber or a cushioning effect. So, I mean, it will be really difficult to convince the patient, I think, or how do you talk to them? It's a little challenging about the outcomes and convince them for surgery. Especially when you don't have literature support also as far as the long-term outcomes are concerned.
Whatever literature support were available, I shared the same literature to the patient and I gave him both the options. Can we go with allograft, which is a gold standard, what they call, or even with the tendon autograft? Patient was not affordable for the allograft, but he was okay with the autograft. And then he did not wanted this kind of disadvantages associated with the allograft. So we went ahead with the tendon autograft with the proper consent. I told him in case if it fails, it fails.
In your case, the anterior horn of the lateral meniscus was there.
Yes.
Did you trim it? Did you leave it there?
No, I had to debride it completely. Initially, I thought I'll retain it, but it will be difficult because that particular structure don't have a blood supply. As you see, it's only 25% in the periphery. Again, if I suture it to the same area, yes, segmental tendon autograft is described for the mid body, but not towards the anterior. So I thought it will become easier to remove the complete anterior horn.
Rajkumar sir, any inputs regarding autograft versus allograft for meniscus?
I'll congratulate Dhanpal for his talk, because lateral meniscus autograft transplant is not easy and it has got a lot of challenges. If you want to ask, the popliteus hiatus is not created when you transplant, correct? So there are other many mechanics wherein the load bearing of the lateral meniscus is more than the medial meniscus. So there is a limitation of how much you can do with an allo or an autograft. Having said that, a meniscal autograft would be an ideal choice for all the beginners to experiment with. And then you can go for an autograft. The autograft results are limited, as Dharmpal said, but there are papers coming out even with the pressure gauges to show that they can bear the load. They can remold like the normal meniscus, but only if you think, will it be like a fibroelastic cartilage like before? I am sure not. But still it will, improve the lifespan of the knee by, taking the load and trying to maintain the internal milieu of the knee when you all have reconstructed your ACL and taken care of the other instabilities and the alignment part. So in such situations, there is a 50-50 chance how much you can do with an allograft or an autograft. Not everything you can do, but you need to, sit them down and see, this is what we can do for your knee and this is what you will get out of it. Not everything that a patient wants can be given. But yes, there is a way that the allo or the autograft can give you a better outcome. Regarding the allograft, my choice and experience is limited because you are not gone to do that, because the kind of patients we deal are not that great. But as I'm sure the next procedure that I'm going to see by my good friend, Dr. Raghu, you will be able to understand and ask him how the allograft functions. But as far as me and Dharampal are concerned, we can talk to you about autografts, which can be more useful for all the youngsters or all who want to venture into doing that, can have a hand of it and hang of it. Okay.
Grabber, could you grab her?
What have you felt the pain relief, immediate pain relief for these patients?
It is a great question.
Long-term prevention of arthritis is okay, but then the patient has come to us with pain in the knee. And usually if a medial meniscectomy has been done, he's already definitely developed some chondral changes. Yeah, grade 3, grade 4 are contraindications, but at least a grade 2 chondral changes. So will he have good pain relief
shaver.
with this procedure? Because part of the pain is from the chondral lesion as well.
This is just short of match fixing. Anyway, it's a great point that Dr. Chetan has brought out. Now, among the audience, I just will have a poll, if you permit, chair. Yeah? How many of you read your own MRIs? Not the report by the MRI guys. How many of you read your own MRIs? So everybody is reading their own MRIs. So it is great thing. Correct? So what all you look at when you look at a meniscal tear in the MRI? One is type of tear, any associated injury, any other thing you would want to look at? Chondral changes, how it will be depicted on the MRI? There will be signal changes, correct? Those signal changes nowadays are given more importance. When we all started, they used to say it is a bone edema. You can leave it and you can forget about it. Hemant Kalyan sir, nowadays the bone edema has got very important point to be taken into consideration, because if there is a significant bone edema, even in an young individual, they are wanting to decompress that area because the life of that area goes down because you will have subchondral sclerosis. Correct? So that is when it causes more pain. And in gentlemen, where we have done an autograft or allograft, make sure it has minimal amount of that. And the pain relief will happen over a period of time. It is not like you do a meniscal repair at the end of 6 weeks, he'll come to thank you. No. You need to buy your time, need to be patient, need to have a good physio and rehab going on. You need to have a good pain medication and also building of the bone and the bone mass. Okay. So all these things will run into play. It will not happen over a period of time. It will take some time, and then probably you can see the patient. The patient which I showed, he's very happy on his left side, where you have done a hemimeniscal transplant. The side where we have done a full meniscal transplant, he's wanting to buy time. He keeps coming, calling us, saying that he has pain at the end of 3 months also. Now he's 4.5 months down the line. He's still little unhappy about the right knee. Left knee is perfect. His knee is moving well. He's load bearing. He's going to school and teaching to the students whom he is already teaching before. So that's how it is.
I will try and put a relook arthroscopy sometime in 1 year of the same patient.
You plan to do a relook arthroscopy?
I have told him. Before I told him, I gave him the option. If he has to get into sports, I need to look at your meniscus. Thank you.
Thank you, sir. Thank you for all the insights regarding the meniscal reconstruction. So I would like to thank Dr. Niranjan sir and Dr. Chetan Nagraj sir. I would like to call Dr. Rajkumar Amravati sir on stage to chair the last demonstration. So we'll be going ahead with the demonstration of the meniscal allograft transplant.
Dr. Raghu, you are able to hear us?
Good evening. Can you hear me?
Yeah, we can hear you loud and clear.
Oh, thank you. I thank and congratulate Dr. Sharath for giving me this opportunity to demonstrate this medial meniscus allograft transplant. And also congratulate Dr. Rajkumar for giving that wonderful elaborative talk, which I think must have woken up most of the delegates, I guess, from the sleep. The soft tissue allograft, because we did not have the allograft from the proper bone bank. So we have arranged a medial meniscus soft tissue allograft from one of our TKR patient. I've already prepared the graft. I'll be showing you the graft soon, but now I'm showing you the inside part of this knee. Okay, I'm going to trim the meniscus because that's the initial preparation. You need to trim the meniscus and leave around 1 or 2 peripheral margin of the meniscus intact. That is a mandatory for most of the meniscus transplant because that's rim will prevent the subluxation or meniscus extrusion over a period of time. So keeping 1 or 2 mm medial meniscus rim is very important. So I'm going to taking off this most of the native meniscus now to demonstrate the allograft transplant. So I'm just going to clean it up first. Then probably I'll be starting with the procedure soon. So since there is already multiple procedures that has been done on this cadaver, like already medial meniscus root repair has been done, PCL has been done. So I just hope I don't get to have a difficulty in preparing the root and roots for both the medial and for the posterior and the anterior roots. So I'm going to clean up all these things. Section work ಆಗ್ತದಾ? Okay. Okay, yeah. Clean up the shaver blade, please, and give me a meniscus punch. And it's very important to do a MCL pike resting to get the space opened up. Because medial meniscus transplant, you need a good space to perform this procedure. You can't be struggling with passing the instrument. So you need to open up the space thoroughly so that your graft goes inside and you don't end up struggling with this. Okay, so I'm going to shift my scope so that I can pass my meniscus punch from the other portal and remove that middle third and the anterior part of the native meniscus intact. Meniscus punch, please. Okay. So meanwhile, if you have any questions, you can clean it up.
Hi, Raghu.
Oh, hello, sir. Good evening. Sir, it's a
Good
wonderful
evening.
talk.
Good evening. Thank you so much.
It was very elaborative
Everybody,
and detailed.
Yes. Now, if you are looking at this young knee that you are doing a meniscal transplant.
Yes, sir.
Correct?
Yes.
So in your hands,
Assuming so, yeah.
You have traveled that path ahead of all of us.
Yes.
What would be your ideal conditions and ideal intra-op decision makings when you look at the knee and say that this is the knee I will transplant or this is the knee I will do something else?
So ideally, the patient should be between the age group of 20 to 45 to 50. That's the ideal age group. And they should have undergone a subtotal or a total meniscectomy in the past. And they should be having symptoms related to the particular compartment. Suppose if they've undergone medial meniscectomy, they should be having medial pain, medial joint pain. And also, there should be some demonstrable cartilage changes in the MRI. So, and that has to be a grade 1 or a grade 2, like outer bridge classification, if you have to consider. So there has to be some demonstrable cartilage changes. So that means we can conclude that because of the meniscectomy is undergoing medial compartment increased peak pressure, and that is giving him the symptoms. So those are all the ideal candidates. And coming to the alignment and the ligament instability, yes, the alignment should be reasonably good. Or if I can say correctable alignment, if you can do an osteotomy and if you can correct the alignment, yes, they are still the ideal candidates to do the meniscus transplant, if you can correct the alignment. An extreme gross alignment, yes, you cannot do this procedure. And coming to the ligament stability, again, is the same thing. If you can correct the ligament instability along with the meniscus transplant, yes, they're also ideal candidate for it. And coming to the cartilage damages, if they have damages which is more like a grade 3 or grade 4, and if they are focal, and if you can be able to treat it like either with the ORTS or with the help of any other cartilage procedures, you can still consider meniscus transplant in them.
Thank you, Raghu, for that elaborate answer. But if I give you a hypothetical situation,
okay,
of all that indications and contraindications that you're talking,
yes,
which is the one most that you would want to choose while you're doing your cartilage transplant, or sorry, meniscal transplant, or you will apply importance more to age?
Sorry, sir, I missed that part. Can you ask once again, please?
Age will give more importance, or to what you see inside you will give more importance?
No, age is not the paramount importance, but yes, what we see inside is very important. Yes, was there any demonstrable cartilage damages, or able to see that increased pressure in that particular compartment? That's more important. If they are physiologically young, if their joint is very good, and if you can give them a active, a native knee, and they want to continue with their active lifestyle, yes, they are still a candidate for the procedure.
I like that word, physiologically young.
Yes, sir.
Yeah.
Raghu, I have a practical question for you.
Yes, sir. Please go ahead. Yeah.
The patient has come to you.
Yes, sir.
His discharge summary saying that he underwent subtotal meniscectomy or partial meniscectomy.
Okay. Yes.
And you have the MRI images latest. Would you depend on these clinical and radiological, or would you like to have a relook there and then decide whether the patient needs a meniscal transplant?
Relook in the sense you want to perform an orthoscopy and then take a decision whether they are candidate for transplant, is it?
Correct, exactly. That's what I would.
No, sir, that would be little, because see, now the science has evolved and we have a definite indications and contraindications set, guidelines have been set now. So you just, but yes, choosing an ideal patient is important, but there are various ways to do it. Like I said, clinical thing. If they have a good demonstrable symptoms, if they are symptomatic for a couple of months or years and a failed conservative treatment after this. So yes, and with the demonstrable imaging changes, yes, we can go ahead with the transplant. But provided there is a good detailed counseling between you and the patient, because this meniscus transplant is the new kid in the block, and not many people are aware of about the consequences of it, how the it's going to take, what are the results of it, what are the pros and cons of it, meniscus punch. And so they should be knowing in detail, straight punch, in detail, what are the, what are they, if they're decided to go ahead to the surgery, what they're heading to, they should be fully aware of it. Yeah, if we can do it, and I think we can go it with the procedure directly rather than doing an orthoscopy and then taking it, because now we may just give a detailed details, the complete details, what's actually going on in the knee. I hope I'm clear.
Yeah, you are you are clear, of course, but I had my doubts.
Oh,
because
sure, sir.
many times the images do not correspond with what we see inside.
Okay.
And many times the cartilage damage is more seen on having a look inside rather than on the MRI. And maybe
but if they have so much of doubt that whether they have a cartilage there too, either it's a too extensive cartilage damage, or if they don't have any cartilage damage, then I would suggest that they are not ideal candidate at all. Then you better rather wait. Or maybe you can look into the orthoscopy and then see. Yeah.
I was just wondering, because you are going to order for a very expensive implant.
Yes, yes, exactly. So they are not the ideal candidate. If you have a doubt on their clinical scenario, then yes, they are not ideal candidate. So yes, I'm going to do a MCL pie crusting now to open up the space. So what my technique is, I always prefer to do from outside in with a 16 to 18 gauge needle. And I prefer to come inside the meniscus rim so that it can act like a pie crusting also and get some blood channels into the meniscus remnant. So this same thing can be done from inside also using the same spinal needle. So you have to do multiple trephination. And you can also use a diamond rasp after this to create the biology. So creating this biology is very important in the meniscus transplant, as you're going to reconstruct the whole thing. So once I'm prepared with the bed, then I'll show the graft and then we'll proceed with the root tunnels. All right. Come back into this, come back. And now you give valgus. Suhas, now you give valgus. So with me is my team. Dr. Suhas is an associate consultant with me, and my fellow Dr. Mandeep Reddy is from Andhra Pradesh. And my scrub nurse, Mr. Govardhan. So yeah, you can see the space is opened up nicely. You can see clearly and the roots are visible. Now we can go ahead with the tunnels. But before that, I will show the graft first. Come back. Okay. Can I have the outside in picture, please? Yeah. Can you see this? Can you zoom it a little bit? So for the benefit of delegate, I'd like to tell you how to process it. Suppose when you generally, fresh frozen allograft is the one that is most commonly used. So when you get it from the blood bank with the freezer, you have to take it off. And my suggestion is when the anesthetists start inducing your case, take off your graft and you have to start the thawing process because that will take around 20 minutes to 30 minutes procedure. So you need to take the graft from the ice cubes and put it in a warm saline of 36 degrees centigrade with a vancomycin in it. So leave it for 15 to 20 minutes. Then slowly the graft will get softened and then you can start the preparation. So this is how the preparation is. So you have to mark the graft beforehand. So P is for the posterior, T is for top, and A is for anterior. Because once the graft...
Raghu.
Yes, sir, please.
If you can lay it on the table next to you, then ask the guy to focus on it.
Yes.
It will be easy for you to explain.
Yeah, can
because
please.
you will have a lot of clutter behind what you're telling. Yeah.
Can you see now, sir, clearly?
Better.
Yes. So this is our medial meniscus. We were fortunate enough to get a very nice meniscus graft. So this is the posterior part. So we have marked P, if you can see that. And this is the T for top. Because once the meniscus slips inside, you'll get confused because sometimes the graft may get twisted. So then you'll have a confusion. So these markings will clear that confusion. So P is for posterior, T is for top, and A is for anterior. So generally, this is an all soft tissue plug. Instead of the bone plug, we have prepared this soft tissue plug. So if you can see, we have prepared this posterior root with the fiber tape. That it can go with any pattern of stitches like a Chinese strap or bundle stitch. I generally go with the way that I prepare my hamstrings graft. So this is a crisscross stitch with the fiber tape, and you have to make sure that both ends of the fiber tape exits from the inferior surface of the plug. That's important. It shouldn't be exiting from the superior surface. So that this can take this plug into the tunnel. And there is one more fiber stitch at the junction of the posterior third and the middle third. This is important because when you're passing the graft, so both this fiber stitch and this posterior stitch will be pulled so that they can go in an anatomical position. If we don't put this stitch, then only the root will go and this part may get stuck outside. So preferably we put this in the pull-out stitches beforehand before passing the graft. And similarly, we have prepared this anterior plug also with a similar crisscross. Can you show me again the sizer, please? I'll show you the size of this bone, the soft tissue plug. Yeah. So this is coming approximately around 8 mm. Let me check with the 7.5 first. 7.5 is also going, but it's a little tight. But since
your hand is blocking, Raghu.
Yes. Yeah. Can you see me, sir? Can you show now?
Yes.
Can you see now clearly? So
yes.
This is how we are checking the size of the soft tissue plug. So 7.5 is going clearly, but since we are going to use a flip cutter and that comes with either 7 or 8, so I'm going to choose the 8 mm flip cutter for the posterior one. For the anterior one, let me check with the 6. So 6 is a little tight. Yeah, 6.5 is good. So preferably our posterior plug, like at least 7 to 10 mm, I would say that should be your plug which will go inside the tunnel on either side. So any doubt, any questions regarding the graft preparation?
No, it is great that you have kept a differential way of doing the posterior root as well as the anterior root.
Yeah,
probably that will match to your anatomical thing. Now
Yes,
your
sir.
planned suture fixation is all through the meniscus, or you want to leave some part of the meniscus not fixed?
No, before the passing the graft, is it?
No, inside.
Inside, no, sir. I'm going to fix it completely. I will show you that. Posterior part will be using an all inside